Hello? Hello? Good afternoon. वक्रतुंड महाकाय कोटि सूर्य समप्रभ निर्विघ्नं कुरु मे देवं सर्वकार्येषु सर्वदा. On behalf of RSSDI, we welcome all of you on Diabetica 2022. As we all know, like glycemic variation, blood pressure variation also plays a great role in the complication of diabetes and hypertension along with it. So, whether it is a beat-to-beat variation or short-term or long-term variation, we had an eminent speaker, Dr. Narsingh Verma. I invite Dr. Narsingh Verma to deliver his lecture on diabetes and hypertension, a role of ambulatory blood pressure monitoring and home blood pressure monitoring in the management. Dr. Narsingh Verma is a professor and head of Department of Physiology, officiating head Department of Family Medicine, former head of Department of Transfusion Medicine, Dean Student Welfare KGM Knoxno. His area of interest is chronobiology and metabolic disease. He has more than 225 publications. He received 14 international awards and 38 national awards in the field of cardiovascular and metabolic research.
Thank you, sir. Sir, I snap, sir. Thank you.
Without wasting much time, we will start lecture.
Okay. So, thank you, Chairperson, for introducing me. And first of all, I would like to thank RSSDI Gujarat chapter for giving me this opportunity to talk about the topic on which I have some my original research as well. And I would like to thank Bansi Bhai, Pratap Bhai to invite me for this conference. And I will be talking about diabetes and hypertension, the role of ambulatory blood pressure monitoring and home blood pressure monitoring in diagnosis as well as in management. So the topic is vast, but I have limited time. So I will rush through two silent epidemics. We know that hypertension and diabetics are these two silent epidemics. They are rising day by day. And if you compare the prevalence, then hypertension is most prevalent disease in Southeast Asia. In India, the prevalence is around 35 to 38%. In Pakistan, it is 52%. 52%. How common are the hypertension and diabetes? Hypertension is twice as common in diabetes as diabetes mellitus, and new onset diabetes is 2.5 times in hypertension, and 20 to 40% of patients with impaired glucose tolerance have hypertension. 40 to 50% of type 2 diabetes mellitus patients have hypertension, and only 1/4 of hypertension in diabetes mellitus is controlled. So a lot of uncontrolled. In India, it has been found that only 12% of the hypertension population is having good control. So diabetes mellitus, hypertension, they both, when they combine, they increase the cardiovascular risk by threefold. So that is why this becomes important. And causes why hypertension develops in diabetes, basically it is basically because of the insulin resistance, endothelial dysfunction and high glucose values. When they all combine, it causes the hypertension in diabetes. Excessive RAS activity has been found, that is the main mechanism involved. Because of increased RAS mechanism, the hypertension develops. That is why probably the drug of choice for hypertension and diabetes is RAS inhibitors. The renal scarring is recurrent pyelonephritis is one problem which has been found. Endocrine causes causes for both hypertension and diabetes are there, and they are not very rare, and we encounter them. Coincidental diabetes and existing hypertension, it has also been reported, like diabetogenic antihypertensive drugs may be responsible, because we know that these two group of drugs have been abused to diabetes, that they can further increase the complications, and drug causing hypertension, diabetes, like the oral contraceptive pills and cyclosporins and the similar type of drugs, they can cause both diseases. So the hypertension and diabetes, and both are there, that increases risk, severe risk especially, by threefold, which I talked about, and hypertension is associated with 57% increase in all-cause mortality in diabetic individuals. When in diagnosis, the blood pressure when more than 130/80 millimeter of mercury, then we, especially in diabetic population, then we will call it hypertension. Confirmed by, on a second occasion, in either the office, if we are using office measurement, then we have to use repeated measurements, then only we can say it is hypertension. The single measurement has no use. And if we are using home monitoring, then at least 7-day monitoring is required, both 2 readings in the morning, 2 readings in the evening. And if we are using ABPM, then at least 48 hours ABPM is required, 24 hours may not be enough. More frequent monitoring by home monitoring or ABPM can be done, and that is helpful in making the diagnosis. And initially, if we are using the office one, then initially both arms should be taken, and if the difference in the both arm, interarm difference is more than 10 millimeter mercury, it is further increasing the severe risk. And especially in diabetic population, we have to take blood pressure in both supine and standing position. The therapeutic goal in diabetes and hypertension, when both are there, then the goals are the blood pressure systolic should be less than 130 and diastolic should be less than 80. And these goals are not different from the other goals which we usually use. Hypertension, optimal treatment, BP control reduces the CV event, that we know if we control hypertension, then the CV events are definitely going to down, and because of that we want to reduce the systolic as well as diastolic blood pressure. But the problem is that most of the time blood pressure is uncontrolled in most of the diabetic population. It is difficult to control. We all know that, and proportion of treated diabetic patients with controlled and uncontrolled blood pressure is shown here. You see 85% of the patient, even more than that, do not have the control of blood pressure. The blood pressure is more than 140/90, and even the 15% of individuals have blood pressure less than 140/90, but the goal is less than 130/80, which is very, very less population can achieve it, only 3%. So the achieving goal is very, very difficult job. Sometimes we use 1 drug, 2 drug, 3 drug, 4 drug, and sometimes using even the 4 or 5 drugs. What are the difficulties of hypertension and diabetes? The systolic hypertension is more common in diabetes. Systolic is a stronger predictor of cardiovascular event, and 65% of type 2 diabetes patients have systolic hypertension, and it is more difficult to control. And depression is also more common in diabetes, and because of that the adherence to treatment goes down, because of the depression patient is not compliant. And clinical inertia is also a big problem, because physicians are not escalating the drugs and increasing doses of the drugs to manage hypertension. Most of the time the decision is taken very late. Clinic measurement is not enough. If one is doing clinic measurement, he or she may not be able to diagnose blood pressure properly, hypertension properly, and basically in the ambulatory BP levels have been shown to be better than clinic BP in predicting cardiovascular events. A riser pattern has been associated with increased risk of cardiovascular disease. That is why we had to know the riser pattern. And white coat hypertension and mask hypertension in diabetes, they are more common and they constitute a moderate risk. That is why we had to know them to diagnose them. A non-dipping pattern is a very common in obese hypertensive patients, and especially if the non-dipping pattern is there, it further increases severe risk even when blood pressure is not increased. So why ambulatory blood pressure should be taken in account? Because high BP variability in diabetes blood pressure variability is more in diabetes mellitus, and increased 24-hour pulse pressure was significantly associated with cardiovascular event in diabetes. Ambulatory BP control was shown to be more closely associated with target organ damage of the brain, heart and kidney than the glycemic control. And most of the physicians are focusing only on glycemic control. They forget about the blood pressure control. That is where mistakes usually we are doing. In diabetics, an abnormal BP rhythm that is of a non-dipper pattern is frequently observed, and because of that we should do ABPM. in type So in circadian rhythm of blood pressure, we should know that when we do ABPM, then we can find out whether the patient is having the dipping pattern or the non-dipping pattern or the reverse dipping pattern, or there can be extreme dipping pattern. So this can only be known by ABPM. This cannot be known by any other methodology. So that is why ABPM is required, and ABPM data are also effective to improve adherence to therapy. And not only that, if ABPM is not possible or every patient cannot be done for ABPM, then another modality can be home blood pressure monitoring, and home blood pressure monitoring offers an attractive alternative to 24-hour ABPM, and several studies have reported that target organ damage and cardiovascular outcomes are more strongly correlated with home blood pressure monitoring than the clinic BP measurement. So home monitoring is better than clinic one, and home BP monitoring provides measurement over a much longer period, cheaper, more widely available, more convenient for patients, particularly for repeated measurements, and has been shown to improve patient compliance with treatment and hypertension control. That is why the home blood pressure monitoring is the alternate choice, and we should adopt that. If we compare both, then unlike ABPM, home BP does not allow the assessment of BP during sleep or at work, and quantification of short-term BP variability is missing. In addition, the recommendation to measure BP at home may induce anxiety that leads to excessive measurement and treatment changes made on the basis of erroneous measurement. That's what we face the problem in Indian patients, especially. If you allow them home monitoring, then they will have only one work, keep on measuring blood pressure every half hourly, and then troubling you, doc, my blood pressure has shooted, it has gone to 200, now it is only 100, like this. Reproducibility is high in ABPM. That is why the ABPM is gold standard, and but both ABPM and home monitoring have impact on the compliance. A recent meta-analysis showed that home monitoring and clinic BP measurement have insufficient sensitivity and specificity compared with 24-hour ABPM. That is why it is called as gold standard. Home monitoring should be used in conjunction with ABPM as a complementary method of BP assessment, but the acute blood pressure variability will be missing in home monitoring. When there is a coordinates between the methods, home blood pressure monitoring may be appropriate for long-term follow-up of treated hypertension patients. So the recommendations can be the clinic BP values close to the threshold levels. Then this is because these patients are most likely to have either white coat hypertension, or they can be having the mask hypertension. So they had to be subjected to ABPM. The home monitoring may be an easier, cheaper and equally effective way to determine the true status of patient BP under daily life conditions. When home BP monitoring is not feasible or the results are not easy to interpret, then we have to go for ABPM. Subjects in whom a suspicion of the impressive diagnosis by office BP should be considered are those with signs of organ damage despite apparently normal BP. We should go for ABPM. Diabetic patient being exposed at a very high risk may derive particular benefit by using ABPM and home monitoring. Nocturnal hypertension is attracting a lot of attention today, and we know that the nocturnal hypertension is more related to cardiovascular risk rather than the daytime blood pressure. So by ABPM we will definitely be able to know the nocturnal hypertension, we can diagnose it, and ABPM is the only way to ascertain that BP is adequately controlled all over 24-hour period, not only for few hours. So nocturnal hypertension should be suspected, especially in subjects likely to have obstructive sleep apnea and similar conditions which are warranting to do ABPM. In these cases, some simple measures such as switching to long-acting compounds or adding an evening dose of antihypertensive may be effective. If we by ABPM, we can diagnose them. Episodic changes again can only be diagnosed by the ABPM. So episodic hypertension can again be confirmed by ABPM, and it is related to autonomic dysfunction and other modalities. They can also be diagnosed by ABPM. Also, in such cases, the adjustment of antihypertensive treatment may be required, and that again will be better if we use ABPM. Finally, ABPM may also be useful when identifying patient with episodic BP elevations in the context of enhanced BP variability, increased arterial stiffness, and autonomic neuropathy, because we know in the variability of the chronic variability is because of the arterial stiffness changes. The identification of these phenomena may trigger appropriate changes in treatment strategies, and that will be helpful for long-term management of blood pressure. So the American Diabetes has shown that whether all patients should go for blood pressure monitoring done by ABPM, but that is not possible. So it has been seen that tipping pattern is one pattern which is very important, and we should try to find out whether patient is having dipping pattern or not. That can up to some extent can be known by home monitoring also, but confirmed only by ABPM. And should 24-hour ABPM be done in every patient with diabetes? It is difficult to answer this, but most of the patients require them, and this depends upon the high risk individual may definitely be subjected to ABPM. And if you see the cases per 1000 patient years, then the cardiovascular events, cerebrovascular events, and all events, in all cases, ABPM is helpful, and by doing ABPM, we can definitely diagnose better, treat better, and if we can interpret the data better, then definitely the risk of cardiovascular risk, cerebrovascular risk, and all events can be decreased. To summarize, diabetes and hypertension are interlinked and increase the burden of cardiovascular and cerebrovascular burden. Office measurement most of the time may not be sufficient, and if at all done, it requires repeated measurements at different times. Home monitoring is a better option and can diagnose white coat, mask hypertension, and early detection of cardiovascular and other risks. ABPM is gold standard, and most of the patients, especially high risk, should require the ABPM. Home monitoring and ABPM also increase the compliance and are helpful in adjusting doses and tool for better control. So I would like to end here. Thank you. Thank you very much.
Thank you very much, sir. Is there any questions?
Sir, I have one question.
Yeah.
What typically I have observed after applying ABPM to my patient, that they become over anxious, they become little stressful, and on that basis, I have made changes in the treatment. But in follow-up, I have to reduce that antihypertensive doses over a period of time. That is my first observation. And in EBPM report, 15 minutes ago, the blood pressure is showing, and we have to look 15 minutes later, 15 minutes later, and so forth. But the patients became so anxious that why it's happened. That's the biggest challenge what I faced when I applied ABPM. How to counter that?
Yeah, very good question, I will say. This is just because the most of the ABPM monitors being used in my country, they are not good monitors. Only few companies have good monitors, and ideally ABPM should be done in at least 48 hours. Ideally should be 7 days, not possible, but I have original data of 300 patients of 7-day monitor. Why 7 days? Because first 24 hours there is white coat effect. Patient feels something is there, and because of the anxiety and autonomic nervous system, the blood pressure rises. So ideally should be done for 7 days. Practically not possible. So at least 48 hours. In 48 hours, first 24-hour data you can discard. Use last 24-hour data. Third thing, 15-minute interval is not good. In daytime, it should be 30 minutes, every 30 minutes, and night time, every 1 hour. You adjust your monitor so that in daytime, it takes every 30 minutes, and night time, every 1 hour. So unnecessarily, patient will not be awake, because whenever the cuff applies pressure, the patient will awake. So this is the initial problem in that. Regarding the interpretation, patient is not able to see the data. Only you will be able to see, and you know very well, the sir has already mentioned that blood pressure variability is of different type. Blood pressure varies every 30 seconds. Every 30, because the baroreceptor activity goes maximum in 30 seconds. And baroreceptor mechanism is the most important mechanism to have these acute changes in blood pressure. So it is possible to have blood pressure different in 15 minutes. Very well possible. I give one example that in my university, 15 years back, there was no audio visual things available, and we used to shout and compete with the noisy fans. And that time, my own blood pressure was shooting to 180 by 110, but I'm not hypertensive. That is called an episodic hypertension. Because of certain episode, blood pressure rises. So that is possible. Interpreting the ABPM data is a difficult task.
Regarding in management, most of the times we prescribe many drugs together for diabetes and hypertension, diuretic, antihypertension, sometimes ARNI, and now SGLT2 inhibitors. What would be your comment on this, whether this patient should be undergone for orthostatic hypotension, or what to adjust? Lot of in armature, lot of drugs, and when the patient is having both disease, diabetes and hypertension, the prescription is also longer.
Yeah. Actually, orthostatic hypertension usually found in those patients who have autonomic dysfunction, severe autonomic dysfunction. But in other patients, usually we do not have that. And the drugs like ARNI or other ARBs, they do not produce orthostatic hypertension. The other drugs which are vasodilatory in nature, they can produce that. We are facing the different problem, that it is difficult to control blood pressure in diabetic individuals. Sometimes we use 2 drugs, 3 drugs, 4 drugs to control it. But the basic problem is that we are using 2 drugs, 3 drugs. Ideally, most of the drugs should be given in the evening and 1 drug should be given in the morning. If you are using 3 drugs, that will help and will not develop these type of problems which you are saying.
No, no, it's just. Any question? Yeah. Any question? Yeah.
Yeah. Probably you are talking about isolated systolic hypertension. For isolated systolic hypertension, the drug should be different. They have most effect on the systolic one, less effect on the diastolic one, like the indapamide, like the CCBs. So they have more impact on systolic hypertension. Yeah.
Now we develop benign prostatic hypertrophy. We take and incidentally once a while in 15 days he goes the
Postural hypertension. Yeah.
before they take blood pressure of 140 by 80 has to be changed.
2 things can be done. First, we have to investigate patient by doing detailed autonomic functions. These patients may have autonomic dysfunction. Number 1. Number 2, in drugs, the alpha blockers should be given late in night before going to bed. That will help. Thank you, sir.
Okay, sir. Thank you very much. Give him a big round of applause as he has started our game. Actually, he's an opening batsman, and we know how it is difficult and courageous to speak first in the conference. Thank you very much, sir.
Now, hello. Now we'll start our second session. second topic, I invite Dr. Rakesh Sahi. He is a MD/DM, Professor in Health Department of Endocrinology, Onspane Medical College Hospital, recipients of many awards, and he has more than 150 publications. He will deliver his talk on diabetes and thyroid disorders.
Thank you, sir. Thank you to the chairpersons. And at the outset, I would like to thank Dr. Bansi Sabu and Dr. Pratap Jetwani for inviting me to be here on this important meeting of the Gujarat RSSDI. And I would be speaking about thyroid disorders and diabetes. So we have a RSSDI came out with the guidelines and recently, and that was So I would be quickly discussing about I will give you an overview about thyroid disorders and diabetes. We just heard about, we heard a very elegant talk by Dr. Narsingh Verma, who spoke about the twin epidemic of diabetes and hypertension. Similarly, what I would say is that thyroid disorders are also equally prevalent. Not as much as hypertension. Hypertension is about 35%, as he said. We could say that thyroid disorders are on the about 10% prevalence of thyroid disorders. And so what we see is that both diabetes and thyroid disorders are common problems. Are they just coexisting just because they are common? Both of them are common. We could have a coexistence of these problems, or is there something more to it? So that is what I'll be discussing now, and showing you some of the links between diabetes and thyroid dysfunction, how they influence each other, and also then I'll be discussing about what should be our strategy for screening for these thyroid disorders. Do we need to screen all individuals, or do we need to understand who needs to be screened amongst the patients with diabetes? So that is what I'll be trying to cover in the next 10 to 15 minutes. So what I would say is that if you look at thyroid dysfunction, it leads to increase in insulin resistance, whether you look at hyperthyroidism or even hypothyroidism, both of them through different mechanisms. Both of them actually, it's a paradox that hypothyroidism leads to increase in insulin resistance, and when you see hyperthyroidism, you would expect that the insulin resistance should come down, but due to different mechanisms, to other mechanisms, it also leads to an increase in insulin resistance, and so insulin resistance becomes a natural consequence of thyroid dysfunction. And I'll not go into details of that. And one more important overlap between the two is this AMP kinase. AMP kinase, as we know, is a pathway through which metformin works. Metformin acts by activating the AMP kinase, and thyroid dysfunction, also thyroid hormones also have an important regulatory action on AMP kinase. Just not to complicate the whole issue, what I would like to say is that the action on AMP kinase is a little intriguing, in the sense that in the central nervous system, that is in the brain, the thyroid hormones have a effect of stimulating the AMP kinase activity, while in the periphery they actually reduce the AMP kinase activity. So that way, what is happening is that because of this, we see that metformin, by increasing the AMP kinase activity, actually causes a little decrease in TSH levels. So that is one important observation that has been made in several studies in the recent few years, where this has been shown in different studies, and that has been an aspect of debate for some time. But just to summarize what happens in hyper and hypothyroidism, both of them, as I said, have significant influences on glucose metabolism. Hypothyroidism through mechanisms of slowing glucose absorption from the GI tract, retarding the glucose assimilation periphery, reducing the liver glucose output, and reducing the reduced ratio of insulin synthesis versus the glucose disposal, has effects of decreasing the glucose utilization, that is increasing the insulin resistance in effect. On the other side also, hyperthyroidism also through other mechanisms causes increase in insulin resistance. So my focus today is more on hypothyroidism, because it's a more common problem, and this is what we have discussed more in the guidelines. The hyperthyroidism is a relatively less common problem. We could say that less than 1% of the population is affected, whereas hypothyroidism about 10% of the population is affected. So what this again summarizes the effect of hypothyroidism on glucose homeostasis. It works by reducing the hepatic glucose output and also leading to post absorptive increase in glucose levels, and there is decreased activity of the GLUT4 at the level of the muscle, thereby interfering with the glucose metabolism. Now, apart from the effects that we have seen, there are other effects which are also happening in patients with hypothyroidism. Again, as I said, insulin resistance is increased because of through effects on the major adipokines, which again lead to increased insulin resistance, reduction in glucose disposal, and marked increase in free fatty acid levels. Circulating ghrelin levels are inversely related to T3, independent of the fasting and other forms of stimulation of the ghrelin. So ghrelin is another factor that is released from the stomach, modulates the insulin sensitivity, and has effects on islet cell proliferation and survival. So through all these mechanisms, as we're clearly seeing that thyroid dysfunction has a significant impact on glucose metabolism. Now, if you look at the prevalence of thyroid disorders in countries like the UK and US, they have data from studies like the Enhanced database, which has shown about prevalence of hypothyroidism to the tune of about just 2-3% only overall population. With diabetics, they said that it's almost about 5%. In Colorado study also, the prevalence of hypothyroidism amongst diabetic patients is higher. And what we also see is that there is an increased risk of autoimmune thyroiditis in patients who are GAD antibody positive amongst our patients with diabetes. Whether it is type 1 diabetes, obviously they have very high prevalence of thyroid dysfunction, thyroid autoimmunity, and even amongst the the presumed type 2 diabetics who are, we could say part of LADA or the lean type 2 diabetes that we may call them as. So they also tend to have a greater degree of thyroid autoimmunity. And so this can also have impact on the manifestations of diabetes also. I'll just discuss that. This is an interesting paper from a study from Dr. Talwarkar, who has shown that when diabetes amongst diabetics, he said that the prevalence of he has found the prevalence of hypothyroidism to be 24%, and amongst diabetics with hypertension he found it to be about 30%. So this is what is data from our country, and while we are saying that in the general population it's about 10%, it is clearly about double the prevalence that you're seeing in patients with diabetes. And this is again interesting data from Kerala, Dr. Jabbar's group and Dr. Jay Kumar. So what they have shown is that they have again looked at prevalence of hypothyroidism amongst patients with diabetes, and what they found was that although the prevalence rate is higher, but they have identified that those diabetics with hypertension, those with dyslipidemia, and those with anemia, these are the groups of people who are likely to have higher prevalence of hypothyroidism as compared to the entire group of patients with diabetes. So therefore, this is important point to understand that we may have to selectively screen such individuals for hypothyroidism. Then another important thing that was noted from a similar study was that the thyroid, those requiring insulin, those who were on insulin had higher higher prevalence rates of hypothyroidism as compared to those who were not on insulin. And another study from the Gulf, which again they showed that those with family history of thyroid disease, females amongst the diabetic patients, and those with duration of diabetes more than 10 years, they are more likely to have thyroid dysfunction as compared to the entire population of diabetics. So probably these are some of the messages that we get from various studies, that apart from type 1 diabetes, which we clearly know that they have because it's an autoimmune disease, and thyroid autoimmunity is very likely to be present in patients with type 1 diabetes, we need to screen them frequently, keep that in mind. And even amongst type 2 diabetes, these are what we have seen. And some of the other relationships are that there could be altered deiodinase activity, which is in patients with diabetes, which can also be contributing to thyroid dysfunction, and all the other aspects that we have looked at. Now, people with type 1 diabetes with thyroid autoimmunity is very common. That is a known fact, I will not be discussing more about that. But what I'm quickly going to look at is some aspects about how the hypothyroidism affects the complications of diabetes. So there is increased risk of nephropathy in patients with diabetes who have got subclinical hypothyroidism. Those who have got overt hypothyroidism also, they tend to have higher frequency of complications. If you look at the microvascular complications, they tend to have higher, and treating hypothyroidism has been shown to improve the renal function in diabetics. This is one small study from Allahabad from Dr. Sarita Bajaj group, who have shown that there is a increase in that, and there are other studies across the world also who have shown that treating hypothyroidism in patients with renal dysfunction improves the renal functions. And diabetic patients with subclinical hypothyroidism have more severe euthyroid retinopathy. Have retinopathy more frequently amongst patients who have got subclinical hypothyroidism, and also the frequency of hypoglycemic events probably is more in these patients. CVD risk is again another important factor, because we know that thyroid dysfunction contributes to CV risk, and that is again increased with patients with overt and subclinical hypothyroidism. There is data on this is again a data set of 813 3 patients with type 2 diabetes without cardiovascular disease at baseline, and what they found with that TSH levels even within the reference range had a positive association with the CHD events, but they did not have an association with new onset AF or all cause mortality. So and even subclinical hypothyroidism has a significant impact. Not only overt hypothyroidism, we are looking at subclinical hypothyroidism also. They are associated with increase in insulin resistance, increased risk of cardiovascular events, and increased risk of diabetic nephropathy. Does the presence of diabetes, does it influence the progression from subclinical to overt hypothyroidism? That is something which has been debated, but different studies have given different perspectives to that. One of the studies said that yes, they have higher prevalence of progression, but the other studies have not shown similar data. So that is something which is not clarified. Now let us look at what the guidelines are saying, and then we'll quickly look at what RSSD guidelines are saying on thyroid dysfunction amongst patients with diabetes. So if you look at the British Thyroid Association about type 1 diabetes, so this is again about type 1 diabetes. Type 1 diabetes, there is a lot of clarity, because all the guidelines clearly recommend that people with children with type 1 or adults or adolescents with type 1 diabetes should have thyroid antibody, thyroid TSH and thyroid antibody at diagnosis and every year thereafter. That is what the British Thyroid Association says. Even the American Thyroid Association says the same thing. The American Diabetes Association also says similar guidelines. But all in all, what we are saying is that type 1 diabetes, they should be screened for thyroid dysfunction, preferably annually, and also look at thyroid antibody levels initially and whenever you have a concern about that. Now if you look at ISPE, that is the Indian Society for Pediatric and Adolescent Diabetes, and also the what they have said is that screening for thyroid disorders must be initiated at 10 years of age or at the beginning of puberty, and at every 2 years. With additional risk factors such as obesity or family history of thyroid disorders, you should do more frequent screening. Now, if you look at type 2 diabetes, however, there is a lot of variability in what different guidelines are saying, because type 1 it was very uniform, but type 2 there is a lot of variability. British Thyroid Association says you should screen at diagnosis of type 2 diabetes along with regular screening in patients with subclinical hypothyroidism. The American Diabetes Association says that you should only look at those with thyroid which is enlarged, that is palpable. There you need to do or do TSH in adults who are more than 50 years of age and or patients with dyslipidemia. So by and large, what we are saying is that all the guidelines regarding type 2 diabetes do not recommend uniform screening of all individuals with type 2 diabetes. They have looked at presence of goiter, presence of older people, presence of dyslipidemia. So different guidelines have used these criteria to say that you could screen such people for thyroid dysfunction. And so then I'll come on to what our guidelines saying. So we have come out with the RSSJ guideline. Bansi is here with us, so what is the guideline saying? That we are saying that screening should be done for those with additional risk factors. Screening is recommended. TSH screening is recommended every 5 years, and particularly those with anti-TPO positivity, we should screen them every 5 years. For patients with uncontrolled diabetes, presence of other comorbidities like hypertension, dyslipidemia, and existing complications like neuropathy, nephropathy, or microvascular disease may necessitate the need for screening for thyroid dysfunction. And patients above 65 years, especially women, it is recommended to screen them for thyroid dysfunction. So there's a grade A recommendation for for screening such group of individuals, and also looking at the starting dose of levothyroxine. 1.6 microgram per kg is a suitable dose for starting thyroxine treatment. And we have also highlighted about metformin use, that we don't have to be worried about metformin. As we said, there's these studies which have shown that metformin can reduce the TSH levels, and we are saying that it can be safely prescribed in diabetes with thyroid dysfunction, and regular monitoring of thyroid function may be recommended in those who are on thyroxine and metformin. That is about these two aspects. Then grade B recommendation on on early insulin. I mean, on those on insulin, we need to have them also in the list of people who should be screened, and we should think of starting insulin early in those who have thyroid dysfunction and diabetes. The other aspect that we have spoken about is subclinical hypothyroidism. We said that those with subclinical hypothyroidism, as you can see this, I'm not very sure if the slide is visible at the back, but what we have highlighted in this is that those who have subclinical hyperthyroidism, it is the elderly people, those who have got persistent those who have got AF, or those who have got cardiovascular risk factors, or have osteoporosis or risk factors for osteoporosis. They are the ones who need to be treated with when the TSH has been 0.1 to 4. With the lower TSH, then appropriate treatment is required in most of the individuals. While subclinical hypothyroidism, it is to be treated in younger people, those who have got CV risk factors. Their younger people have to be treated. Older people probably would defer treatment in such patients, or not use treatment unless their TSH level is more than 10. So that is about the subclinical thyroid disorders. And I think with that, I would like to say that I would like to conclude saying that our these guidelines have mostly spoken about looking at thyroid, diabetics with comorbidities, diabetics with dyslipidemia, with hypertension, older diabetics. These are the ones who need to be screened and appropriately treated. Thank you all. Thank you all for the patience.
Thank you very much, sir. Any questions from audience? I have one question.
Yeah, please.
Once we start with 1.6 milligram per kilogram body weight, once we detect TSH is higher, is it because most of the times diabetic and hypothyroidism patient, most of the time they have some coronary problems associated with it. If we start with higher dose, will it end up with some problems?
Yeah. So basically, what we are saying is that all the younger individuals can be started at the full dose that is required, while older individuals, those with subclinical hypothyroidism, can be started with a smaller dose, and that can be applied. So that is the and particularly those who have got pre-existing cardiovascular disease.
Sir,
Yes.
what is the label you suggest that it should be treated as a subclinical hyperthyroidism?
As I was mentioning, it's a sort of a mirror image of that. So while we are concerned about subclinical hypothyroidism in younger individuals, we are concerned about subclinical hyperthyroidism in older people, because they are the ones who have cardiovascular morbidity because of even subclinical hyperthyroidism. They can have atrial fibrillation, they can go into osteoporosis because of this. So in those older individuals, we may require treatment, but in younger people, subclinical hyperthyroidism, we are not very much concerned.
Is it very positive and negative? Even with this data, favoring developing this coronary artery movement data, something like that. Why don't we treat this patient even though it is less than 10?
Yeah, so what we are saying is that when we are looking at any of these this data, while we have data saying that okay, while we could I could give a comparison saying that we know that HDL is very important. Low HDL is a important risk factor, but treating HDL is not showing the improvement. Rather, we have to correct the entire dyslipidemia and rather focus on other aspects rather than treat HDL only. Similarly, we could say that if just because we find data that there is a increase in cardiovascular morbidity with increasing TSH, it doesn't mean that everybody needs treatment. We should have a clear benefit of improvement, then only we can do that. So that's why what is seen is that benefit is certainly seen in those individuals who are having a TSH more than 10, or in the other subgroups, those who have got significant dyslipidemia, those who have got severe antibody, significant and high antibody levels, there we treat. Otherwise, we don't treat.
If we just keep on observing the on annual or quarterly TSH value, and the patient develop full-fledged hypothyroidism maybe in 3 or 4 years.
Yes, yes. So that's what I'm saying.
These patients very early.
Yeah. So that's what I said, that if you have a patient with between 5 to 10 with the high antibody levels, then you start treatment. But if otherwise you don't start treating everybody.
No. Thank you very much, sir.
Thank you.
So very nice coverage. And we are happy to have our own guidelines. So we congratulate Dr. Bansi Sabubhai and his team to have they came out with our own guidelines, RSSDI guidelines. Thank you very much, sir.
Thank you. I request Dr. Parikshit to present the memento to our speaker.
So with this, we are moving ahead with the intermittent fasting, and I think so. We all have taken lunch, so it's time for intermittent fasting. So we have a eminent speaker, Dr. Kavita Gupta ma'am, who is a director, head department, dietetics and therapeutic diabetes educations, Sunil Diabetes Care and Research Center, Private Limited, Nagpur. And in this August gathering, everybody is knowing her, and she is a Joint Secretary Association of Diabetes Educator with a lot many more awards. But with the recent data we have, which point out that calorie restriction is more favorable than the intermittent fasting. So for that matter, it will be interesting to listen you. Over to you, ma'am.
Yes. So thank you, chairpersons. And at the outset, thank you, Dr. Banshi Sabu sir, and thank you, Pratap Jetwani, and the entire team of RSSDI Gujarat chapter for having me over here. And let me talk a bit about intermittent fasting. So at the outset, I would just like to know, we all know that I think every 6 months there is a fad diet which is popping out, and most of the people who are obese or try to follow these diets. So they when we broadly see the perspective, so all these diets, they are being classified somehow into 3 categories. So first is like they are manipulated, the macronutrients are being juggled. So whether it is a low fat or a high fat diet or a high protein or a low carb diet, which goes into the green category. And then secondly, it is the manipulation of the timings. So whether it has to be a periodic fasting, or alternate day fasting, or a time restricted fasting, again, this is another type of a fasting. And then it is a restriction of a specific type of the food. So it can be a plant-based, a vegan diet, or a gluten-free diet, or a paleo diet. So these are basically different characteristics how the diets are being classified. And like today I am here to speak a little on intermittent fasting, so just giving a broad perspective on what is intermittent fasting to our August gathering. So we know that intermittent fasting is not about what to eat, but it is about when to eat. It is about the timings about of the food, like when to eat. And there are different regimes in intermittent fasting. So first it is like the alternate day fasting, whereas like one day you're going to fast, and another day you are going to eat at pleasure, which is called as by days of ad libitum food consumption. Second is the periodic fasting, so individuals can fast for 1 or 2 days, and so it's like maybe 5:2 or 6:1. So 5 days they're going to eat a caloric restriction, and 1 day they are going to fast. And second is like the most common, which is the time restricted feeding, which is 16 by 8 or 20 by 4. So that is basically, we can see that 16 by 8 is like you're eating for 8 hours interval. So maybe from from 11 to between 6 o'clock you can eat something, and then after 6 o'clock you're not supposed to eat anything. So that is a big long fast for 16 hours. And I think this is the type of a fast which usually we observe in Jainism. And then we have the 5:2 approach, which involves regular fasting, which is 5 days a week, and for the other 2 days you limit yourself to 500 to 600 calories, not more than that. So an alternate day is like eat a normal diet on one day and either completely fast on the other day, or eat only a 500 or 600 kilocalories diet. So these are the different type of fasting, and this is a typical picture what you can see. The red is like this is the day you are fasting and then you are eating. So this the picture can be something like this. So for 2 days you are eating a normal diet, then you are fasting, and then again and you are eating and then you are fasting. So this is a typical 5:2 method. And this is the time restricted fasting, where the 16 hours you're not going to eat something, eat anything. Maybe 12 to 16 hours you're not going to eat anything, and the next 8 hours you can eat or consume something. And very important thing is any of the diets, whether it is keto diet, whether it is any diet, it's been always hyped by some of the celebrity. And let me tell you, this intermittent fasting has been followed by most of our celebrities. When I just happened to browse, I saw, okay, yeah, these guys are all doing intermittent fasting. And we and very well, I think sir has already said that the circadian rhythm actually also regulates the eating, sleeping, psychological process, and also coordinates the metabolic energetics. So the circadian it coordinates most of our metabolism and energetics. So let me just talk about a little on the effects. What are the effects of intermittent fasting? We've already seen that yes, intermittent fasting helps to reduce the weight. It ranges somewhere from around 2 to 9%, and it also reduces your fat mass. And what about the glucose? Yes, it helps to reduce your fasting glucose, which is actually a difficult endpoint to translate into the clinical setting. So in human trials, we've seen that yes, IF also helps to reduce your fasting glucose. It has a potential cardio protective effects. Does it have any impact on aging and cognition? So, and yes, in human studies, though they are less human studies, we need more of human studies, but then it has shown that most of the studies have assessed that intermittent fasting and aging are mostly conducted on animals. And we the conclusions of these studies yet cannot be generalized. So we need more of human data, which is lacking. What about the psychosocial impact? So we've seen that people who have a particular sort of disorder, that is a binge eating disorder, they, when we put them on intermittent fasting, they tend to eat larger portions of food, especially when they are on intermittent fasting. So that is why are they actually able to manage weight loss, and sometimes they may also get irritable or confused, because initially when we are putting them on intermittent fasting. So again, so people who are on binge eating disorder, usually we do not try to put them on this intermittent fasting. What about the psychosocial impact? Again, there is a study of Odi et al. Which was found that after in the 8 weeks of alternate day fasting in 59 subjects with obesity, it decreased the depression and binge eating. Further, it is essential to define the restrictive eating consistently among the studies. That is the subjects who were randomized to ADF or ADF plus exercise restrained eating and increased, while uncontrolled eating decreased. So that is why it is actually patient to patient. We need to make them understand. We first need to understand whether that patient will be able to carry on intermittent fasting. So that there is a lot of thing we need to actually teach our patient. Okay, do not go immediately on intermittent fasting. So maybe we put them for a week on trial for 16 maybe, or 12:12, and then maybe further we increase the hours of fasting. So there are again number of studies which has shown that intermittent fasting helps to reduce the BMI, and also helps to reduce the body weight and also the blood glucose levels. And there are number of clinical trials which has shown in patients with and without diabetes. And this is about the alternate day fasting, 1 day of fasting and 1 day of ad libitum feeding, which has shown that there was a decrease in body weight and decrease in fasting glucose and decrease in also insulin levels. And all these studies has also shown a decrease in the body weight and also in the fasting blood glucose, and also the fasting insulin has also reduced in all these patients. And when we are talking, this again is a clinical trial of patients who are on time restricted feeding. Again, we see that there is a decrease in fat mass, fasting glucose and insulin levels. Again, for the patients who are on these method of 5:2 method, again we can see that there is a decrease in body weight and decrease in A1C as well. And again, these are number of studies which has evidences which have shown that there is a weight loss. But again, in few of the studies, then we have seen there was no effect in glucose, lipid and protein metabolism. Now, I just came across this paper which shows the popular pro claims for insulin for intermittent fasting, which shows that whether the intermittent fasting increases the weight loss as compared to the isocaloric diet. So, RCTs has shown that there is the same weight loss for the daily caloric restriction and intermittent fasting. So, whether or not you do intermittent fasting or you do caloric restriction, the weight loss is almost similar. So, is there any reduced hunger compared to the traditionally daily caloric restriction? Overall differences, hunger ratings, though individual preferences. So, again, it's very, very individualized. Any diet is very individualized. Does it improve your insulin resistance? And it is independent of weight loss. So, overall, there is no clear evidence whether it improves the insulin resistance or it is independent of weight loss. Timings of the food intake could also have a role. So that is why it's again individualized, and it also depends from patient to patient. Does it improve the glucose control in type 2? RCTs have shown similar reductions in weight and A1C, which we have already seen anti-aging and anti-inflammatory effects. Again, animal models demonstrate increased longevity and reduction in chronic diseases with caloric restriction and IF, but data again in humans are lacking. What about again, there are some negative claims also. Would IF lead to overeating on feast days and would trigger eating on disorders? It is not so. It is almost the same whether it is the feast days or on eating, whether it does not trigger eating disorders. Would it reduce lean mass? Again, the results are conflicting. Would IF is or not sustainable and leads to higher attrition rates? Yes, few of the studies which I saw, yes, intermittent fasting has slightly higher attrition rates naturally, because if you're going to eat, you're going to fast, again it is all patient to patient, it all depends. Again, the results are conflicting. Does it have side effects such as nutrient deficiency and lethargy? Yes, again, that we have seen from patient to patient, they may land up into nutrition deficiency. It all depends on the pattern of eating or what are they eating. So naturally, we need to understand and add on the micronutrients as well if there is any deficiency which is seen. Then there are some questions which are unanswered. Does time restricted eating during morning, afternoon or evening have any metabolic effects? We've seen that, yes, whenever a circadian rhythm, actually whenever it kicks in, the metabolic arrangements, when food intake occurs, it is in the rest phase of the species. So are the weight loss dependent effects on intermittent fasting on cardiovascular risk markers and insulin resistance? Humans suggest that insulin sensitivity can improve even in the absence of weight loss. So again, prolonged fasting has a unique metabolic profile in animals. It does have cardiovascular if good effects on intermittent fasting on humans. Can fasting mimicking diets reduce aging? Again, we have only evidence of improved surrogate markers. We need to have again more data. Is there any intermittent fasting protocol which is associated with higher long-term adherence? There are again few studies on this. So the question arises here, is intermittent fasting versus your daily caloric restriction which is more effective? Again, the effect equally is the same. The weight loss, we have seen the intermittent caloric restriction and the daily caloric restriction diet, it appears that it is to be equally as effective in decreasing body weight, fat mass and potentially visceral fat mass. Though in some studies it is seen that intermittent calorie restriction may be superior as it conserves the lean mass. And again, overall, intermittent fasting can be given for the patients who are overweight and obese populations. However, again, the weight loss what we have seen is almost the same as compared to the energy restriction, and sustainability again of intermittent fasting was similar. Other markers such as insulin resistance, fat mass improved more with intermittent fasting than continuous energy restriction in preliminary studies. Again, more research in this area would clarify the things ahead. So whom should we actually, what are the risk which is associated with intermittent fasting? Again, the patients, if they are on insulin or sulfonylurea, their doses should be titrated. There's some what are the things what should be kept in mind when IF is to be prescribed? The patient should be educated regarding the importance of consuming nutrient rich meals. That is very important, so that they are eating the right food so that they do not land up into micronutrient deficiency. So we need also consider some vitamin or mineral supplementation depending on their dietary practices, and also ask them to be adequately hydrated. And these are the patients whom you should not are appropriate. So maybe children or teens with underage of 18, or the pregnant and the lactating woman, the elderly woman, or patients who have brittle diabetes or are suffering from eating disorders should not be advised about intermittent fasting. And again, the question comes, so what can I eat while you are intermittent fasting? So yes, you're going to have 2 meals, and in between, if you are feeling hungry, so maybe you can have something which has which has very low in calories, like your maybe your water, your zero, which has 0 calories in fact. So your water, your black coffee, black tea can be taken in between. So so basically what I would want to focus now, that is intermittent fasting new? So it's absolutely not new, because fasting already existed in our culture, and most of our sadhus and most of our our priest, or every culture or every religion has been carrying out fasting, whether it is Islam or Buddhism or Jainism. Everybody is carrying out is practicing fasting. So another thing what we observed is that intermittent fasting is also being practiced by our rural farmers. When we have taken the dietary recall of some of our rural farmers, we have seen that they take a heavy lunch in the morning, so that is at 9 o'clock, and they have a early dinner, so maybe around at 5 or 6 o'clock, and then they do not eat. So again, this is a typical sort of intermittent fasting, which has been, it is nothing new, it's already existing. Again, in Jainism also we see that is the same type, that they have at 11 and they have their dinner at 6. In fact, even the few working professionals, so I have a case of a professional SSG who has a cup of tea, maybe at 7. Of course, it is not an intermittent fasting, but something similar, and I'm sure this type of a diet must be practiced by few of the professionals who are also sitting here. So maybe early morning it is just a cup of a tea, who is this case is not in in a habit of eating breakfast, so he has a cup of tea, just has 1 or 2 glasses of buttermilk, a very thin buttermilk, and then maybe around at 1:30 or 2, he has 2 chapatis, dal and vegetable, and then a lemon tea, and a dinner is something similar to lunch, and that is somewhere around at 9:30. So this again is a picture of a somewhat similar to a intermittent fasting. And this is a thing, which has been actually carried out since many years. And in fact, let me reveal that this is a typical scenario of, I think, Dr. Sunil, which he's been doing it since, I think, last 30 years. So these are the different things which has been followed by many of us in our scenario, and there are number of studies which has also showed that it is not only intermittent fasting, it is the what I've told, juggling between your macronutrients, the meal replacers, then the lifestyle modification, the intensive lifestyle modification, that is the look ahead trial, the direct trial. These all have shown that this again can lead to weight loss. So finally, is there the scientific evidence concludes that there is no optimal effective diet to promote weight loss. Fundamental point to success is you need to adopt a diet that is based on high quality foods, which creates a negative energy balance and promotes a good level of adherence. So intermittent fasting, whether it is a hope or hype, we really think it is a hype, because there is again no one size fits all. It has to be highly individualized, it has to be structured. Whatever diet you are following, it has to be simple, it has to be consistent, it has to be structured. And I think the main mantra should be mindful eating whenever for whatever diet you are following. So thank you so much for having me over here.
Excellent talk, Dr. Kavita. So, is there any relation with stress and hunger? And while we eat a food, a lot of happy hormones like dopamine, serotonin are in the food.
Yes.
So, can you throw some light on this?
Yes, stress, of course. See, what I was just focusing on binge eating. So whenever a person is in stress, they happen to eat more. So that is why that's like again a vicious cycle. You are stressful and then you're going to eat more, and that thereby you're going to gain more weight. So that is why. So usually when you are stressful, I think we need to be eating not eating foods which are high in calories. So rather we can focus on foods which are low in calories, of course, and try to divert your mind.
Thank you very much.
Yes.
Thank you, thank you. So, requesting sir to take a moment and give a moment to ma'am, please.
Yes.
Those who are not member of the RSSDI, you can become a member. So there is a link given, and we will pass on to everyone. But you can be the member of RSSDI, as well as those who have got their credentials already there. Please change their email ID, because now e-voting is going to be there in the elections. So please change their number, mobile number, mail ID, everything. Please update the mobile numbers.
Thank you very much, ma'am. Now we are moving for a fourth session. There is a slight change in the program. So I invite Dr. Purvi Chawla, ma'am, for diabetes and oral health. She is a consultant diabetologist and director of clinical research, Lina Diabetes Care and Diabetes and Beyond, and Mumbai Diabetes Research Center. Is a co-and sub-investigator for many national and global trials, Fellowship of Diabetes India 2017, scientific chairperson for many conferences, secretary at Santa Cruz Medical and Social Association, and many awards, trainer for diabetes
Thank you so
educator.
much.
Thank you, ma'am.
So first of all, very thankful for this exclusive opportunity to speak to an August gathering here, and secondly for the organizing, the elite organizing team for including this Hatke topic also in the conference, because this is as you will see, it's a very important topic, but we don't pay much attention to it. So diabetes and oral health. And well, let me upfront tell you that diabetes and oral diseases are bidirectionally related due to the common milieu of risk and causative factors. Just to remind you all that this is the normal periodontium, the cut section of the tooth with the crown as well as the root deep, very snugly fit into the bone or the dental alveolus, and held together by the gums. Shown right here, and this is the cementum, which again adheres it to the periodontal ligament, and periodontium is nothing but the gums, the bone, the cementum, and the periodontal ligament. So after this anatomy crash session, let's move on. Well, oral health related conditions associated with diabetes are a myriad of conditions, right from periodontitis, gingivitis, caries, so on and so forth, and even oral cancer. And one factor which actually leads to all this aggravation of the problem is the fact that the percentage of people with edentation or edentate people has gone down from 4.4 to 2.4% over the last few years. Thus, we have more natural teeth going into old age, and with the increase in longevity, definitely more teeth require preservation with prevention, treatment, maintenance of teeth, and protecting them from infection, inflammation with good glycemic control. So this is the crux of the matter. Periodontitis, one of the most commonly and adversely linked conditions with diabetes, is nothing but oral gum disease, which is characterized by the inflammation of the soft and hard tissues surrounding the teeth, initiated by the bacteria and the plaque on the teeth, and then enhanced further or promoted by the host immune system. Right from 1993, Harold Lee had said that this is the sixth complication of diabetes, but it was only several years later that the scientific community started acknowledging that and gathering generating the evidence to prove that poor oral care, oral diseases are a risk factor for uncontrolled glycemia, increase in cardiovascular disease and complications, and definitely adversely affect the outcomes. Well, normal periodontium, I just revised that with you, but at the bottom panel you can see the healthy teeth and gums, and then progressively you can note here, can I use a pointer? Does this work? And progressively, you can see that, the gum tissue is being lost. This is still the reversible stage of periodontitis, where it is gingivitis first and then early periodontitis, and then irreversible phase of moderate and advanced periodontitis, and eventually tooth loss. So you can see how pathetic this, starts to even appear clinically. And now just a quick, talk about these terms, because we as physicians are not even familiar with some of these. So dental plaque is nothing but a biofilm of bacteria and food debris on the surface of the tooth, which accumulates over time because of poor brushing, poor oral hygiene, and it causes gingivitis. And plaque buildup, like I said, it can be seen even with brushing, but poor brushing. So one needs to remove the plaque regularly. Gingivitis, on the other hand, is a reversible inflammatory reaction caused by the buildup of the plaque and affects 50 to 90% of adults worldwide, and eventually leads to swollen, reddened, and possibly bleeding gums. In susceptible people like those with diabetes, untreated gingivitis further leads to chronic periodontitis. Chronic periodontitis is severe, irreversible form and affects both soft as well as bone surrounding the tooth, is a major cause of tooth loss in adults, and requires lifelong monitoring and management, just like diabetes. Severe periodontitis affects 10 to 15% with considerable variations across the world. Periapical periodontitis affects the jawbone around the opposite end of the tooth. So remember, it's actually inside the gums or inside the bone, because it sounds like it's on the top, but it's actually on the reverse. So despite similar oral hygiene habits and amount of plaque, children with type 1 diabetes have more gingivitis and more calculus than children without diabetes, and this has been proven. Again, the enhanced data, where they divided patients above 30 years of age with diabetes into different age tertiles, as you can see, and based also on the level of dysglycemia, with blue indicating A1C above 7% and green less than 5.6 and yellow somewhere in the middle. It clearly shows that periodontitis, moderate and severe, are proportionally linked to age as well as the level of dysglycemia. Similarly, it's more prevalent in men versus women. Thus, race, ethnicity, and smoking status were also significant drivers of periodontitis besides diabetes. So this is just to horrify you all that in the absence of self oral care, in the absence of professional dental treatment and uncontrolled glycemia, this is the outcome, where there is complete loss of the tooth structure, the bone structure, and also an aggravation of the systemic conditions as well. Diabetes and periodontal disease. Well, hyperglycemia thus adversely affects both soft and hard tissues of the periodontium. Prevalence of gingivitis, periodontitis, and its progression and even tooth loss are directly proportional to the level of dysglycemia, like I showed you in those with diabetes. And it's 2 times more prevalent in diabetes, 3 times more in the younger age group as well, who have poorly controlled diabetes, and more in men as compared to women at all levels of glycemia. Prediabetes is also forerunner for detrimental effects on the periodontium, and in uncontrolled diabetes, terminal affection of periodontitis may require complete extraction and even restoration. And unfortunately, it's always diagnosed late, because the patient may not have any symptoms or any tissue breakdown or bleeding or swelling, especially in smokers. And lengthening of the tooth is the only symptom or sign available which needs to be detected at the first go. So diabetes is a sufficiently strong risk predictor of periodontitis for the recent clinical and the Americans as well as the Europeans have agreed that diabetes is an independent strong risk predictor of periodontitis, and they've included it in the classification, diagnosis, staging, etc. Now, oral health also impacts diabetes. This should be diabetes, not periodontitis. Right from years ago, we know that periodontitis adversely affects glycemic control and diabetes related complications. Even those who are undiagnosed, have pre-diabetes or diabetes with poor periodontal health, have poor glycemic control and increased risk of diabetes related complications as well. In fact, even when those who don't have diabetes but have poorer periodontal health, they have a greater risk of developing diabetes than those with better periodontal health. A Taiwanese study also showed us the same, and random fasting sugars are also found to be increasing with increasing prevalence of periodontitis. And so is the case with inflammatory markers, even locally as well as systemically. Now, what links the two? Well, three main pathogenetic mechanisms have been identified. First is the bacteremia, which originates from the plaque that I told you, that biofilm on the tooth surface. Then the inflammatory response surrounding in the surrounding tissue because of diabetes, as well as the inflammation caused by the bacteria itself. And then the immune dysfunction, which we know that all diabetes patients seem to have. There is a lot of crosstalk between the two, and periodontitis and hyperglycemia, which is worsened by complications like diabetic neuropathy, and in the milieu of increasing age, alcohol intake, genetic predisposition, and chronic conditions like dyslipidemia, hypertension, obesity, socioeconomic status, smoking, stress, and vitamin D deficiency, these seem to be aggravated. Again, the three major aspects that I told you that link the two, the biofilm, the dental biofilm, the chronic overexpression of pro-inflammatory mediators, which eventually elicit the acute phase reactants from the liver and further add to the oxidative stress and insulin resistance, and the immune dysfunction, which also negatively feeds into both these conditions. Periodontal infection leads to a lot of systemic affection because of bacteremia. One bacteremia, where the periodontal bacteria not localized, but they systemically travel and aggregate in the different organs of the body. Then the inflammatory response, which is elicited and which also affects different sites, and then the immune dysfunction, which also leads to antibodies to the periodontal bacteria as well as other byproducts, but may also lead to a lot of other systemic issues as highlighted here. This is a range of oral complications with diabetes. The first one, periodontitis, and these green dots in the X-ray just show where the gums should have been, and red is where they really are. So this is the lengthening of tooth which I was telling you, and this appears to be the only symptom or sign in most of these patients with diabetes that we really need to pay attention to. This is dental caries, even fissured tongue, candidiasis, and then you have caries again, and then you have leukoplakia. This is the periapical lesion leading to this pus pocket and the swelling. And even when you have implants, it is not spared, or they are not spared, and you have peri-implantitis as well. So very quickly a dive into all these other co-associated situations. Even in case of implants, like I told you, you have mucositis and implantitis, which is akin to periodontitis, and patients with diabetes have 50 to 90% greater risk of peri-implantitis than those without diabetes, as seen in several studies. So diabetes may be a risk factor for peri-implantitis, even independent of the smoking status. Again, dental caries, whether it's coronal caries, which is on the top, or the root caries, untreated caries may lead to the destruction of the pus, of the pulp, and lead to the toxins collecting there and even spreading from the local site. And 35% of patients taken all together across the ages are suffering from caries today. So in diabetes, again, the occurrence is much more than in those without diabetes. And because of caries, when your when your teeth become more sensitive to the different temperatures and the different tastes in the food, that leads to poor nutrition, because one may not be able to consume a lot of fruits and vegetables, but maybe just consuming more carbohydrates or more sugar, fat, and other aspects which may aggravate the metabolic syndrome, diabetes, or insulin sensitivity. Periapical lesions, again, which is a complication of diabetes, are more prevalent in those with diabetes, and untreated caries may lead to that breakdown or necrosis and accumulation of pus, which may spread to the surrounding bone and tissues, and this may be apparent only on the x-rays and not even clinically. Again, studies have shown that with poorly controlled diabetes, the prevalence of tooth with periapical lesions is much higher, or almost 18% higher, as compared to well-controlled diabetes. Early tooth eruption comes with its own issues, especially in girl children in the teen years, 10 to 14 years, and this may lead to malocclusion or impaired oral hygiene or periodontal disease, and even caregivers may not notice it, which means they get neglected and further become susceptible to other diseases. Dry mouth is again, or hyposalivation is also a side effect of many of the conditions associated with diabetes, or maybe due to persistent hyperglycemia itself, and that leads to increased glycemia in turn and mucin, and these changes in the cleansing, lubricating, and digestive capacity again increase the viscosity and contribute to oral diseases as well. Tooth loss is very common. Diabetes patients have more than 2 times the prevalence of tooth loss as compared to those without diabetes, and we know that edentulism is very strongly associated with depression as well as poor self-rated healthcare, both across young people as well as older age groups, and this has been proven in multiple studies as well. Again, missing teeth or hurtful teeth lead to poor nutrition or poor nutritive intake, and lead to greater intake of refined foods. Candidiasis is also more common. We know delayed wound healing and iron precipitation also can occur on the enamel of the crown, but not on the root, and this may cause aesthetic issues as well in those with diabetes. Oral cancer is also more prevalent, especially 2.5 times higher risk of oral squamous cell carcinoma, especially in women with diabetes and periodontitis. Complications, especially neuropathy, I already showed you how it affects and worsens the oral health care in those with diabetes. The oral microbiome in health pre-diabetes and manifest diabetes, it has been clearly shown that from the oral microbiome, which is the bacteria, viruses, and fungi in the mouth, you can actually predict, or you can have a good sense of the glycemic status of the patient as well. Oral health and other oral diseases also lead to systemic inflammatory responses and cause an increase in blood glycemia, and we've seen that already. The quality of life needs to be evaluated, but by 3 main things: dry mouth, periodontitis, and tooth loss. But does that really matter? Well, periodontal treatment and the effect on glycemic control has also been very well studied, and we know even simple procedures like deep cleaning, which is non-surgical periodontal treatment, really shows that there is a reduction in inflammatory markers and HbA1c reduction as well. And so is even tooth extraction when it's decayed and it's completely is surrounded by the periodontitis. So, and of course, reduction in healthcare costs. So, deep or very cohesive interprofessional collaboration is definitely required for us to focus more on such a niche topic or niche area of health that is widely ignored. and a joint statement of the Indian Society of Periodontology and the Research Society for the Study of Diabetes in India was convened, and we have an entire document which was published, and I was very honored to be a part of the same. It provides not only good clinical practice guidelines for the management of diabetes patients with periodontal diseases and enables a good collaboration between the two worlds, but also aims at improving the quality of life. So with that, I come to the last two slides. Must do is regular checking of blood sugars for any oral work is necessary, and regular oral care as well as dental visits are equally necessary. Dentists and physicians both need to collaborate for any procedure that a patient with diabetes must undergo. A glucose meter at a dental clinic may be a useful device, and screening for random blood sugar also should be undertaken. Dentists should regularly measure the depth of the space between the tissue and the soft tissue, which I just showed you in that diagram. And physicians should definitely ask pointed questions pertaining to oral health and examine for loose teeth and other symptoms at every visit. So we need this synergy between the physician, dentist and patient to maintain periodontal stability and glycemic control. And so the bidirectional adverse link is well proven, and regular sugar checking as well as regular dental visits are very, very necessary, and this can be reinforced only by a multidisciplinary team that is functioning in sync to improve the quality of care for the life of the diabetes patient. And with that, brush your teeth thoroughly twice a day at least. Thank you very much once again for this very exclusive meeting opportunity.
Thank you very much, ma'am. Only one question is allowed, if you have.
Burning syndrome. Hello.
Right. So I think one is glycemic control should be established, good glycemic control. Secondly, one needs to also look at systemic neuropathy before looking at just burning syndrome in the mouth, and treat that. And there are a lot of techniques for increasing the salivation also in the mouth, which helps to alleviate some of these symptoms. Sometimes there is underlying depression as well, which needs to be tackled with, because xerostomia is not, you will not find that patients have measurable or objective hyposalivation. It's more of a feeling of dry mouth, and usually with it's just treated symptomatically rather than anything else, and of
Bansi
course
bhai?
looking at underlying causes.
Good question.
They have recommended that annually there should be a dental checkup.
Yes.
That is part. So why is so important? Diabetes is important. So dental examination was part of ADA recommendation before 2015, and it has not been recommended still by RSSBI in our guide.
So we have all the dignitaries here. It's right in your hands to include that as well. But with respect to ADA, I believe that, I mean, this is just my guess, that it may have been driven by the insurance coverage as well, because not everybody may be covered by dental insurance in the US.
Just for the for
Sharing with.
you will be normally very important. Very few clinics in India who have dentists inside the diabetes clinic also, which is very much becoming. No, I am not very I am still it's not like
Good practices, good clinical practices. Yes,
Thank you very much,
completely
madam.
take your
It's
field.
an excellent
Thank you.
eye-opening lecture.
Thank you
Thank
so
you
much.
very much. Thank you.
Thank you, Dr. Purvi. And I request Dr. Parikshit
Yeah.
to hand the memento. beautiful moment of Statue of Unity. I request Dr. Parikshit to hand over one moment to our chairperson, Dr. Kantibai Patel. You will get later on when you are a speaker. So, thank you.
Thank you very much to RSSDA for giving me an opportunity to chair the session. Thank you very much.
Thank you. Thank you. So with that, the next session, statue batao hum, right. So that is. With the next session, I call up Good afternoon, friends. First of all, thanks Dr. Bansi and Dr. Jetwani for giving me this opportunity to chair the very important sessions, for which I would like to call upon the first speaker, Dr. Rajiv Goyal, and he's going to speak on. Rajiv Goyal is here? Yeah. So, a recent update on ADA 2022. So, Dr. Rajiv Goyal is a diabetologist and is medical director and consultant diabetologist at Covil Diabetes Center. And he's consultant diabetologist Nanavati Super Speciality Hospital, SL Raheja Hospital, KLS Hospital, Arogya Nidhi Hospitals, and a speaker from many international and national forum. And also has been invited faculty in a diabetes fellowship program.
Thank you.
DY
Thank you
Patil.
so much, Chairperson. Thank you. Thank you.
Over to you, sir.
Thank you, everyone, from Bansi to Pratap to Uman to Sandeep, everyone. That, people have left river rafting, SOU, and have been here, and there's a good audience here. What I'm going to do is that I can't compress the ADA in 15 minutes, but I've taken out two interesting award lectures, and I'm just giving you a gist of two big research. One was 40 years and one was 20 years of research. So this was the Banting Award lecture and the Edward Wyman Award lecture, both presented on the 4th day of the ADA. I'll just give you a background of the Banting Award, one of the most prestigious award lectures, and usually looks at pathophysiologies. And around 4 years back, there was another Banting Award lecture which looked at what actually triggers patients to progress from pre-diabetes to diabetes. How does the compensatory hypersecretion of the pancreas go down? And clearly it was seen that fat around, ectopic fat deposition around the organs with fat deposition in the pancreas, 3 grams of fat in the pancreas is more than sufficient to disrupt the pancreatic regulation and functioning. So, and then there is a crosstalk between the liver, the fat in the pancreas, and the fat in the kidney. So liver seems to be one organ. We talk about NAFLD, MAFLD, so many things, but that seems to be this kingpin in this metabolic blunder which we call as type 2 diabetes. So everything starts from the liver. Liver makes hepatokines, which is ferritin A. It triggers a lot of crosstalk and the pancreatic secretion of insulin goes down. So that is the background to the talk that I'm going to repeat, Francis Ashcroft. So metabolic regulation of insulin secretion in health and diseases. Now we all know that glucose enters the pancreatic beta cells, undergoes glycolysis, then it enters the Krebs cycle, it enters the electron transport chain, you have an increase in ATP-ADP ratio, the potassium channel shut, calcium channels open, and we have insulin exocytosis. Now, in the 80s, when she came out with her first research, she knew that the calcium channels open and there is insulin exocytosis. But the potassium sensitive ATP channel was not identified in 40 years back. It took her some time to identify that some electrical activity occurs because of the increased ATP-ADP ratio which occurs. Now, she's somebody who worked a lot in neonatal diabetes, and we know that earlier neonatal diabetes was considered some form of type 1 diabetes, and later we realized it's a form of monogenic diabetes with mutations occurring in the potassium ATP channel, very rare as you can see it, very high blood glucose in 6 months, low birth weight. And when she serially looked at patients who were treated with neonatal diabetes and then changed over to SU treatment around a decade back, what she saw that the response of patients when they were put above 18 years of age as compared to patients who were put on an SU at 6 months of age, majority of patients who were put on 6 months of age had a 95% chance of getting controlled with an SU as compared to patients about 18 years of age where it was 60%, thus showing that the pancreatic secretion of insulin goes down even in neonatal diabetes. So even in neonatal diabetes, there's something which is happening, that the pancreatic secretion goes down. Now, a lot of people have said that whether it's somewhere between type 2 diabetes. Is type 2 diabetes is also a form of genetic diabetes. Now, as you can see that this is what the SUs made the change in neonatal diabetes, and the insulin secretions got enameled. Now, this is what happens in type 2 diabetes. We have glucose coming in, you have metabolism is low, the ATP production is low, and that's how the insulin exocytosis is very, very low. Now, the whole moot question is, why do beta cells fall or fail in diabetes? The problem is that when glucose enters the cell, instead of undergoing aerobic, anaerobic glycolysis, getting into Krebs cycle and then getting into the electron transport chain, doesn't happen. There's a reduction in ATP, ADP which occurs, and there is an accumulation of certain other elements in the pancreatic beta cells. 5 years back, it had said that there is some amount of inflammation because macrophages were found inside sitting on pancreatic beta cells, and there seems to be some inflammation. So this was tested by creating a mouse model where this particular gene defect, and we caused diabetes with tamoxifen injection, and you can see there's hyperglycemia. So when it was stained with electron microscopy, the one on top is what is the control, and the one below is the 4-week-old mice. You can see certain degranulation and those white colored patches which you can see on the right, and those are degranulated cells. And what further testing, what they realized, that there is glycogen accumulation. So those cells that you see, those white cells on electron microscope, is glycogen accumulation, and glycogen accumulation suggests that the beta cell metabolism is impaired by chronic hyperglycemia. I'll just go back to the previous slide and say that loss of insulin staining in diabetes does not necessarily mean loss of beta cells. So again, it is not loss of beta cells. It's not loss. If there is no insulin, doesn't mean loss of beta cells. Beta cell mass in type 2 diabetes may be underestimated if assessed by insulin staining. So here you have glycogen deposition, and what happens in the pancreatic beta cells of type 2 diabetes, there's an impairment in metabolism, and instead of entering the TCA, Krebs and the electron transport chain, it enters into what is glycogen synthesis, which will occur when we have glycogenesis in the liver. That is what occurs, and you have excess glycogen deposition in the beta cells of patients with type 2 diabetes, and hence the ATP-ADP ratio is low and there's no electrical activity. Now they try to change it by using, this is from avocados, and they use this manoheptulose, which is a form of carbohydrates, and restore insulin secretion in chronic hyperglycemia. I'm not going into deep, but if you look towards the right side, the cells cultured at a high glucose also showed an assay in the absence of manoheptulose. Now we all know that how pancreatic function can be restored either by a bariatric or the direct study and so many things. But here what is being suggested is that till almost a few years back, glucokinase activators were used as treatment for type 2 diabetes. Here they are saying counterintuitive glucokinase partial inhibition may be the treatment for diabetes, or not diabetes, maybe pre-diabetes. So to return glucokinase flux to normal. So if you are able to, what happens before diabetes, chronic hyperglycemia, make sure that they shift the metabolism internally. So excess glucose enters and they get into glycogen synthesis. So if you are able to do some amount of glucokinase inhibition, selective glucokinase inhibition, the chronic hyperglycemia which lasts for almost 7 to 10 years from normal to pre-diabetes to diabetes, and then you get that trigger and you progress to the tsunami of diabetes, can be prevented by this mechanism, which is a glucokinase partial inhibition. And this is sir, 40 years have been recorded in only doing this, and this is the conclusion that beta cells remain viable even after many years of diabetes. Chronic high glucose leads to reduced insulin content, impaired beta cell metabolism, and most importantly, it is not glucose but a glycolide metabolite that causes these changes. We always thought it was glucose. Then the other award-winning lecture is by Gary Lewis, and it looks at intestinal lipoprotein research and 4 big surprises. I'm going to go very fast. We all know that insulin resistance and dyslipidemia and certain genetic variants, as you can see on the right, make sure there is increased production of VLDL from the liver, and we have triglyceride rich lipoproteins come in, and these triglyceride rich lipoproteins are easily going to be oxidized by the lipoprotein lipase and other lipase, and then you have the small dense LDL, small dense HDL, finally landing up to atherosclerotic cardiovascular disease. The 4 big surprises, I have 5 minutes, is one, that chylomicron production is increase in insulin resistant states and diabetes. We always thought that VLDL production by the increased ApoB100 in patients with type 2 diabetes is increased in diabetes. But now we are saying that chylomicron production from the intestine is increased in diabetes and insulin resistant state. Another thing, although fat ingestion is the major determinant of chylomicron secretion, we all know there's a complex multi-organ regulation of secretion that involves nutrients, hormones, and neural networks. So it's not just the amount of fat. Another thing, very important, that a considerable amount of ingested fat is retained in the gut postprandially in various lipid pools for up to 10 to 12 hours. So today, whatever fat you had in the morning, your fafda, jalebi, bansi is giving you tonight, will be stored in the lipid pool for up to 12 hours, and it doesn't get absorbed immediately. There is a trigger. I'll show you what the triggers are for mobilizing the fat from your intestine into your circulation. Another thing is that lymphatics, we thought that they are passive conduits, but they are actually not. They are very active pumping system which transport chylomicrons from the intestine to circulation. So this is the hamster mice. They took the hamster model because it also, like humans, ApoB100 from the liver and ApoB48 from the intestine. So insulin resistant humans overproduce ApoB48 containing intestinal lipoproteins. This is what happens. We know that we have increased NEFA coming in, VLDL production goes up, it comes out, and you have increased triglyceride, ApoB100, which occurs in type 2 diabetes, insulin resistant, and dyslipidemia. Lipoprotein secretion by the liver and the intestinal chylomicron is modulated by several factors arising from gut, pancreas, and adipose tissue, and by neural signals from the brain as well. And this is what is it, that we always thought that it is the liver, but presently you have chylomicrons which are being actively transported in insulin resistant and type 2 diabetes. GLP-1, glucagon, and GLP-2 has a part to play in that. GLP-2 is a analog of GLP. It has been used in short bowel syndrome, where many of the kids and adults require total parenteral nutrition, and it restores nutrition in short bowel syndrome. It may be the future for patients with type 2 diabetes and dyslipidemia, or only for dyslipidemia. And these are known potential and novel factors regulating chylomicron. We always knew diet and circulation, but there are a lot of other genetic variants and other factors. The third most important thing which I was talking to you is lipid is sequestrated in intracellular CLDs in enterocytes as well as extrocytes, secreted chylomicron in the intercellular space. So basically whatever we eat is put into these kind of buckets in the enterocytes for a long time, And triglyceride storage in enterocyte initially increases after fat stimulation and then decreased over time. In humans, significantly intracellular enterocyte lipid stores have been observed after 10 hours, and lipid is mobilized from the gut up to 18 hours post dietary fat ingestion. And what is one of the triggers? Is glucose. This diagram says that glucose ingestion many hours after your fat ingestion is the stimulus for your chylomicrons to be put into circulation. So you may have had a fat in the morning, but 18 hours later you have a gulab jamun, and that fat from that droplet or that bucket gets mobilized into your system. So this is dangerous. This is dangerous, that you think that, so maybe some kind of blockers may come in. Another thing which is not there on the slide is GLP-2. GLP-2 inhibits this stimulation of the or the mobilization of these buckets of fat into the system, and GLP-2 may be used in future in dyslipidemia as such. Again, as you can see, lymphatic pumping is not just a simple pathway. There's an active pumping which occurs especially in the intestine, and that's probably one pathophysiological defect. This has not been researched. This is a proof of concept, is what the investigator had said. Again, as I said, GLP-1, again, mobilization of intestinal lipid. Again, another thing is that GLP-1 is not seen in the enterocytes, it's inside the Golgi, and therefore some amount of inhibition will occur at the Golgi apparatus to make sure that the GLP-2 acts to prevent this depot from going out. So the future would be that some kind of a GLP-2 analog may help us, that we eat everything wrong, all the fat, and make sure nothing get absorbed. Today we have a few drugs like that, but nothing is effective. But the future may be that nothing will get absorbed from your intestine as such. So summary is that GLP-2 stimulation of chylomicron does not require mobilization. GLP-2 mobilizes major chylomicrons, most likely residing either in the lamina propria or intestinal lymphatics. Is an important modulator of chylomicron's appearance in human without acting on the enterocytes directly. They act on the Golgi. It suggests that novel atherosclerotic treatments for hyperlipidemia could target intestinal sites beyond enterocytes to suppress chylomicrons. Thank you all for a patient hearing.
Thank you, sir. Thank you for a wonderful lecture. Any questions from?
Thank you, Bansi. Thank you very much. Okay. Thank you so much. Thank you very much, Bansi. Thank you so much. Thank you.
Any questions from audience? Any questions?
Yeah.
May again think that something like that will be effective when in the early course of diabetes, and for the long-term purposes which was proposed in the previous years, and then using sulfonylurea rather leads to beta cell failure, and then the decrease in insulin content of beta cell, which is not improved as per this lecture, because they show that it is the insulin secreting capacity is gone away, but not the beta cell.
Absolutely.
So do you think that there will be possibility that again the usage of sulfonylurea will be used in early course?
So I'll take the question in two parts. One is that beta cell apoptosis story has been buried. There's no more beta. It was the Oxford group's imagination from the hat that brought that. Two, what they are actually saying is that the chronic hyperglycemia, when patients are in the pre-diabetes or higher sugar range, actually makes sure that the glucose gets inside the cell. And instead of getting metabolized in this phase, which is pre-diabetes, borderline high sugar, they get accumulated as glycogen. Whether a new SU can come in which helps in partially only entering the glucose. So what has happened? Chronic hyperglycemia is pushing in low amount of glucose and the metabolism is getting impaired. So if the glucokinase can be triggered in such a way that you are able to inhibit the excess glucose coming in, then the glycogen deposition will go down. It is not a complete, it has to be a partial inhibition of glucokinase. That's why it's very counterintuitive, because till date, we always looked at glucokinase activators to be the treatment, and none of them have been successful, and none of them have come out to the market, probably because of this. Because durability will go haywire. You will have lot of glucose coming in and lot of glycogen, and the durability will go haywire. So you will require a smart SU. You will require a smart SU which delivers the glucose in, goes inside, but again inhibits the glucokinase partially. You will require a smart SU there.
So, in your summary, you have mentioned that chylomicron modulators will be innovatives for this preventing the lipid transfer. So, any comments on that? Any ongoing molecules or any?
GLP-2 is what is being thought about, but it's not yet tried in this.
Okay.
It's only tried in short bowel syndrome, and it's been used.
Thank you.
Thank you. Thank you so much.
I request Dr. Jitendra Bhai to present the moment to the speaker.
Now we are moving ahead with our next topic, diabetes remission in clinical practice, turning dream in reality. I welcome Dr. Manoj Chawla sir for this topic. He is the director and consultant diabetologist at Lina Diabetes Care and Mumbai Diabetes Research Center, Andheri, and consultant diabetologist at SL Raheja Fortis, Mahim, Mumbai. And he has more than 25 papers in national and international journals and associate editor in International Journal of Diabetes in Developing Countries.
Afternoon, chairpersons. Thank you. I'm going to change my topic for today. You invited me to speak on one thing, but I don't feel like speaking on remission today. So I will change the topic. I'll let Neeta speak on remission, who comes in next. So just kidding. Warm afternoon, all of you. It's just wonderful to be here. I must request the organizers to change one of the aspects written here. I think Statue of Unity is not only pride of Gujarat, it should be pride of India. So we all are extremely proud of being here. Over the next 14 minutes that Neelam is giving me, I will speak on technology in clinical practice, where we can use that. We, of course, have many uses of technology. I'm going to be able to focus only on a few in this time. So this is the pre-COVID, the Superman scenario. As we said, a lot of us, we said we treat patients only at the clinic. Patient record is not our responsibility. Let patients have the papers and the files. It's their problem. Handwritten prescription, because that's what we were always trained for. And software is considered a waste of time, waste of money, and we really don't want to do that. Of course, things changed during COVID. And this is for people who are not using EMR. So my first focus of technology is on EMR usage. Patients were no show. Doctors getting quarantined at home, could not communicate to patients, and which is where it all moved to the digital health aspect. Many of us were already using the EMRs for many years, and that has helped us not only in the patient connect, but also in all the papers and abstracts that we get out at all the conferences. However, things changed. I'm sure by now most of us have gone digital to some aspect, allows us practice from home. I'm sure some of us have done consults from their hotel rooms this morning, also with patients reaching our clinics and so on. So this is helping, and I think everyone should have a certain aspect of digital connectivity. What is the Go Digital strategy? Implement EMR in your practice, allow online appointments, facilitate online payments, of course, enable paperless sharing of medical documents, and allow the teleconsultation facility. Many softwares, I'm not speaking for a particular software today, but I use OneGlancer. I've been extremely happy with that. And it allows us easy and simple view to the patient's history. But these are certain characteristics that you need to see in the software that you want to use. You get comfortable with a particular dashboard. What is the provision there? The ease of use, very important also to see in a clinic setup how your staff is able to use it. So they are the ones who are going to do the entry, how much time is taken to do the data entry, the connectivity on the go, and so on. This is some of the aspects that we see in our software. Well, this is patient trends. So at the click of a button, I'm able to see what is the patient's HbA1c been over the last couple of years, how it is moving, what is the weight, what is the blood pressure, cholesterol, and other aspects. So you are able to compare that and talk to your patient, and any of these aspects always helps in a chronic disease for them to see and understand how they can improve. Prescriptions, of course, I think one of the times that we can just depend on handwritten prescriptions. Our handwritings really, many of us really suck, if I can say that. So type prescriptions is important, and of course with the generic drugs as warranted. This can be translated into multiple different vocational languages as required by the patient. So that is something that also these prescriptions require. I'll give an example. There was a prescription that I saw written from a charitable hospital sometime back, and patient came with a problem. Doctor had prescribed a new brand of folic acid. Normally it is Fol 5, Fol White, I don't know how many. It was some Folitex which came in. So doctor wrote that Folitex, and the chemist gave Folitrax, right? And you can imagine what was happening to that patient taking Folitrax. It almost reached into an agranulocytosis kind of picture. The entire thing was a mess. So I think it's time that we don't put ourselves into that situation. So choose the right software, look for good availability. Importantly, somebody who can serve you. I must say, avoid softwares which kind of lure you by free software and we will support you, and there's always a catch. There are really no free meals in this world. Choose your software, pay for it. Your data should be owned by you. The rest of them are going to always try and get the data and sell it somewhere or the other. So that's an important aspect. And of course the government also moved on to talk about the telemedicine guidelines. I move quickly to the second aspect, which is on understanding that the number of patients we all see, there is a huge patient burden. There is no improvement in outcomes in spite of everything that we are doing and all the advances that we may speak about, whether today or those coming in the future. We know less than 30% of our patients in diabetes are achieving target HbA1c. So we need to have a more patient-centric approach, wherein amongst various aspects, you're also focusing on adherence to treatment, compliance to treatment, and you are sensitive to the patient's limitations and needs, be it cost, be it the ability to take medications twice or thrice a day. So again, I repeat, in a chronic disease segment, do not be regimental in writing your prescription, because that's what you heard at the last conference you attended, but be practical and realize what your patient can follow. At the crux of all of this, in diabetes at least, is going to be monitoring. So blood glucose monitoring is extremely important. And when we talk about monitoring, at the center of this is SMBG. Now, is SMBG a new technology? No, this has been the crux of it. But what's important is, though we recommend about the need for doing regular SMBG, today we've also realized that just random advice on SMBG, do it few times a day. Some patients will do once a month, and that used to be the average thing. They would typically do one fasting PP once a month, not even realizing that your strips, once opened, it has to be consumed between 3 to 4 months, even though the expiry would be a year and a half. Your 25 strips in that respect would not. Every time you open and close, there is air, there is humidity entering it. These are all chemically dried reagents on the strip. It will get spoiled. So that's where we move to understanding that what is structured SMBG. Let your advice be specific, something that shows you how the readings are done at different times of the day. Give that specific advice. When patient comes back, spend 2 minutes on their logbooks or on their recordings or on their digital logbooks to interpret those data and talk to the patient. It encourages them to check regularly. So when we understood about SMBG and started talking to the patients, that this is how structured SMBG should be, that sometimes you're doing it pre-meals, pre-lunch, post-lunch, pre-dinner, post-dinner, and so on, and these can be varied. Somebody who's on multiple daily insulin injections, you may ask for more aggressive monitoring. Somebody who's on oral but wants to monitor, you may ask for lesser frequent. The last thing that any of us should do is, when a patient, even if he or she is a pre-diabetic or only on metformin, asks you that shall I monitor, and sometimes we will say nahi, zarurat nahi hai. It is never zarurat nahi hai. Monitoring is the crux. Somebody asks you, do not lose that opportunity. If somebody is ready to check, yes, you may decide the frequency. Sometimes you'll have patients who get completely obsessed. They may be on simple orals, non-hypoglycemic drugs, and wanting to check 2 times every day. You may tell them to cut down if you feel so, but never lose the opportunity. So, and based on these patterns, you can advise the patient. Now, is there a problem? Now this is what, when I told one patient to do structured SMBG, this is how the patient got the data. Now I really can't understand what is written. Can any of you? There are some blood pressure readings, there is some sugar readings, right? 30th March, fasting almost in the evening, I don't know, vomiting, God knows, ultraset taken, was feeling very low. So this is the structured SMBG at home. Now this is another interesting one. This patient saw me just a couple of days back. Can any of you identify something which may raise some doubts in your mind? So if you look at the fasting, right, you still see some odd figures, but look at the post lunch. What do you see? Right. So do you get those values? Right. Right. So it's either fabricated or patient is approximating. Somehow I don't know, some patients have this habit. Why? 117 hai to 117 likho. Why should it be 120? Right. So either the patient is just writing the readings and this. So this is where the problem still lies in your instructions not being followed. How do you counter that? Well, it's time that you move to digital connected meters, and I'm focusing on two systems. Again, my disclosure is as I'm not contracted by anybody for today's talk except by RSSDI Gujarat, and they gave me this beautiful trip of the Statue of Unity this morning. Otherwise, I'm speaking purely for what has to be done. So you have the one touch system. Again, you will have the machine, it gets connected to the app on the phone, it also gets connected to the software in the doctor's clinic, can be shared by another family member. So very often you have children living in UK, US, Australia. They also want to monitor through the same. Once it's in the cloud, they are able to see the sugar from anywhere. These systems will give us many a pattern. So at the click of a button, you can see, I want to see only what is happening on the weekend. I want to see only what is happening post meal, and get different. So I want to see last 7 days. I want to see last 14 days. You are able to see all those patterns as long as the patient is checking their sugars. You have the app, you have the glucose meter. You can also start getting how much time the patient is in range. Today we all talk about time in range, right? Time in range is not only from CGM. If you're doing frequent SMBG, most softwares for BGMs will also give you time in range, and I'll show you that as well. This will be patient summary report. So in that summary, you're getting the patterns, you're getting some comparative statistics. You can see when the patient is going above targets. You want to just see the high readings. It will tell you whether it's on a weekend or it's only at dinner and not at breakfast and so on. So this can be a solution. As I said, putting it all together can be a solution. Now, so this is the other system, which is the AccuCheck system. So just like OneTouch, the AccuCheck also has a system, again integrating this between the AccuCheck Instant and their apps. It has a better logbook, again the ability to share the PDF reports, smart data analysis, and various other promptings. I will quickly take you to a dashboard report. So this is for one of our patients. Again, on the left here, you are able to see the time in range. You're able to see the multiple readings. You're almost able to see like in a AGP format as to how the readings have been, though in a linear form. You're able to see the total hypos. You can also have the patient flagging this off, whether it was a meal, it was bedtime, it was exercise, and so on. So the patient can put their input and it all gets recorded. So the larger message here is connected blood glucose meters are far better than non-connected ones, because sometimes patients do not give us the data, and all of this can improve the experience for the patient as well as the healthcare provider. Finally, let me move to CGM. Continuous glucose monitoring guides decision making and must be a part of diabetes management toolbox. It is expensive, it is costly, rubbish, really rubbish. In today's time, every person with diabetes should be able to do their CGM to understand that pattern. I prefer to do it for every individual detected with diabetes for the first time. Unless you see their profile, you are hitting in the dark. Sabko metformin do, sabko aise hi blindly lifestyle bolo, gone are those days. We have not improved. Less than 30% of our patients are achieving target control. Multiple CGM systems in our country, we still have just a few, many more to come. How to effectively use this data? Yes, standardize the CGM data, which is happening across many CGM platforms. Organizing this in a usable report, which is usually the AGP, which is a software. To remove the confusion from the minds of any of you, AGP is not a different CGM machine. AGP is a software which can be licensed by even a blood glucose meter company or a CGM company to have a software derivation of all the data of their CGM. Analyze this and then use to data to optimize the glucose control. Now, of course, in 2 minutes, I will not be able to explain. These are the TIR targets, so which has time in range, time above range, time below range. We have Bansi here, who's been a part of the international recommendations for TIR and has shown the way and on TIR being an essential tool for everybody with diabetes. This is the AGP report and this is the daily views. The important thing, if you start looking at CGM, remember the mantra of FNIR. What is FNIR? You want your patient's glucose profile to be flat, to be narrow, and to be in range. So that is FNIR. You start getting your patient's FNIR, you're doing a good job. What we see in practice is the fact is that every 5% increase in TIR is clinically beneficial. Even 5% if you improve the time in range. The recommendation is 70% between 70 to 180 for most people. There may be some different targets for the elderly and some for in pregnancy. Let's leave that on the side. Predominantly 70 to 180. 70% time, if you are spending within that, you're doing a good job. Of course, avoiding the hypoglycemia. And you can start seeing the daily spikes as well in this to figure out where patient may be going wrong. Let me quickly focus on some utilities. This is clinical utility of HbA1c enhanced when used as a complement to time in range. So this is patient with the same HbA1c but different time in range. Now obviously, which one would you prefer for your patient? The one on the left or one on the right? Which? Left? Right? Okay, right is always right. So here the time in target is clearly more at 64% as compared to 46. The larger problem here was the patient was having 18% time below range. Second, picking up hypoglycemia trends in different subgroups. Now that's another paper of ours and I'm speaking on that next week completely somewhere. But just to bring out that patient will have an A1C close to 6. There are chances of hypoglycemia 18% and 11%. No rocket science. Very good control, hypoglycemia is possible. But look at this individual, this A1C is close to 9.5, forget the estimated A1C, the actual A1C is close to 9.5, but this patient is having 10% time below range. So he's going into hypoglycemia, huge variability. So high HbA1c does not rule out hypoglycemia unless you do the CGM. This is as a tool to see the impact of lifestyle modification and medication. Same patient, 3 CGMs done. This is in May 2019, 41% in target. This is later in November 2019, 65% in target. And this is October 2020 for the same patient when is improved to 74% with 5% below target. Finally, impact of medication in drug naive patients. Sometimes your patients are extremely afraid to start medicine. I should not go into low sugar. How much is the impact? One other way where you can use CGM. This patient was started on a drug for 14 days when you're doing the CGM. On day 1, how much is the time in target? Only 4%. By the end of day 13, day 14, this patient has gone to 82% time in target. Huge satisfaction for the patient that my doctor has given me the right medicine or I am doing the right thing through diet and exercise. My last 1 minute, sir. Let me end with a case study of a gentleman who's been on a huge dose of insulin, GLP-1, SGLT2, metformin, sulfonylurea, acarbose, जो दे सकते थे सब कुछ दिया है, right? Yet this patient's sugars are on the higher side. Now we did in Libre Pro, we did the blinded CGM. So what did the blinded CGM give us? That the time in target was only 43%, right? So we changed. So this prescription is after seeing this CGM, and this is the CGM. So estimated A1C 8.4, patient is spending huge amount of time above range. So we made the changes for the patient in the insulin dosage, again recounseled. Did it help? It did not help. Patient comes back in May, again the HbA1c is 10%. Okay. Now this is where the patient was then told to get into a freestyle CGM monitoring, and I'm ending my talk on technology saying a lot of us started using blinded CGMs. Blinded CGMs are good, but they do not inspire the patient to change as much as a real-time freestyle CGM does. There's a huge difference. So yes, from cost aspect, freestyle pushes up the cost, but where you struggle in your patients, this patient was spending huge amount of money, right? Insulin, GLP-1, everything. this patient changes to real-time CGM, is of course a little more encouraged to make changes. The real-time CGM shows this patient how each thing that he or she is eating is impacting how their walk is impacted. And see the real-time CGM data as my final slide for the day. What do we see here? We see the estimated A1C, which is also called as GMI in the rest of the world, come down to 6.4%, average glucose at 138. You're getting the TIR targets here as well, 86% in time. We did not make any changes. In fact, this patient is now getting the insulin down. There was nothing more we could have offered this patient except the right monitoring. So monitoring in real-time CGM can be far better than even the therapeutic drug very often in such patients. So do consider where you struggle. My appeal to all of you using CGMs is time to move from the Libre Pros or any professional CGM to open-ended freestyle CGMs, even for your type 2 patients who are struggling. It makes a world of a difference. So with that, let me end the talk and give you the take-homes for use of CGM and TIM for various clinical situations. Thank you and have a wonderful stay here. Thank you.
Thank you, Dr. Manoj Chala, for giving excellent talk on the utility of the digital technology in day-to-day clinical type 2 practice. Now, any questions from the audience?
Yes. Software is there, Bansi. In India, the company doesn't give it to you. Are you seriously telling me that you are not aware? Bansi, are you guys kidding me? So, sorry, I will talk outside. The CGM is, the software is available. Every patient, there's no point of doing freestyle without that, Bansi. So, the software is available. The Abbott company doesn't give it. Off label, the same guy will tell you. I can share the link to you. Every patient who's using your freestyle should get that software. Then only they can download the data. So, all my patients download their data, they keep it with them and they share it with us. I thought you were joking about this. I will share that with you right away. The company doesn't officially give it. Photo. No, sir. All. Yes, Bharat. Bharat has a solution. Right? So GLIMP is right here. GLIMP is GLIMP is a means to read, like GLIMP and Meow Meow and I don't know what not. So these are apps which read through NFC your data. My experience with GLIMP is it's not exactly accurate, right? I think it overreads. So the comparison between GLIMP and the other ones is if GLIMP gives you a 167, when you actually see, you will get 10% lesser, is my observation. It may not always be true. Also, when patients use, so when do patients use GLIMP? You put them on a professional CGM, the cost is lesser, they keep using GLIMP. Sometimes it stops working, the company guy will tell you कि GLIMP use किया इसके लिए बंद हुआ, rubbish, right? It has nothing to do with it. वो कभी it comes off and all, it's a different thing. So GLIMP works. However, GLIMP will give you the value, right? It will give you the graphs. Doesn't give you all the software, this thing, but which is okay for a patient to use that. For a pro, right? But if somebody is using freestyle, unlike what has happened is the software has not yet been gotten approval in India, but which is ridiculous for the company to launch a CGM without the software. So often their guys only will give the software for the patients to use. Uske bagay, there's no point in spending this money. Rutul.
All the CPMs had the same problem. Even the company guy asked that please use our the glucometer and
Still it should.
all the
So the answer to that, Rutul, is every technology has its some limitation, right? Today even SMBG may not be working. Today you will have patients where HbA1c who has no impact because they will show you a high or a low HbA1c which doesn't match their sugar profile. Hypoglycemias being exaggerated was the issue in the beginning with the older sensors. As the sensor generation is improving, this is getting better. With the Libre sensor 3, which has now been approved in the US 2 weeks back and was there in EU, we will still take a while to get. We never got 2. My belief is we'll go directly from 1 to 3. The MAD has come down to 7.5%. Yet in hypoglycemia on day 1 and day 14, you may see a little exaggerated. So what does the ADA or even the ACE say? Where you are doubting it, please verify with your SMBG. As pertaining to your case, there will be one odd individual in whom the interstitial fluid glucose is just not giving you the value. In such an individual, better not to use this technology and stick to the conventional one. But this would be one odd patient. In most of your others, no, I think maybe just try a different CGM for them and see what's happening with the Medtronic one, or even the Eris one, which is now being available on more of a demo mode. Sarka is the brand, right?
Thank you, Dr. Manoj.
Thank you.
I think last questions to you.
Sure.
The problem of offline software versus server-based software of safety of the data, and what is your comment on that?
So I was using an offline software for many years, right? The issue is when you talk about data privacy and ownership, even the offline was then had to have a backup, right? So you use it. Now, how much can you rely on your computer's capability to do that? I lost my data, something went wrong. They could retrieve the data, but last few days could not be retrieved. So I think gone are the days, unless you really have it, you're going to keep taking and the backups and doing that. In that also there is fear. Today largely it's going to be cloud based, right? So it is going to be, and it gives you the advantage, like otherwise you would be still sitting in the clinic and using it. The cloud based ones, you can use that software from your phone. You're sitting here, your patient is in a different city, you can do that. In terms of data privacy and secrecy, that's why I said it all depends on which EMR you're using, what is the agreement, what is the confidentiality clause there, and those are the things that you should read and ensure that that data cannot be shared with anybody, unless you ask for a certain part of the data. And which is where, when you're paying for that software, that understanding happens. When ABC company comes and tells you ki we are giving this to you free, please understand that nothing is free. There will be some catch in that.
Thank you very much.
Thank you.
Now, over to our next talk.
I request Dr. Arpit to give the memento to Dr. Manoj.
Now, the last lectures about the remissions in diabetes field, and for which we have a speaker, Dr. Neeta Deshpande. I would like to invite Dr. Neeta. Is she here? Yeah. So, she is a diabetologist and bariatric physician, and she is MD FRCP and ASPP obesity certified USA. She is having a Belgaum Diabetes Center and Weight Watch Obesity Center, and Professor HOD Medicine Dental College Belgaum, and also Associate Professor Medicine USM KLE International Medical Programs, and have publications of many peer reviews in journals and textbooks, and past chairman of Karnataka RSSDI, and also KS RSSDI Oration 2016, received the RSSDI Fellowship 2016, and also coordinator and consensus group of RSSDI ESI clinical practice recommendation for type 2 diabetes. Over to you, ma'am.
Thank you so much, Chairperson, for the kind introduction. At the outset, a very big thank you to the team of Diabetica 2022 for having invited me to this very, very exotic historic location. I'm so glad to be here. I have come to this part of Gujarat for the first time. Thank you so much. Coming to the topic that has been given to me, it is about diabetes remission in clinical practice, turning dream into reality. So this is a topic that is very close to my heart because I have been doing diabetes remission for my patients for the last 6 to 7 years, and I have data of my own which I'm not going to show you here because I'm going to talk about turning dream into a reality that can come in the question and answer session if at all. So I do not have any disclosures for this particular talk. Now, why is diabetes remission a dream? Why do we call it a dream? The topic that was given is it's a dream, which means maybe it's a myth but what's the reality, and can we really convert it into clinical practice? So why did we think that it is a dream? We think it is a dream. Many people still think it is a dream because historically we have been taught in medical school and even later on that diabetes is a chronic incurable state that can only be controlled but not cured, and that's why remission seems like a dream. The second thing we have been led to believe is that once the beta cells have lost their function, they cannot recover, and hence remission remains a dream. So because of that, many people, even in our own fraternity, think that this cannot happen. If it happens, it's only for a short time. Maybe so, but whether it is for a short or long, is it really possible or not? So the myths, which are like dreams, is once diabetes is diagnosed, beta cell cannot recover, and diabetes is a lifelong disease. It cannot be managed without medication. That is what has been thought. But that has been proven wrong, and I'm going to show that to you in the next couple of slides. When we talk about remission, the core goals of remission are two. Number one is weight loss. Actually, they are interlinked. Without weight loss, you cannot have remission. And the second is improved glycemic control, of course. So these are the two main core goals of remission, and I'm going to take you through to look at the evidence to see whether this can really happen. So the first evidence that ever came out was from bariatric surgery, and that's what I'm going to take you through. Whatever remission or reversal that you are hearing about nowadays is lifestyle modification, but that diabetes remission can occur. The first evidence was from bariatric surgery. So bariatric surgery, what does it do? Basically, bariatric surgery has consistently been shown to dramatically and rapidly improve blood glucose. All of us know that even before weight loss occurs, we know that diabetes remission starts to happen, effectively reversing diabetes in up to 80% of patients, at least in the short term. But I'm going to show you data, not just short term, even of 5 years and 10 years. Importantly, the reason that diabetes starts to remit even before weight loss occurs is that bariatric surgery causes changes in the gastrointestinal hormones such that feeding behavior is influenced, which means that satiety hormones and hunger hormones change in such a way that feeding behavior is changed even before weight loss occurs. Also, we know now that surgery causes dramatic changes in the gut microbiota, which we know are very much involved in obesity as well as diabetes, and it changes the obesogenic environment of the gut microbiota to a lean bacterial population. There is a lot of work that is still ongoing with respect to gut microbiota, and that changes with bariatric surgery. So I'm going to show you just this one slide which talks about 5 years data and 10 years data. When we talk 5 years and 10 years, it is long enough actually, and this is going to show you that it's not just a dream, it is going to be a reality. Now, whether everyone should go for bariatric surgery or not, that question I'm not going to answer. I'm only going to answer the question of whether it is a myth or a dream, or it can be changed into reality. Now, these are, I've just put it in short, 5-year follow-up studies. You have 2 of these studies where sleeve gastrectomy, Roux-en-Y gastric bypass have given you complete or partial remission to the tune of 37% and 45% respectively. And in the Stampede trial, interestingly, they had one arm of medical therapy, that is the IMT, and you can see that at the end of 5 years, at least in this study, it has been 5%. You must understand here that whatever studies have compared bariatric surgery to lifestyle modification they have used intensive lifestyle modification, but they have not used very low calorie diets. That means they have not used VLCDs. So the percentages have to be taken in that respect. 10-year follow-up study. You have a 10-year remission rate of 83% in PORI's data, and in the Swedish obesity studies, that is a 10-year follow-up of Roux-en-Y, At 2 years, it was 72%, and 10 years, 36%. And this is pretty impressive. So there's no question of diabetes remission by bariatric surgery being a dream. It is reality. We have data of 5 years and 10 years that I'm showing you here. Now comes the conclusion of this is that at least in 1/3 of patients, you have long-term remission. Long-term means I'm talking 5 years, 10 years. So at least in 1/3, as you can see here. But more interesting for us as physicians is from the lifestyle modification studies, because we are not going to ask all our patients to go for bariatric surgery. That's very difficult. So when we're talking about lifestyle modification, which is also difficult but probably more attainable than bariatric surgery, what is the evidence that we have? So the evidence that we have is with low calorie diets and very low calorie diets. That is what I'm going to show you. I'm going to tell you the problems first. There is difficulty with long-term maintenance, and we really need to find out what best we can do to have long-term remission when it comes to lifestyle modification. Micronutrient deficiencies, when you use caloric restricted diets for long periods of time, you will have to use supplementation, monitoring, and you have to consider the use of all these supplements. So if you have to compare it, I have shown you data with bariatric surgery. Let us look at the rates when it comes to low calorie diets. The first and foremost that we had, the earliest evidence we have is of the Look Ahead study. And this was a study that was done way back in 2003. Again, please remember, Look Ahead did not use VLCD the way Roy Taylor or the way we are doing it now. It was just intensive lifestyle modification, but not a VLCD. So you had about 5,000 patients. They had two arms. One was intensive lifestyle modification and second was the other group was control. At 1 year, the remission was 11.5, at 2 years 9.2, and at 4 years 7.3. If you recall, 2 slides back I showed you Stampede, again showed you 5-year data of about 5%. So you have 5 to 7% of 5-year data for lifestyle modification. They call it intensive lifestyle modification, but again I reiterate here that it is not VLCD. 2015 to 2017, you had certain other studies, including the Y-weight of Osama Hamdi in Harvard, that is in Joslin, and they assessed short-term remission. But they also had only 4.5% remission because they used a little higher calories, not a VLCD, though they had a robust exercise program. Then came the era of Roy Taylor. You know, he had the Banting lecture and all of that, and he started his studies in around 2011. And if you look at the trajectory of his studies, which is now the basis of most reversal programs, you can see that in 2011 he did an initial 8-week study as proof of concept, which was a 600 calorie VLCD, but 25% had an early recurrence. Not much is talked about this, but 25% did have an early recurrence because it was only proof of concept. So in 2016 there was a larger, longer study. Responders were supposed to be those who had a fasting of less than 126. It was an 8-week VLCD with meal replacements, followed by a 6-month weight maintenance program. And at 6 months, what he found here, interestingly, was that 40% of the initial responders were still in remission. Now, this was encouraging. So, further studies could be taken up. And that is why in 2018, the direct trial was taken up, because in 2016, he found evidence that yes, responders can be put into maintenance and they can still remain in remission. So came the direct study, which, as you know, inclusion criteria was type 2 diabetes of less than 6 years duration, no insulin, and a BMI of more than 27, and it was community based, cluster randomized, and he had about 306 patients, and it was standard of care versus VLCD. So this was not just intensive lifestyle modification, it went further than that, and what you had was a very low calorie diet, 600 to 800 calories for 3 to 5 months, followed by a maintenance period, and then there was a stepwise introduction of food, and then there was a long-term weight maintenance program. So this was a very properly designed remission or reversal kind of program. So diabetes remission was defined as an A1C less than 6.5 with no medication, and look at the remission rates. The remission rates at 1 year were 46 and at second year were 36, so 1/3 of the patients. So at 2 years also there was a good bit of remission. And this is the famous slide that all of you know of the direct trial at the end of 1 year, which has one of the best odds ratio, as you can see here. And what it shows you is more the weight loss, more the chances of remission. So 5%, 10%, 15%. So 15 kg weight loss was supposed to be the optimum at which remission occurred. And this is what has been found in most studies. But in Indian data, what we find, what I have found in my data is that even 10 to 12 kg of weight loss, because our patients are leaner. So 10 to 12 kg weight loss can also bring about remission in most patients if it has been followed diligently with the same kind of a VLCD program. So the summary of evidence for low calorie diets and very low calorie diets is that it is definitely effective in the short term, 2 years, maybe even more. And it is effective predominantly in diabetes less than 6 years or 5 years. But let me tell you that in the Indian scenario, it is possible to remit even with longer duration of diabetes. I'll soon tell you why. There's a substantial level of caloric restriction that is required. Please remember that a standard regular diabetic diet can give you a weight loss of 3 to 5 kgs maximum. If you want reversal or remission, you require far more caloric restriction than what you would do in a simple diabetic diet. Modest weight loss is not effective. 5% weight loss, 10% weight loss, not effective. In the latest ADA, which I had the opportunity to attend in New Orleans, the entire thrust of the conference in various halls was you require 15% weight loss for diabetes remission and better diabetes control, and they were all equating weight loss to diabetes remission and to diabetes control also. Of course, there's difficulty with long-term maintenance. Old habits die hard. Behavioral intervention is most difficult. And there are concerns about deleterious effects on body composition and physiology of severe caloric restrictions, which I don't really believe. It's not my belief. There is a lot of data that I have been seeing, I have been reading over the years where caloric restriction actually prolongs life. That is an anti-aging tool. Caloric restriction is an anti-aging tool, and that is something you need to remember. Micronutrient deficiencies are there even in bariatric surgery. Obviously, they will be there also in caloric restriction, and it has to be dealt with. So, to put it in a nutshell, I already told you that the core goals of reversal or remission are weight loss and improved glycemic control. And this is the summary slide of all of that. So you can see here that you have sleeve, bypass, low calorie diet and low carbohydrate diet. And obviously you can see here that all of them work, but the low carb and low calorie diets, they have a tendency to revert. Whereas the bariatric surgery has got a longer remission, and that is very obvious. So what are the challenges in realizing the dream? The challenges are that it may not be widely applicable to practices with limited resources. Trust me, reversal or remission is not easy. I have an entire team dedicated only for that, and that is how it works. So if resources are limited, it may be difficult. It will need a dedicated, specialized team who understand what is going on, who understand the fundamentals of reversal or remission. Maintenance of weight loss will be the biggest challenge, and we do deal with that in different ways, and that has to be done. Behavioral therapy is often not addressed. It's not just about a VLCD. It is not just about exercise. It is about adherence, and the adherence has to be long term. So behavioral therapy is of utmost importance. Actually, it should have come first. These are the practical aspects of bringing the dream into a reality. And that is that only highly motivated patients can do it. It is your job to motivate them, of course. It has to be done under very close supervision. You have a lot of fly-by-night operators who are doing reversal, who do not closely monitor the patients, and that can be very, very detrimental. It can be catastrophic, and that is why I say it has to be under very close supervision with supplements and frequent follow-up. Choose your patients wisely. It is not for everybody. You must know who not to do it for. It cannot be done for everyone. The choice can be offered, but it cannot be done for everyone, and one must know whom you should not do it for. It is not a permanent diet in the sense that the initial reversal diet that you give is not meant to be continued long term, and the patients have to be weaned off very carefully, very slowly. And while remission may not be the goal in all the patients, reduction of medication, better metabolic parameters and quality of life definitely are. Please remember one thing, that in the quest for remission, the diet and exercise that you put the patient on may not revert the diabetes completely, but it is going to do a world of difference to the metabolism of that patient. And at the end of the day, I have not put up that slide here, you are retarding the vascular age of that patient. Please remember that inflammation, oxidative damage, these are all the things that accompany diabetes and obesity, and those are the things that are going to come down with a reversal kind of a diet. Even if the diabetes does not remit completely, you are retarding all those metabolic parameters, because of which you can retard the vascular age. And what's your goal ultimately in diabetes? Your goal is to prevent cardiovascular disease, because that is the biggest killer in most of our patients. So my views on this are that interventions aimed at reversal are not yet, I'm saying not yet, first line standard of care therapy in any guidelines. Nobody talks about this as the primary goal. But what we do know is that standard of care does not lead to remission. You have to do something much more. The current standard of care may be suitable for some, but others would surely choose remission if they understood that there was a choice. It's our duty to give them that choice. Therefore, it must be offered to them. Those who keep the weight off manage to keep the diabetes reversed. The second thing that I have seen, and many of my colleagues also have seen, is that in the Indian scenario, even patients with longer duration on insulin therapy, lower BMI, they can attempt reversal on account of high carbohydrate Indian diet. Some degree of reversal of remission always occurs, and I have data to show you insulin stoppage. I don't have it here because of time shortage, but I have data for insulin stoppage, medication stoppage, even in patients who were on insulin, patients who were on multiple drugs, patients who were leaner, not with a BMI, very high BMI, even patients who were leaner, and patients with diabetes duration of even 15 to 18 years, going down all the way from insulin of 80 units down to 10 units or even 0. So that has also been seen. So that's why I say that it is not just a dream, it is reality, but you have to work hard at it. As physicians, we have to work hard at it. The ones who regularly follow up are the ones who stay reversed. Those who don't follow up, they relapse. As a rule, we have seen it. They don't follow up, they relapse. Proper patient education, optimal support for long-term behavioral change has to be given. So this is my final slide. Myth versus truth. Dream versus reality depends on this. It depends on your healthcare team. It depends on what patient you choose, how safely you are doing it, the quality of your care, your operational performance, all of that. You have to, at the end of the day, have the right patient, the right place, and the right time. And then only we can say that remission of diabetes can be not just a dream, but actually reality. Thank you for your attention.
Thank you, Dr. Neeta ma'am, for giving excellent talk on the diabetes remissions. I have one question regarding the very low calorie diet or low carbs. So what are the options in Indians perspective, because we use most of the times wheat and the rice in our food.
Yes.
So what options you offering to your patients to put in on the low carbs or zero carbs diet? So are you using some available preparations in the markets, because that is going to be very costly. It's not be practical to use each and every patient.
Right.
And second question in connection to that,
off-label uses of any drugs along with this very low-calorie diet or the low carbs,
Yeah.
like use of Voglibos with some high carbs meals or use of metformin with some high carbs meals, though patient is not diabetic, but just obesity perspective.
Right. So there are actually many questions rolled into one, and I can actually take a whole lecture on this, but no, don't worry, I'm not going to do that. So the first question that he asked was that when we talk about very low calorie diets and low carb diets, how can we do this in the Indian scenario? First of all, when you use a VLCD of 600 to 800 calories, it's not possible, even if the person is eating non-veg and is a predominant, non-vegetarian eater. It is wise, and there is data. This is not what I'm saying. There is data to say that when you use a VLCD, you must use meal replacements. You cannot use a VLCD with the regular natural home food. That just cannot be done because the nutritional needs are simply not going to be met. If you want to give natural food from the house, you cannot go lower than 1200 calories. Then that does not become a VLCD. So that is number one. But to answer your question, once the patient goes into a maintenance phase, then yes, there is a role of using home food for low carb. So there are many options. A good nutritionist will be able to do this very well, like reducing the amount of grain, increasing the amount of vegetables, including nuts, seeds, etc. So there are plenty of vegetarian options. We just have to change the way we think and eat. So that is number two. We do not do zero carb. I have not used keto diets for remission. So that there are people who have used it. Sarah Halberg is the one who has got the largest data for use of keto diets for the remission of diabetes, but I have personally not used keto diets for I've used keto diets, but not with remission. So that was the second. Third thing, you asked about the drugs. I have not used Voglibos, whether diabetic or non-diabetic, for remission, no. But in the maintenance phase, I have begun to use in recent times for many patients, especially if they are diabetic, GLP-1 receptor agonists. So I have been using that, and it's a good maintenance therapy. So before I end my talk or this question, let me tell you that this time in the ADA, there was a extremely interesting talk. If you can get the recording, you must hear it, about Julio Rosenstock. He spoke about why do we insist that a person, when he remits his diabetes, why should he be off all treatment? And he gave a fantastic example in oncology. In oncology, when you say that a patient is in remission, you do in many cases keep a maintenance therapy. You do or you do not, you do. So even diabetes is a chronic disease. So why do we insist that everything should be zero, HbA1c should be less than 6.5? So why not have a maintenance therapy in the form of, say, a semaglutide or a tirzepatide or even metformin? So as a maintenance therapy after you have achieved remission. So there is no need to say that. So that is the other thing. So yes, off-label GLP-1 receptor agonists, etc. have been used. I do use also myself in patients who have been very obese and who find it difficult to adhere to behavioral therapy. Thank you. Yeah. Yes. Yes, there is enough data. If there is extreme obesity, of course the way to go would be bariatric surgery, because it is simply not tenable. It depends on the amount of weight loss you need. The best results are with Roux-en-Y, but of course it comes with its problems, and that's why the next best is sleeve gastrectomy. So sleeve gastrectomy gives you slightly lesser weight loss, but then you're not changing the anatomy there. And because you're not changing the anatomy, many of the problems with Roux-en-Y, the dumping syndrome, the malnutrition, etc., is not seen with sleeve gastrectomy. So when the deficit, the amount of weight to be lost, if it is in the range of say 30 kgs, 35 kgs, sleeve gastrectomy works just as well, and even its long-term data is quite good. Roux-en-Y gives you even more. That yeah, so that's why I showed you. I showed you just two very pertinent data: 5 years and 10 years with bariatric surgery. So that is what it is. Yeah. Yeah. I will call them. I will call them partial remission, because I do not believe that partial remission goes on that A1C. You know, the definitions which were, and those definitions are in a flux. Nobody believes those definitions anymore. So they, for me, they have reversed. Not reversed completely. See, for me, remission is, that's why I said the definitions of remission and reversal are very, very fluid, and we must accept that a lot of, see, we are talking about treating pre-diabetes with metformin today. And a person who has already been diabetes, you want him to go off therapy, it's a dream. Yeah. Yes. Remission in?
You are no more on a medication, or you are for a long term without any medication and keeping your
Yes.
HbA1c less than even 5.7. The criteria which was given by Dr. Roy Taylor and his team was less than 6.5
Yes.
without a medication, which he
Correct.
has done
Yes.
for some of his patients and tried to call it the reversal of diabetes. Well, again, we call it less than 6.5, means pre-diabetes.
Pre-diabetic
It is not
stage.
5.7.
Yeah.
We know there are three types of drugs which are there, like insulin sensitizer are there, insulin enhancer, which is like GLP based therapy and sulfonylurea. Then you have sugar excreter, which is like SGLT2, and sugar absorption, which can be inhibited by the medication alpha glucoside inhibitor. So if you have a patient who is already on an insulin
Yeah.
or on premix insulin, if you are reversing that patient, whatever the stage of diabetes he is, and if you can come out up to the stage of when he is no more on sulfonylurea or GLP-1
Insulin.
or on insulin enhancer, I mean now he is only on SGLT2, on metformin, and only on like AGI, then you can say that at least you had come out with the stage 1, because he
Yes.
was before that he was on insulin enhancer or he was on insulin. The stage 2, when we have decided, I mean, he was already on previously on whatever the medication. Now you have stopped even SGLT2 and alpha glucosidase inhibitor also. Now patient is only on insulin sensitizer. So you are the patient who was on multiple oral anti-diabetic agents and plus insulin. The stage 3, when you stop even insulin sensitizer also, and keeping the patient HbA1c less than 5.7. When you are stopping the patients even on insulin sensitizer and keeping HbA1c less than 5.7, then we call it a prolonged remission or patient is in remission stage. So in the 3 stages we divided the patient. So it means any type 2 diabetic patients, whatever the therapy when you are giving, a remission or a reversal we should also use as a part of therapy and try to give a medication, along with medication, a diet or nutrition in such a way that you can reduce the medication and you
Absolutely.
can reduce the A1C to the level below 6.5 without hypoglycemia.
Exactly.
And that what should be our
That is exactly, you have reiterated my point.
Roy Taylor has done when he has started all his patients. He stopped
Everything.
from day 1
Yeah.
by giving a patient only a 600, 700, 800, which is not acceptable. That too for 3 months only on a replacement formula. That was again not acceptable. And he stopped even anti-hypertensive drug also at the time of starting this reversal program. So this is something, and that's the reason probably 1/3 of his patients could achieve only after 2 years remission but 2/3 of the patients could not have the remission.
That's because of his stringent definitions which he had put for himself. It is, as far as Roy Taylor is concerned, I think it is still an evolving science that we are looking at. The science of remission is still evolving. So what he talked about as less than 6.5, no therapy, we have come a long way from that, and we are talking about giving maintenance therapy. So it is still evolving. As far as I am concerned, I would not conform to the theory of stages of reversal, for the simple reason that it is a continuum. It is a continuum. One tablet here and one tablet there, extra or less. So these are the, if you want to be very go into semantics and call them stage wise just to slot them, that is okay. But if you look at it as a,
it gives the patient also a sort of a motivation.
Yes,
Like,
yes.
I was on X, Y, Z medication. Now I had come to the X.
Absolutely,
Y,
absolutely.
So you know you are going from the X, Y, Z to
Yeah.
only X. So that gives you a motivation.
That gives the motivation,
Then
and
the patient will come again after 3
Yeah.
months. Then now I am X minus also, and now again I am getting the X also going away. So that's how in next 9
yeah.
months.
So as they see their tablets and insulin going down, obviously that itself is a motivation. Their antihypertensives start to go down completely, and their musculoskeletal system also starts to respond better. They can walk, they can do so many things. So we have all that data also about, how their life has changed and things like that. So that is why I said, we should not stick to that definition of remission of 6.5 or 5.7. We need to see how far back they can go. That means you put the car in the reverse gear. How far back it will go, we don't know, but it is still going back. So that is what is important. The reversing the process is important. How far you will go, that is okay. That does not matter. But the initiation of that process itself, as I said at the end of the day, it is you are retarding vascular age. That is the most important. Whatever stage you're bringing them at, you are ultimately reducing inflammation in their body by reducing some amount of weight, by getting them to eat right, by getting them to eat less carbohydrate. So it is basically retarding vascular age. That is what I would say, and increasing longevity.
Okay, thank you very much, Dr. Nita.
I know I've overshot the time.
Okay.
We have now clinical remission going stage by stage, stage 2, stage 3. I think we should be doing all these things. My very simple question is, instead of HbA1c, if I subject the patient has come to 5.7 or 6.5, okay, 5.7 of that, instead of HbA1c, if I go for oral glucose tolerance test, what will happen to this patient?
What will happen in the sense, what will be the...
In my opinion,
After remission, see,
We don't know. We need to see that.
Very specifically, the first phase of insulin secretion comes back, and that's the reason he called it word reversal. The word which he had used, reversal, was because the first pathophysiological defect which occurs in type 2 diabetes is the first phase of insulin secretion goes away. So when you reverse the patient, again by giving them a OGTT, the first phase of insulin secretion comes back, and that's the reason he used the word the reversal and remission.
so I think the simple line between reversal and remission is OGTT and not HbA1c.
Yes. So it was that.
okay. Okay, thank you very much.
The worry is it's good to discuss and find out the new method, but don't try to apply the idea of patients, like trying to bring it down to 5.7 and do the surgery. You don't need to bring anybody's HbA1c to 5.7. So people are living happily with 6.4. Otherwise, okay. Why
5.7, it is not that. I mean, somebody who can. No. Why you want to? It is not diabetes. It is not diabetes. 8. Let me be happy with 6.5.
So in the very beginning of my talk, I have said that we have naysayers in our own fraternity, and you can see it here. But it's a matter of debate. Absolutely.
I think controversies will remain remission. So I thank
you
Dr.
very much
Nita
for very healthy
and
discussion. Dr. Desai.
Yeah, Dr. Jitendra, please present the memento to our speaker. Thank you. Dr. Jitendra Nagar, can you give the memento to both of our chairpersons? But the same is inside, don't worry. Dr. Arpit, thank you. So we move on to the next session, and session 3. The chairpersons for this session are Dr. Bhumi Dave from Rajkot and Dr. Kishore Sheth from Bhavnagar. Okay, they can take over the sessions. We have 2 lectures already. One lecture on diabetes and thyroid disorders was in the morning by Dr. Rakesh Sahai. So here we have only 2 lectures, DM and dyslipidemia, and how can we save the feet in diabetes patients.
Thank you very much, the organizers of Diabetica 2022, for inviting us as these chairpersons. And I would invite our speaker, Dr. Professor L. Srinivas Murthy. He is MD, FRCP, and Senior Consultant Physician and Diabetologist at present at Bangalore. Over 2 decades of his experience in both undergraduate and postgraduate teaching. And he is principal investigator in over 75 clinical trials and in part of landmark trials for Hope 3 Clarify.
I think we are running 1 hour late. It's
Yeah.
okay.
So
Bansi sir has promised me not to give dinner if I don't finish in 15 minutes.
No, he will
So I
definitely
don't want to
give.
lose 1 minute here.
Yeah. So I would
I don't want
invite
to lose
him
1 minute
to give his talk.
Thank you, ma'am. Thank you. So, good evening, all. And post lunch, I understand, but this is one of the important consensus which I was also part of. And any questions on this, you can ask Bansi sir and Vasant sir who are sitting here, including Sunil Gupta sir and Vijay Vishwanathan. All of them are part of this consensus. So, no questions to be asked to me. That's a disclaimer. So, dyslipidemia plays a key role in inducing CVD in both in type 1 and type 2 diabetics, and the lipid profile in type 1 diabetics with good glycemic control is quite identical to that of the general population. That's because the lipoprotein lipase gets activated because of the external insulin supplement, and that's how the VLDL and triglycerides gets neutralized, and that's how it's equivalent to general population in type 1. But in type 2, even with a very good glycemic control, you see the lipid abnormalities quite often. I think it's one of the commonest comorbidities we see. And this is the prevalence of dyslipidemia in diabetics in the Indian context, what we are talking about. 2010 cross-sectional retrospective analysis, diabetics in India recorded a prevalence of 85% in males and 97.8% in the females. And the large-scale ICMR India study, which conducted involved 16,000 plus adults, increased risk of hypercholesterolemia, hypertriglyceridemia, and high LDLC in those with dysglycemia. Look at the prevalence, and the epidemiological cross-sectional study, which is called as a solid study, which looked at people who are already on the statin therapy, out of which only 48% were well controlled, and that's a very disheartening number. And another recent cross-sectional study by Daikar et al. Reported that the incidence of occurrence of hypercholesterolemia to be 58% and that of hypertriglyceridemia to be 36% in diabetic adults. And of course, this is the causes of dyslipidemia which has been alluded in this consensus statement: primary and secondary. Secondary, basically lifestyle related and comorbid conditions like diabetes, liver disease, chronic renal failure, cigarette smoking, tobacco in any form. You should warn your patients to get rid of it whenever you see the dyslipidemia as a comorbidity. And of course, drugs, steroids, whenever we look at the dyslipidemia. Now, the need for screening is very important because people with diabetes, especially the type 2, what we see in major chunk, are at high risk of vascular events, and as a result, regardless of other risk factors on the history or physical examination, they have to be screened for dyslipidemia for sure. In diabetics type 1, it is advised from the age of 12 years onwards, but ISPAT advises 11 years. And known case of family history of hypercholesterolemia, early CVD in the family history, or family history is unknown, then screening should begin at the age of 2 years in these set of patients, and if results are within normal limits, screening should be done every 5 years. In the absence of ASCVD risk factors, middle-aged individuals should be screened for dyslipidemia at least once every 1 to 2 years. Annual screening for dyslipidemia is recommended for older subjects with 0 to 1 ASCVD risk factors, and our recent RSSDI guidelines advocates simultaneous screening and treatment of modifiable risk factors of CVD like dyslipidemia, hypertension, alcohol consumption, smoking in patients with pre-diabetics also. That's very, very important statement. Even in pre-diabetics, we are advising simultaneous screening and treatment for these modifiable risk factors. And in diabetics, dyslipidemia should be assessed at diagnosis and every yearly. Periodical screening for dyslipidemia is recommended in overweight or obese children with family history of type 2 diabetes, or those from a predisposed race and ethnicity like Asian Indians. Now, this is a very important practical slide which talks about the differentiation between the fasting and non-fasting sampling, because most of us are busy practitioners. People come from outskirts of your city. They cannot come back 2 times, 3 times to show the results, and they come tomorrow for fasting, etc. So look at the very clear definitions of fasting and non-fasting. The non-fasting is something which is very practical, reduces the patient barrier, increases convenience and compliance of the patient, so that with the same sitting you can finish and consult them. It definitely decreases the strain on the lab facilities also. Who are the patients whom we should look at? The non-fasting. The preferred in patients with diabetes due to increased risk of hypoglycemia with fasting people who are on SUs and insulins, elderly. And of course, it detects the plasma lipid levels of both atherogenic lipoproteins of hepatic descent and those originating from the intestine. That's very important statement. Except the triglycerides, all the other things, components of your lipid profile are not affected by your fasting state. And of course, the LDL cholesterol can be precisely assessed using modern techniques. That depends on, of course, the lab. And this is a very important tool to assess. And of course, who are the fasting compulsorily you need to look at when the non-fasting triglycerides is more than 440. And of course, to be considered fasting sampling when after 2 to 4 weeks, when non-fasting triglycerides is more than 200. If somebody in non-fasting state, you find a TG of more than 200, ask them to come back after about 4 weeks and repeat in the fasting state. That is the only condition where you should look at. Otherwise, in most of the settings, you can do the non-fasting estimation. And this is what you should know in clinically, that cutoff points for the lipids in the fasting and non-fasting. If you look at fasting and non-fasting, the only difference you can notice is about your triglycerides, which is 175 versus 150. Fasting, you should have 150 and here it is 175. You can look at all the other parameters except the non-HDL, which is 150 and 145 respectively. All the other parameters do not alter in the non-fasting state. So that is why it is very convenient, easy for you to estimate in the non-fasting state. And of course, the non-HDLC, which is nothing but total cholesterol minus your HDL, includes all the circulating atherogenic lipoprotein molecules, and therefore it's an accurate predictor of ASCVD, and that is why the Lipid Association of India has recommended as a co-primary target along with your LDL. And monitoring of this non-HDL-C will provide a simple practical tool for treatment decisions relating to lipid lowering therapy, since it does not require fasting blood sample and it takes care of both LDL and TG components. In all individuals, the non-HDL should be kept within 30 milligrams of the LDL cutoff. Now let us look at the assessment tools. This is all the various risk scoring systems we have provided in our consensus statement, but the QRISK 3 is one which is highly recommended because it takes the ethnicity into consideration. All the other things do not take the ethnicity into. So lack of time, we will not get into that. But the calcium scoring is another one which we have recommended, coronary calcium scoring in the National Lipid Association. And this is the population which we see mostly 40 to 75 years, where the LDL target and the moderate or high intensity statin is indicated regardless of the CAC scoring whenever you see these numbers at this age with a diabetes background. And of course, the ASCVD risk categories and treatment goals for dyslipidemia and diabetics. Look at the definition of high risk, very high risk and extreme high risk. This is a very, again, a practical point in our busy routine clinical practices, where diabetes with no other risk factor, you call them still a high risk. There is nobody called low risk in our practice in diabetes background, and very high risk is diabetes with more than one major risk factor for ASCVD. I'm sure 90% of our patients in OPD fall into this category of very high risk, because most of them are with more than one ASCVD risk factor. And of course, look at the targets. So we'll concentrate on this very high risk group: LDL less than 7, non-HDL 100 and 80 and 150, triglycerides 150, non-HDL and 70 of LDL. If you target these, I think most of our patients are well managed. Now, the category stratification, after that, obviously we need to set the treatment goals and what is the kind of treatment. Now, before getting into that, now in diabetic patients, the cardiovascular risk categories, which is applicable to Indian context, is most of them, as I said just previously, high risk patients with a long standing diabetes, especially with other CV risk factors or one target organ damage. And that's what I said, we see 90% of our patients fall into this category. Moderately high risk patients with recent onset diabetes, no other major cardiovascular risk factor, no evidence of target organ damage. Again, we seldom find this in our routine clinical practice. And in recent expert consensus statement on dyslipidemia by the Lipid Association of India, it stratifies Indian patients with diabetes as either high risk or very high risk or extremely high risk. So there is no way you can consider a walk-in diabetic into your clinic. Even without examination, you can blindly say this guy is going to be on a high risk category, not at least not without any risk. Now what do you do with this? High risk, very high risk and extremely high risk. You can see three categories there, and what is the target LDL you need to look at is 70, 50 and 30. Look at this, diabetes with coronary artery disease and other major ASCVD risk factors, you can reach up to 30. Of course, controversial, but still this is what the recommendation says. But most of our patients, as I said earlier, are in the very high risk group, wherein you need to look at them at least below 70. So how do you manage them? Non-pharmacological therapy, again, the least given importance by all of us in our routine OPD practice, the physical activity, yoga, sleep, MNT. And all of us go towards the right hand because most of our patients do not oblige with the lifestyle modifications. So look at the evidence for the physical activity. It has been linked with glucose intolerance, hypertension, waist circumference, obesity, as well as dyslipidemia. There are explicit improvements in lipid levels with regular exercise, and constant reinforcement for regular exercise, physical activity is recommended in non-adherent individuals. And of course, a meta-analysis clearly showed that a progressive resistant training even in elderly patients will give rise to a lot of benefits with respect to the lipid abnormalities. MNT, of course, carbs, fats and proteins, we discussed about reversal, which is almost not possible in our routine practice. As Vasant sir was alluding earlier, it is not the target which is 5.6, it is a good control what we should aim at in our routine practice. And again, MNT, most of our patients may not be affordable for this. So again, it falls back on us. It is purely on us that how do you modify a given patient, and each patient has to be individualized, managed. But the global clinical practice guidelines in diabetics from the ADA, IDF, AS, etc. talk about the significance of incorporating MNT. The goals of MNT are to endorse and support healthful eating patterns, accentuating the assortment of nutrient-dense foods in appropriate portion sizes in order to improve overall health. That's our goal. Of course, this can be achieved even without MNT if we spend time enough with our patients. Now, we know the statins, high intensity, moderate intensity. You can see 40 to 80, 20 to 40, Atarva and Rosua, respectively. And of course, there are other statins also. This is what we should know when to use high intensity and low intensity. And based on the stratification, again, less than 40 years, above 40 years, you can see there the risk factors. How do you stratify moderate, and somebody is above 40 years, as I said, 40 to 75 years is the major chunk of patients what we see in our routine practice, and most of them fall into the high risk category, and this is how you manage. So atorvastatin 10 to 20 or rosuvastatin 5 to 10 in most of the patients would suffice irrespective of this categorization. Of course, statin intolerance, all of you know that various symptoms which are highlighted on the third paragraph there, muscular pains, weakness, cramps, stiffness, etc. And in such scenarios, the smaller statin doses are a less potent statins with lower incidence of myopathy, which is pitavastatin. A lot of evidence is there for that, that can be used. And of course, in high risk patients who are intolerant to statins, an amalgamation of lifestyle measures and non-statin drug can be tried. And of course, there is a diverse statin based approaches suggested to manage these muscle symptoms, including moving to another statin, down titrating, weekly, alternate days, etc. And of course, in order to achieve this LDLC goal with minimal or no muscle complaints, if well tolerated, doses can be slowly up titrated in case by case basis. And if statins are not at all tolerated, other lipid lowering agents as monotherapy are added to the maximum tolerated statins. And this is bempedoic acid is one other new one which has come up, which seems to be safe, effective oral therapeutic option for lipid lowering, of course, in addition to your statins. And PCSK9, again, cost is another constraint in our country, but treatment with these inhibitors have definitely induced analogous relative reductions in the cardiovascular risk, and aggressive lowering of LDLC with human PCSK monoclonal antibodies has been established with a very favorable safety profile. That's something good, except the cost. Otherwise, this is an addition to your statin. And few words about triglycerides. In patients with ASCVD, diabetes, multiple risk factors with TG more than 150, you can use the icosapent ethyl, may provide additional risk reduction. And if TG is more than 500, it is prior to consider a fibrate or other non-statin drug, a statin with or without ezetimibe. All these permutations, combinations can be tried, but it has to be along with a statin. You have to add on something. Even intolerant patients, omega-3 fatty acids can be tried. Fibrates, we know the diabetic dyslipidemia, typically the high TG and low HDL. A meta-analysis of more than 11,000 patients have been clearly showed fibrates significantly reduce the risk of non-fatal MI by 21%. But the overall mortality was not there. Still the controversy is ongoing. But I strongly believe in our Indian context, high TG, low HDL, fibrates definitely have got a role. And that's the field study. Even in ACCARD study, the lipid lowering arm, it has clearly shown the benefits in the reduction of this MI. Saraglitazar is another molecule which has come up. We know the agonist activity of PPR alpha and gamma, and it is a decent drug when you use it for a particular set of patients. I don't recommend this to everybody, but the long-time real-world evidences are there of more than a year, 5,000 patients, and they're doing a lot of trials even in the US. Omega-3 fatty acids, it lacks clinically significant drug interaction, so one of the alternative only we use it whenever there is a statin intolerance. But of course, 2021 Canadian Cardiovascular Society guidelines strongly recommended the use of IPA to reduce CV events with more than one risk factors. Special populations, I'll take another 2 minutes, ma'am. I have 1 more minute left. So, type 1 diabetes, statins are recommended first line therapy in patients with type 1s when they are at very high or high risk, above 11 years or 12 years. That is a recommendation. And of course, the recommended lipid goals for these guys in type 1 will be LDL less than 100, HDL more than 35, TG less than 150. A statin may be considered after the age of 10 years. This is our consensus statement. In cases where despite lifestyle changes and MNT, LDL more than 160 or LDLC more than 130 along with more than one CVD risk factor, you need to initiate. Fibrates are recommended when the fasting TG is more than 400 and non-fasting is more than 1000. Pregnancy, of course, we know none of the statin therapy is recommended. But however, for severe familial hypertriglyceridemia or hyperlipidemias, bile acid sequestrant, which are basically not absorbed but lot of GI side effects, the LDL apheresis is another option which is there. Monitoring is recommended every trimester. And of course, in the elderly, you need to look at there's no harm in initiating above 75 years. In fact, the guidelines are told people with above 75 years can be initiated as a primary prevention. And in cases of substantial renal impairment or a potential drug-to-drug interaction, statin therapy should be initiated at a low dose and later up titrated to attain LDL-C goal. The EHA guidelines advocate continuation of statin therapy in those above 75 years with diabetes and already on statin therapy. And it has not been associated with any clinically substantial decline in renal function. You need not panic about that. And of course, there are live study, which is a Japanese study, which demonstrated improvement in the A1C in individuals with diabetics post long-term pitavastatin treatment, and there is an upturn of the EGFR also. But of course, we need not take that seriously. But pitavastatin is a underused molecule in our country, but in Japanese they use a lot. And a recent meta-analysis also showed that atorvastatin and rosuvastatin improve GFR, and compared to rosuvastatin, atorvastatin was more effective in reducing the proteinuria. So it has got a plus. And in renal impairment, again, we need not worry about this. Most of them in severe can be used. And hepatic impairment, again, NAFLD is one of the comorbidities commonly seen by atherogenic dyslipidemia associated. And the underlying disturbances, which includes activation of the hepatic de novo lipogenesis, hepatic overproduction of large TG, and very low LDL is something which happens with the NAFLD. And mild ALT alteration is observed in 0.5 to 2% of the patients with statins. Guidelines no longer recommend routine ALT monitoring. So you need not monitor LFT. A lot of patients might come and ask you for that. Don't worry about that. US FDA concluded that statins as a class do not negatively impact the liver, and liver monitoring hence is not required. So don't waste money on that. Thank you very much, ma'am, for patient hearing, and any questions I'll be very happy to answer. Sorry, I had to rush. I just kept up my time, sir. So my dinner is available.
Ahmedabad to Mumbai bullet train.
Thank you, sir.
I have only one question.
Sir.
You should target more as a number than less than 50, less than 70, or less than 80, or less than 100, and mild, moderate, and severe, or very severe risk. Or we should decide from the baseline how much should be reduced, more than 30%, more than 30%, and they should be kept between still and healthy, should be normal. So whichever is better, because that is take home message, I think. Most of the time what happens, the patient will come with a baseline LDL of 110. With mild risk, patients are given 10 milligram of statin, and if they reduce to 95 or 98 next LDL cholesterol, most of the doctors, they don't uptitrate the treatment. While for even mild to moderate risk also, it should be reduced more than 30% of a baseline. So that is what required. So if somebody is coming with a 112 LDL cholesterol, the reduction in LDL cholesterol should be 33 milligram, not just 5 milligram. So that's a very important message, and I think which we had included in our guideline, both by RSSDA as well as by Lipid Association of India. But that is very important message, which I think.
Yes, sir. That was based upon the ADA, HA, what Bansi sir was talking about. Mild category, you target 30% lower than what is the baseline entry level when the patient comes to you. High risk category, 50% less than. That is another way of approaching it. But patients may not, the physicians may not remember about the 50% target, all that. It's a mathematical issue which many in busy practice, because we don't document in our routine prescriptions what is his baseline when he comes for the next month, 3 months or 6 months down the line. That is why this is more handy in clinical practice than telling 50%, because the patient comes to me after 2 years, I don't remember his baseline A1C, and patients do not.
There is one more disadvantage of putting the number.
Yes, sir.
What happens, the high dose statin or moderate dose statin is given not just for lipid lowering. It is the other benefits which we are looking for. It's an anti-inflammatory effect of the statin. So what happens, suppose you achieve less than 70. Let us understand you have a patient which is post angioplasty and a cardiologist wants it to be less than 70 or less than 55. With a 40 milligram of statin has been started, what happens after some time, as patient LDL is still less than 70 or maybe 60, the doctor tries to reduce the dose from 40 to 20. Still the LDL is less than 70, tries to reduce the dose from 20 to 10. Still it is the same, the dose is, the LDL cholesterol is maintaining. Patient tries to reduce further dose of the medication, or the doctor also tries to reduce. And it goes with the 5 milligram of atorvastatin is available in our country, and prescriptions are written like this, that 5 milligram of alternate day atorvastatin is given to the patient. And that should
Maintenance, that's a maintenance.
There is of no use. It is not the LDL target for which the statin is being given. This patient, the LDL is not the target, it is the effect as an anti-inflammatory. That is what the claim. And for that it is not being given. So that's the result.
Sir, but
the baseline LDL cholesterol, if a busy clinician is not writing, they should write. That is also very important. When the statin was started, you please write what was the baseline LDL cholesterol, and from there you have to reduce it.
Sir, but I have a question. How long will you use this high intensity statin in a given patient? Say with a post-stented.
It's a high severe risk. Patient should be given lifelong.
Lifelong. That is a message we should give them. Yeah.
Even lipid lowering agent, and giving a lipid lowering agent is the most easy thing in a diabetic patient. But it's still more than 2/3 of the patient not achieve the LDL target.
Unless the severe is changes by weight loss, blood pressure loss, etc. Otherwise,
Which is seldom happens in the practice, sir. Again, patients don't change their lifestyle at all.
They again get the
Cardiovascular.
Thank you. Thank you, Dr. Sriman.
Thank you, sir.
We to hand over the matter to us.
It was an excellent presentation by Dr. Srinivasa on lipid management. Now I would like to invite Dr. Vijay Viswanathan. The topic is how can we save the feet in diabetic patients? All of us know Dr. Vijay Viswanathan very well. He is head and chief diabetologist at MB Hospital for Diabetes and Professor M. Viswanathan Diabetes Research Center, Chennai. He is president of Diabetic Foot International, based in Belgium, and he is national vice president of RSSDI. He has developed specialty of diabetic foot care in India by training over 2,000 physicians in the prevention of amputation. He has done PhD in diabetic nephropathy and published 50 research papers in this field. He has published more than 150 original research papers in diabetic foot. Over to Dr. Vijay Viswanathan.
Thank you, sir. I'll take 10 minutes only to finish because the inauguration is going to start in 10 minutes. With my pranams to the President of RSDA, Dr. Vasant Kumar, and Dr. Kishore Sheth and Madam, I'll take only 10 minutes to talk to you and give you some concrete examples of how to save the feet of people with diabetic foot. Now, this is a patient who came to us last month with absolute gangrene, no blood supply of the calcaneum. And you can see that the calcaneum is completely necrotic. And this patient was advised balloon amputation in 2 or 3 hospitals. Now, it's very difficult to revascularize the limb, but we did revascularize the limb. We put a balloon into the anterior tibial artery and the tibioperoneal trunk. We got good blood supply, and then wound debridement was done, and negative pressure wound therapy was done, and the wound was healed. And then you put a skin graft and send the patient home. So this is how we save the feet of people with diabetes. And diabetic foot, as you know, is associated with a lot of comorbidities. You can have acute kidney injury, the creatinine can be high. It will come down after you amputate or debride the wound. There is a very high direct indirect cost. There is a very potential danger of amputation, and you can die. As we have shown in studies comparing people with Bangladesh and Tanzania and India, that they don't live up to more than 3 years after you remove the leg. Therefore, you are decreasing the life expectancy. This was a published study in JAPI in 2011, where we looked at what are the causes of amputation of people in diabetes. And you will be surprised to note this was a study which we did from 31 diabetologists across the country. And we found that the most common cause of amputation was infection, on top of insensate feet or diabetic neuropathy, which is preventable. Peripheral arterial disease, like the picture I showed you, is difficult. But this is something which is totally avoidable. Therefore, in the next 12 minutes or 10 minutes, let me talk to you on how we can avoid amputation in India. So this was a study which we published in the IDF. This was called IDF Bulletin at that time. There is no IDF Bulletin now. In 1997, and we showed that socio-cultural practices in India, the commonest cause of amputation is socio-cultural practice. Either you walk barefoot. In my state of Tamil Nadu, people walk barefoot right, left, and center. Walking barefoot in a temple or in a mosque happens in India. People walk barefoot on the streets in my state, in the house in my state. So you can't educate them, because they'll say there's picture of God and goddesses. I can't walk with footwear inside my house. So this is my state. But this is what we physicians, so this is the most important slide of my presentation. This was an algorithm from the King's College by Mike Edmonds and late Ali Foster, who gave us this criteria that you have to identify the high risk feet, and that's exactly what the RSSDI is going to do from July 9th, July 10th to August 10th. We are going to have this campaign of save your feet and keep walking campaign, and this is what we are trying to do. We diabetologists or we physicians must diagnose people with LOPS, loss of protective sensation, LOPS. And in this campaign, which RSSD is going to do from July 10th to August 10th, we are going to make 1 lakh diabetologists or 1 lakh patients being examined by diabetologists across the country by RSSDI. So this is what we are going to do. In stage 2, you have a high risk feet, and that's a stage in which you do all your prevention. There's no point in trying to prevent something when you saw the first picture, no blood supply and nothing can be done. Now, do we need expensive gadgets? No. In the RSSDI campaign, we are going to use only the monofilament, and we are going to examine 1 lakh people's feet in this campaign using one device called the monofilament, which is a 10-gram monofilament. You can do a clinical exam, you have history taking, you can do it in 3 minutes. So that's what you're going to do in the campaign, 3-minute foot examination of everybody, 1 lakh patients, 100,000, there's no 1 lakh it seems in English literature. So it's 100,000 patients we are going to screen in 1 month. And this is again reiterate the point that you don't need expensive gadgets to make a diagnosis of at-risk feet. This is from Andrew Bolton and Carolyn Abbott's paper in from Manchester, where you just need a 128 hertz tuning fork. You need a temperature to be tested with ice water or warm water, pinprick, and an ankle jerk. And if your ankle jerk is absent, you give straight away 2 points here. Here, if you don't have pinprick sensation and temperature, you put 1 in each. So totally there is a scoring of 10. And what Andrew Bolton and Carolyn Abbott found was that if you have a scoring of more than 6, you can ulcerate. So this is what Andrew Bolton and Carolyn Abbott showed, and this is what we are going to do. Now, if you have facilities, you can do things like ABI, you can do a color Doppler, you can even do a TCPO2, and you can do an MR angiography if you have facilities. But otherwise, as I told you, all that you need is only this to make a diagnosis of a at-risk feet. You don't have to worry if you don't have a 10 lakhs machine or 20 lakhs machine. So, limited joint mobility we showed in DRCP, which is the official journal of the IDF in 2003, that limited joint, if you can't flex your big toe, Alex, beyond 60 degrees, you have limited joint mobility and you will get an ulcer here. So, it's a very simple test. You just do dorsiflexion of your big toe, and if you can't dorsiflex beyond 60 degrees, you have limited joint mobility. So in addition to LOPS, just test the dorsiflexion of the big toe. Now this is another example where you can, this is a very complicated case. Another patient who came 3 months ago, no blood supply, the calcaneum is infected, it's exposed, no blood supply. So you see there's narrowing of the occlusion of the PTA, the popliteal artery, and the DPA, dorsalis pedis artery, and also distal popliteal, the DPA is distal popliteal artery, I'm sorry. So you have complete occlusion here. So what you do, and also there is a femoral block, distal superficial femoral block. Now you do an angioplasty. If it's above the knee, you can put in a stent. If it's below the knee, you can't put a stent, you can only put a balloon. So you can see that in the distal popliteal artery, we do a balloon angioplasty, and in the upper, in the inflow artery, you put in a stent. And the flow is restored in the foot. You can see the flow is restored. And you can see the foot is salvaged. And we skin grafted this man and did multiple debridements after revascularization. But we should avoid such a situation in a developing country like India, because the total cost of this would have been 2 to 3 lakhs for this individual, which not many people can afford in our country. We do have technologies in India. If you have somebody with an infection, you can use a negative pressure wound therapy. It will suck the interstitial fluid and make the wound granulate well. This is how negative pressure wound therapy works. It promotes the granulation tissue. Hyperbaric oxygen is very useful. We have been using it for the last 10 years. It's very useful after revascularization. People think that by giving hyperbaric oxygen, the blood flow increases. No. The blood flow will increase only after you do some revascularization procedure, and then you do the hyperbaric oxygen, which is inhaling. We are inhaling only about 20% of oxygen in this atmosphere. Remaining is nitrogen. Here you get into the chamber, you get 100% oxygen. Footwear is very important, and I'll talk for a minute about footwear. Such footwear is not good. Microcellular rubber, microcellular polymer is not good for people with diabetes. So in 1991 we looked at newer materials, and today we have a lot of, this is our current factory where we make inside our hospital, where we make footwear for people with diabetes, with different types of lobes and ulcers and so on. And these are very stylish because people with diabetes want good footwear. So this has been developed for only about 1,200 rupees. And this is the characteristics of a good footwear. You should have a good tough outer sole. The insole should be soft. There should be no stitches inside. And you should have a counter. The counter is very important. Without a counter, don't give any footwear without any counter. Patients will ask for a counterless footwear, but you should not give it. But if you have a person like this or a person like this, you cannot give these footwear. You can't give an MCR, MCP or this footwear. They need specialized casting, total contact casting, or you can give a crow device, Charcot restrained orthotic walker, which we manufacture for about 1,600 rupees, and we offload the Charcot foot. Therefore, my last slide, the 5 cornerstones for prevention of diabetic foot, which we are doing in the RSSDI Save the Feet and Keep Walking campaign from July 9th onwards, is regular inspection and examination for the at-risk feet. You identify people who have an at-risk feet. You need only the monofilament. You have to educate people, the family, the patient, not to walk barefoot. Appropriate footwear, as I showed you, and treatment of non-ulcerative pathology is removing a callus. I didn't show you the photo. If you have a callus, your pressure goes up straight away and you have to remove the callus. So it's very simple. I'd like to conclude by saying that the Tamil Nadu state chapter is hosting the RSSDA 2022 this year in October, and we invite all of you to, if you register now, you get 5,000 rupees. You just get the it's about 8,000 rupees, but if you register now, you will get about 5,000 rupees. So this is an open invitation for you to attend the RSSDI annual conference after a gap of 2 years. So Chennai is hosting it. So all of you are welcome. Thank you for your attention. This is my good team which works with me, the surgeons, footwear makers and so on, who are responsible for all the data which I keep showing in every meeting. Thank you for your attention.
A big round of applause for saving that.
Any questions for sir?
We end the session here.
Panchi, I'd like you to talk about the Save the Feet and walking campaign. Yeah, Amit, I think you should talk because we have 2 minutes. Because this is a good chance for you to talk about.
We also would like to felicitate you for the collaboration last year which you had given digitally for our Diabetica, RSC research center, you were the auditor for.
Thank you, sir. With the permission of Vijay, sir, we are going to have one campaign which RSSDI is launching. This is from the 10th of July to 10th of August. The name of the campaign is Save the Feet, Keep Walking. So in this campaign, we are going to screen 100,000 people for the diabetic foot. And as sir has told, this is going to be done simply with the use of monofilament. The registration form is already available and uploaded on the RSSDI website. So you can visit rssdi.in and you can register yourself. And you will be getting monofilaments and the registration and all the how to register the patients and how to record the data. This is all available on the website itself.
And the
So I will request you.
poster also there.
And we will be circulating one video, 3-minute clinical examination of the foot, which is being made by Vijay sir. And we will be providing you one poster also, which you can put in your clinic or your center, which emphasizes the examination of the foot. And we will be having an inaugural program on the 9th of July. So this is all about the Save the Feet and Keep Walking campaign. So all the RSSDA members and those who are not even the members of RSSDA, we request them to become member of the RSSDA and also participate in this campaign. Thank you.
Thanks, Amit. So a big campaign under leadership of Dr. Vijay Vishwanathan, who is the Senior Vice President of our RSSDI. This is a social program which we are going to do. It's a scientific social program which we are going to do. Last year we have done Defeat Diabetes campaign and this Save the Fit program. And it is all under our leader, Dr. Vasant Kumar, who is our current president of RSSDI. So I'm sure this will be a very grand, successful program which we are going to have. And all information are already there on our website. So please visit our website regularly. And one very important message which again I want to give everyone, that update your credential. If you are already a member of RSSDI, please make sure that your mail ID and your phone number and your contact details are right at the website. That is number one. If you are not the member, please become the member of RSSDA. Once again, I am requesting you, please visit our website. See, if you are not a member, become the member of RSSDA. And if you are a member of RSSDA, make sure that your credentials are correct. That is very, very important request from us. Thank you. So,
So we will felicitate Dr. Vijay Vishwanathan for his Dr. R.M. Shah oration in 2021. Yeah.
so this felicitation which we are doing, e-felicitation was already done last year. This is face to face. We are doing the felicitation of Dr. Vijay Vishwanathan. He was here, not here, it was digitally he was with us last year in our Diabetica RSSDA annual meeting.
That
when
was
he
the-
was our monitor, the R.M. Shah oration.
That
Thank
was
you.
the first digital meeting which we started in COVID. Yeah.
Thank you.
For today's momentum.
And thank you, Dr.
Yes, sir.
Pratap, that you are remembering also.
I request Dr. Kishore Sheikh, please take the momentum. And also chairperson, તમે chairperson ને આપી દેજો.
હજી શ્રીનિવાસાનું બાકી છે.
એમને પતાઈ ગયું.
So I will request Dr. Bansi to felicitate Dr. Bhumi Dave, our chairperson, and Dr. Urman Bhai to felicitate Dr. Kishore Seth. અહીંયા chair લગાવવા દે. Chair. So we will be starting our inaugural function in 2 minutes time. I will hand over to Dr. Jimit Padgama, who is Master of Ceremony for our inaugural function.
Thank you, sir. Good evening, everyone, and I thank you all of you who have come here so far for this wonderful venue for Diabetica 2022. And we'll be starting our inauguration ceremony. All the delegates and faculties who are there, I would like them to take their seat here.
Chair ले ले, chair. भाषण में चार chair ले.
Invite our scientific chairman for this Diabetica 2022, Dr. Pratap Jethwani sir from Rajkot. Also, I would like to invite our patron for RSSDI Gujarat State and immediate past president of RSSDI National, Dr. Bansi Sabu sir. Also, for today's guest of honor, Dr. Vijay Vishwanathan sir. Sir, please.
Dr. Vasant Kumar को बुलाएं.
हाँ. And I would like to invite Dr. Vasant Kumar sir.
You are guest of honor.
We would also like to invite. We would also like to invite Dr. Vasant Kumar sir. Sir is our chief guest for this Diabetica 2022. And also like to invite Dr. Sandeep Desai sir, who is the secretary for Gujarat State RSSDA chapter. To start the ceremony, it's my pleasure to invite Dr. Ruman Dhru sir. Dr. Ruman Dhru sir is our chairman for Gujarat State chapter, and over to you, sir.
Thanks, everybody. It's a matter of pleasure and privilege to invite all of you here on this occasion of RSSDI annual meeting for Gujarat chapter. I welcome the national president and vice president. It's really a pleasant moment for us to have them here personally or physically after a long time. So I welcome Dr. Vasant Kumar and Dr. Vijay Vishwanathan. Also our own Dr. Banshi Sabu, who has been the patron and previous president of RSSDI. And then of course my team, Dr. Pratap Jetwani and Dr. Sandeep Desai. This is a official welcome to all of you to the land of Gandhi and the state of Gujarat, state of Sardar, which is said to be a dry land and which was a problem for most of us. But now it is being showered by and it is poured by the river Narmada, as you can see, and you must have pleasantly experienced in the morning while visiting the Statue of Unity, which is now probably one of the best places to visit in India. So it's really a wonderful thinking to have arranged this conference at this place where most of us would be proud to see the statue and the whole area. This is probably the first sightseeing place in all India which is completely planned one. We are also very happy to welcome you to the land of Dhokla, Fafda and Khaman, where we are now talking about reversal of diabetes with 800 calories of diet. So it's really a complete reversal in the minds of Gujaratis also, and we are really very happy to have elevated our level of eating as far as India is concerned. Not taking much of the time, the last thing, my role as far as this conference is concerned, very little, apart from giving my inputs about the scientific session and the topics which the scientific chairman would elaborate. Otherwise, most of the things have been done by my team, Dr. Jetwani and Dr. Sandeep, and so, except for standing here and speaking couple of sentences, my role is very minimal. Thank you very much.
Thank you so much, Urman sir. And I would like to invite our scientific committee chairman, Dr. Pratap Jetwani sir, for his 2 words for this conference.
Thank you, Jimit. Dignitaries on the dais, friends, colleagues, and my mentors, senior friends. So, let me first thank Dr. Bansi Sabu, the patron of Gujarat chapter and immediate past president of RSSDI, and our state chairman, Dr. Urman Dhruv, for putting faith in me for designing scientific program for this annual meeting of Gujarat state chapter of RSSDI. We have tried to cover all the aspects of diabetes, starting from the basics of beta cell dysfunction to the recent most things, that is future therapies in pipeline, role of technology, how we can use technology for our diabetes management, and the newer molecules like Finrenone. We have also invited many national faculties of repute, and we have blended together with the local faculties, and we have designed program in such a way that we will deliver the best of science to our delegates. Thank you very much.
Thank you, Pratap sir. And I would like to invite our patron and immediate past president, Dr. Bansi Sabu sir, to shower his blessing.
So already Pratap told me you have not to speak more than 1 minute. So first of all, our respected RSSDI National President Dr. Vasant Kumar, our close friend Vice President Dr. Vijay, close friend and elder brother Dr. Urman Dhruv, who is the chairman of RSSDI State Chapter Gujarat, Dr. Pratap Jetwani, my younger brother, very close to me, who is a scientific chair as well as National Executive Committee member, and Dr. Desai, organizing secretary. I will not talk about this program or this as a RSSDI research committee chairman. My only request to all of you, as we have very less number of research papers from our country, and as I belong to Gujarat, I can say that we are having very less number of publications, particularly from doctors of Gujarat. So this is my request. at this annual meeting of RSSDI Gujarat chapter, which we are doing. Our primary aim is not only this continuous medical education program, which we do under the banner of RSSDI, but we must do research. And research does not mean that we should do only primary research or a basic research. We clinician can also publish many of our clinical research or the real world data also. We have our own journal nationally, but there are many more journals which can accept our publication. And if it is not possible to write even a full article, we should do more and more papers in our national conference, regional conference. And that's what my request is. This year in Chennai meeting in RSSDI, our national meeting, which is going to happen in first week of October, the already abstracts are open, and requesting every one of you, please put your abstract. It can be as an oral, it can be as a paper, but feel proud while putting the abstract, and next day it should come when it is accepted in a social media that this time I am going Chennai, just not going to attend the meeting, but I am going to present something as a paper also. That's my humble request to all of you, all the members. We have already talking since morning that please check your credential while seeing your RSSDI website. And if you are already a member, see your credential. And if you are not the member of RSSDI, please become the member of RSSDI. And spread this message to your colleagues, your friends, your students, whoever who wants to become the member of RSSDI. Any post MBBS doctor can become the member of RSSDI. Thank you. Thank you very much.
Thank you so much, Bansi sir, and we will definitely have much more improvement from Gujarat this year, I'm sure. Moving forward, it's my pleasure to welcome our guest of honor for this Diabetica 2022, Dr. Vijay Viswanathan sir. Sir is the national president of RSSDI, and sir is also president of D Food International. We are extremely thankful to sir for accepting our invitation.
I'll take only about 30 seconds because... Okay, 1 minute. So I would like to thank our immediate past president, Dr. Bansi Sabu, Dr. Pratap Jatwani, for conducting this Gujarat RSDA every year. I think Gujarat RSDA is a shining example to many other state chapters. So I think we in Tamil Nadu look upon Gujarat for guidance and how to do it. So we are just budding, and we in Tamil Nadu state chapter, which is budding. So, but the point which Dr. Bansi said about research is very valid, and we would like to thank Dr. Bansi Sabu for starting for the first time in the history of RSDA, an RSDA research retreat in Pune about a month ago, no? Yes. And we had set the ball rolling. So I think the things are going to follow now. So Dr. Bansi Sabu has set the ball rolling, and research will now flow from not only Gujarat chapter, but from all chapters all over India. So thank you, Dr. Bansi, for setting the ball rolling. Thank you.
Thank you, Vijay sir. It's now time for the lamp lighting, and for the lamp lighting, it's my pleasure to invite our chief guest for Diabetica 2022, Dr. Vasant Kumar sir. Sir is national president of RSSDI, and I would also like to invite all the dignitaries on the diet to join the lamp lighting ceremony. Dr. Vasant Kumar sir.
या कुन्ते तु तुषारहारधरा या शुभ्रवस्त्रावृता या वीणावरदण्डवण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमां कार्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदा षाढ्यान्धकारापहा हस्ते स्फाटिकमालिका विदधति पद्मासने संस्थिता.
Thank you so much. I would like to invite Vasant Kumar sir to give his speech.
Good evening, friends. It's been wonderful to be in this great place. And thank you, Gujarat team, for giving this great opportunity for us and listen to some of the very good talks, meet friends personally, interact with them. As our Vice President said that Gujarat chapter has been doing extremely well. What it means is that he is encouraging you to do more and he expects more from you. So I'm sure you take the challenge now. It's more than the appreciation. It's a challenge that given to Gujarat team because you deserve it. Just for 30 seconds, what I would like to tell is we keep doing CME programs, training programs. All that is good because we have to update the knowledge. But it's not really going to make a change in the life of an ordinary diabetics in a country, unfortunately. So what we need to do is conduct preventive programs, look at primary prevention, because you have diabetes in young people now. Look at screening programs, which have become a part of RSDI. Please keep doing them. Use the district coordinators in time so that we do more such programs in the months to come, in the years to come, so that we are going to be more useful as a society to the nation, while we continue to do our research, continue to do CME activities, continue to update ourselves. All of us need to get updated, learn more, and finally practice wisely. Whatever we learn, you should always use your own individual wisdom. I even say that any guideline I take with a pinch of salt. You know what it means in English. So I don't want to elaborate. So I thank you all for giving me this great opportunity. Thank you.
Thank you so much, Vasant Kumar sir. Then last but not least, I would like to invite our Honorary Secretary for Gujarat State RSSDI chapter, Dr. Sandeep Desai sir, for his vote of thanks.
Thank you, Jimmy. Good evening, everybody. It is a great pleasure to be with you all, and I am presenting the vote of thanks as a last ceremony. On the dais, we have our patron, Dr. Bansi Sabu, our president, Dr. Vasant Kumar, Dr. Vijay Vishwanath, our vice president, and of course, Dr. Rudmandru, who has not taken any, credit, but he has been our force behind us. And Dr. Pratap Jetwani, who is our scientific chairman. Actually, everything has been done by him, almost 90%. We have just worked around him and done the whole thing. He has been a great organizer. Of course, thanks to all our national speakers who have come from far, and they have probably, I hope they've all visited the Statue of Unity and they'll go back with good memories. And of course, our local speakers, all the delegates who have come here from far. Of course, the RX events who have managed the whole show very effectively. And yes, our sponsors, the pharma people, I thank them all who has putting all the efforts as well as the finance for us. I guess I have remembered everyone. If there's someone whom I have just, unintentionally forgotten, please, accept my, I'm sorry for that. Thank you, everyone, and I think we continue the program. Oh. Thank you. Thank you, God, for, giving this whole thing, first of all. And thanks to my family. They are bearing me for this all, every night we are in the meeting and we don't give time for the family. Thanks for the family members, for everyone.
Thank you so much, Sandeep sir. We conclude the ceremony and we thank all the honorary guests for the welcome, the ceremony. Thank you so much. moving forward, we have a wonderful session coming here. That is the presidential oration. To chair the session, it's my pleasure to invite our next chairpersons. Also like to invite Dr. Urmandru sir from city of Ahmedabad, and over to the chairpersons.
To the dais and will be reading the citation that is being handed over to him as a part of presidential oration. Dr. C.H. Vasant Kumar is MD Medicine.
Hello.
Working at
Urman bhai. Okay.
Dr. Vasant Kumar is MD Medicine, working as a senior consultant physician at Apollo Hospital, Hyderabad. He is actively involved with RSSDI for 15 years and is currently serving as the president of RSSDI. He is founder and president of Diabetes and You, that is a day program society to support kids having type 1 diabetes. He has organized many conferences, including annual meeting of RSSDI, as well as conducted many diabetes awareness and education program for the community. We at Gujarat chapter of RSSDI deeply appreciate his contribution to RSSDI and in the field of diabetes, and with him success in his future, and wish him success in his future endeavors.
I'll call upon Dr. Bansi and Dr. Pratap Jetwani to be on the dais.
All are there. You are here. The late of Sardar Patel. You are as tall as Dr. Mr. Sardar Patel is like yeah, yeah.
Emma, we are ready with. Good evening, friends. I know we've been late. I'm not responsible for the late, but I will take it so that I'll try to finish it off fast. Yeah, let's act before it's too late. So let's be focused for next 15-20 minutes. Let's be grounded. You know, we are living in this world of so-called reality. We don't know what we do from morning to evening. We talk so many things, we hear so many things. But anyway, now I am trying to focus on certain issues related to this country, this state, all the states, where we need to do something seriously. This is, of course, one of the IDF statements done in 2021, which mentions that it estimates that 1 in 10 people between the age of 20 and 79 are diabetics. I'm sure you agree with this statement. And finally, what worries us is there is a strong need for effective intervention strategies and policies to stall the increase in the number of people in developing countries, because you are seeing more diabetes amongst the developing countries. India is one of them. India is one of the largest developing countries in this world, and it continues to be a developing country. Don't expect it to become a developed country very soon. This is one of the slides sometimes actually introduce me. You see even here amongst the world atlas of diabetes, how it's increasing, and India seems to be on always going unstopped. This is actually one of the topics that I used earlier, that I always said we are different and our actions have to be different. We are different in so many ways. The subcontinent is different from the rest of the world. We are one of the developing nations, but we are culturally, socially, economically, in so many ways they are different, and we don't take actions. This is just a slide that I'm not saying that you should enjoy all these mithais, but this could be one of the differences. Nowhere in the world people enjoy so many varieties of savories which are full of white sugar and fat, and everybody enjoys. So this is just one of the slides that I wanted to mention it to you. It's done about 20 years back, where they said, the mean age of diabetes by the time it's detected is 43, 50% had poor diabetes control, 54% have severe complications. The point that I want to mention to you is that we have not done anything better. 2 decades have passed by. Why is it happening? We need to question ourselves. This is one thing all of us know about it. We are different because of this. We have all these 7 features. Center is beta cell dysfunction, which you see more often in more of our type 2 diabetic patients amongst the younger ones. We have a stronger family history, diagnosis at a very early stage, and we have more complications like CVD, and we know the diet that what we eat. I don't need to mention to you. We are becoming sedentary, and then thin fatness is something which is appreciated all over the world, that we Indians, even at normal BMI, have more than 30% of the fat in us. And this is another thing that bothers us is we still have an urban-rural population divide. In spite of the people migrating to rural areas, we still have about 30-35% of them only in the urban areas. 60 to 70% are in the rural areas, the so-called rural areas, which are slowly getting urbanized. But then there are problems which are different. Even in a so-called one of the developed states of Gujarat, you have poverty, you have all issues. Remote areas, people do not have facilities. So that is something which is a point of concern for all of us. As I said, we are experiencing a lot of socio-economic progress, urbanization, and of course we share a huge global diabetes burden. And studies from across India has shown time and again that diabetes is increasing everywhere. One of the worries is you see increase in the incidence of diabetes even amongst the rural areas. And just imagine there is 70% of rural area, and if even there diabetes increases, we are going to have a huge problem. And none of the things that you are planning all these days will be able to give a solution. That is the worry. So growing prevalence of type 2 diabetes is what you see here. Even amongst the young people, you see this. When we say young people, we are talking about people below 30 years. There's a huge increase in diabetes. And of course, this is one of the big issues that our nation people face, because there is a considerable disparity in the availability and affordability. And there is low awareness. When I said affordability, you know what's happening. Most of the patients who are who are seen by the specialists in the cities and urban areas, even there they have a disparity of the patient. There's somebody comes with a lower middle class, somebody comes patient, a businessman who can afford a good treatment. In between you have someone who has got a treatment which can be reimbursed. So you have a different kind of a patients. You need to assess which patient you are treating, the one who is sitting opposite to you. And lifestyle modification, we all know, is an effective tool for not only managing diabetes, for primary prevention of diabetes. This is what is more important. And primary prevention of diabetes is urgently needed to reduce the burden. We are not just talking about managing diabetes, we are talking about prevention at every level. Primary prevention starts from the schools in the children and in the high schools and the colleges and so on. If you actually reduce the incidence of diabetes or postpone it by next decade, the burden is going to be much less. We need to do it, the government needs to do it, all of us need to do it. So there, apart from the social and financial constraint, we have different social and cultural backgrounds. All of you know how it is. Our people, whether coupled with illiteracy, we have our own belief systems. A lot of our patients, even your own patients, would go to homeopathy, would go to somebody else and take the treatment. Even you won't know that. So that is the real situation that's happening. And you just can't blame the society for these things that's happening. You are also part of the society. You are also part of the responsible persons. You need to take the challenge. RSDI should take this challenge. Why is it happening? Where are we missing? Either we are underdoing or we are overdoing, according to me. We doctors, we are underdoing situations, we are overdoing. Sometimes, we do it intentionally or unintentionally, and patients run away from us. And you blame the patient, but finally, you know what happens, the result. So we have so many things, what this slide shows. And this is typically expenses that happen. This is one of the slides from the recent Scandinavian study. I'll switch and show the one relevant to our country. I'm also trying to be short. This is, I took it from Mohan. This is Anjana study, 2020 publication. This again bothers us. Just look at it. We are not looking about the etiology. We are just looking at these clusters depending on their beta cell function and the amount of insulin resistance they have. So unfortunately, we have about 26% of them who have severe insulin deficiency diabetes. These are type 2 diabetics. And then we also have in between, if you come and see, there is a 12% of combined insulin resistancy and deficiency. So that means it's almost about 39% of our type 2 diabetics have considerable to severe insulin deficiency, apart from insulin resistance, which could be to a level of about another 40%. Fortunately, we have about 35% of our type 2 diabetic patients who are older. They got diabetes beyond middle age. It's mentioned as mild age related diabetes. This is one area you don't really try to overdo on these patients. Keep them around, keep the blood glucose normal, ask them to reduce the body weight, give them simple medication without too many side effects, where you don't need to monitor too often. That's another problem. Many of our patients don't come back to you. With your over jealousness or over enthusiasm, we want to give one of the so-called best drugs that have recently been introduced. But are you ready to, is our patient ready to accept what kind of a monitoring is required, what kind of precautions are required? Are they living in such condition where they can accept those medicines? Is an issue that we need to remember. And talking about type 1 diabetes, also if you see the incidence, it is one of course, the commonest pediatric endocrine disorders, and 1 in every 5 type 1 children are out of the world are living in India, unfortunately. So this is also a huge problem. And then diabetes in young is a huge problem. If you see the semi-urban rural areas, a lot of these youngsters, 25, 30, 35, they are just lower middle class, poor families, working, irresponsible, bad habits. They don't even go to the doctor. So this kind of problem, this is something which all of us know. So I always ask this question, So making India a diabetes care capital of the world, can this be a reality? If it's a reality, when is it going to be the reality? How many decades will it take for us if we continue to do what we are doing today, is my question. So we know about the special features which I mentioned to you. Apart from the anthropometry and phenotypes, the problem we have is the infections that people have. Especially if you see our diabetics living in the poverty conditions, living in the urban slums. Do you know where diabetes is now? In the towns and cities? It's in the urban slums. That is where you see. And what kind of hygiene conditions they have, what kind of facilities they have. So they are highly prone for infections, whether they are chronic or acute. Together, it's a huge double disease burden, what we call. They already have a diabetes which make them susceptible. The conditions and poverty itself makes them susceptible to infections. And we don't seem to be realizing this, nor the government. When we try to tell the government about presence of NCDs amongst the poor people, urban poor, I think they're still trying to understand what it is, although they are working on NCDs. So the physicians, when I say physicians, we are all physicians, whether you are a surgeon or a super specialist or a general practitioner. I don't want to include an RMP because many of you may not like. But if you ask me, it is the registered unqualified practitioners who are managing diseases in diabetes. Sometimes I say, why don't you at least teach them some problems like how to manage hypoglycemia, because you and me are not there in that village. It is that guy who manages hypoglycemia. What do? I mean, you have to accept the reality. So we have a huge role to play as doctors in this. And because I know we have limited resources, and I'm asking the question, can we practice what everybody tells us to do? All international guidelines and so many. That's why Pansi was one of the persons, and many of my colleagues, some years back, we thought, why not we have our own guidelines? All the guidelines, whatever they say, even RSSDA guidelines says, you have to individualize the patient. It's only telling individualize the patient on so many situations, and cost always matters. So finally, health education and explaining importance of control of disease has to be done continuously, not only to the patient sitting in the clinic, but at a public awareness place. So all of us need to do some awareness program socially. Take the responsibility, social responsibility, do it in any club meetings or any other community meetings, anywhere. Just talk to them how important it is to prevent diabetes, how we can manage it simply. Go closer to the society. We are slowly becoming away from the society. Please remember this. It might look little uncomfortable to you when I say this, but this is exactly what is happening. That's why people are going to the alternate systems. Somehow they are impressing. You and I may say they are cheating. Maybe they are doing, but they are succeeding. So we need to interfere. We need to reach into the society, both urban, rural, slums, everywhere. And I always believed family physician, general practitioner is very important. And Gujarat chapter should take this lead to train our general practitioners, go with the IMA, tell them some simple things. I don't want to go with the wonderful slides and tell them the latest orally available GLP analog, which I don't need to tell him. I might use for 1% of my patients. I want Bansi to go and tell them about the importance of prevention and manage simply, so that it becomes easy. And of course we need to have our own data, which we are working. This is some simple thing all of us know. This is what we have to tell our GPs. Simply this slide is enough if we teach our GPs and tell about few things about the drugs. The top is about monitoring, is very important. But I always say, when I look at the slide, I see the glucometer. I thought glucometer is one of the greatest inventions that took place in the recent decades in the area of diabetes. Because I remember when I was house surgeon in 1977, we were doing Benedict solution to check only urine. Forget about doing blood sugars. No way that we could have dreamt that we could do blood sugars. We were doing urine sugar, which is highly unreliable. Of course, whatever it is, we were trying to titrate the dose of insulin by looking at the urine sugar. Can you imagine that? Today we are talking about continuous glucose monitoring. We are talking about time in range, time out of range. It's great to talk about it. I hope it becomes practical in future. But why I'm trying to say is the glucometer is the most important instrument that can do wonders in your clinic and also in the patient's home. It can check everybody's blood sugar. It can prevent hypoglycemia. It is the simplest, wonderful instrument that everybody should use. You should tell that the GP, every GP should have a glucometer. He can actually become a diabetes specialist. And if you teach them, of course, elderly diabetes is always an issue for us. We need to be gentle. When I say elderly, actually, we should not dump everybody as elderly. Doesn't matter whether he's 60 or 80. Look at the frailty, his comorbid conditions. Somebody at 80, if he's fit and fine, treat him like a 50-year-old fellow. Only thing is, don't put him into the risk of hypoglycemia. Choose a good drug depending on his financial situations. Somebody at 70, two comorbid conditions, don't keep on wondering and breaking your head to bring down the blood sugar with too many medicines, make his life much worse. So you have two extremes when you talk about, because I also incidentally work in the field of geriatrics, I keep on talking about it. One word about insulins. I know we have great advantage of having newer analogs, one analog after the one is coming. Even I get sometimes confused which is a better one amongst the shorter, longer acting. Sometimes I ask Bansi so that he can guide me. So, but this slide tells us that all insulins are efficacy wise they are same. There could be an advantage, that patient has an advantage, they can take it without waiting too long. It is claimed that the hypoglycemia is much less amongst the analogs, but if you carefully titrate, you can also avoid hypoglycemia, which we have been doing. We've been so greatly, we thought of Boots insulin, which was not porcine initially. Subsequently, it became a porcine insulin. We all were very happy. Lesser antibodies and people are accepting it. Finally, we had human genetic engineering. Then we have human insulin, which is widely available, which is not too expensive. Many of our patients depend on that. So don't jump at giving an analog to a patient who cannot afford. Surely give it to somebody who can afford, give him the advantage. That is one word, one sentence that I beg you. And prevention of diabetes is always important. As I mentioned, we have to take the government and we have to keep talking to state governments, local governments also, sir, in our own towns, municipal chairmen and others. A small country like Singapore involves all NGOs and they go out of the way how to prevent. So these are all the problems we have. High prevalence of diabetes, pre-diabetes, as I mentioned, diabetes comes at earlier age, complications are more. All these things I have mentioned about poverty, literacy, we need to handle all these issues. Our research should help us. Let's do any kind of a global research, no problem, but also focus on this research. Even Dr. Bansi has been trying to do this. And the Defeat Diabetes program is the first time we all work together. RSDA members, we involved a Rotary clubs across the country. People who are not doctors, they understood, they worked with us. It was a wonderful scene. Even the Chief Justice of India was so thrilled and happy. He went on appreciating, and he knew what RSDA was, and he was appreciating us each time we talk about it. It's a small feather in all of our caps. So our approach is detect by screening young people periodically, especially those who have family history, concentrate on the people who are overweight and sedentary, and keep working on them at a social level, at an individual level. Finally, provide an affordable, individualized management and continue to focus on their eating habits apart from physical activity, both of them. It's not that once you tell them, every time you tell them. I know all of us spend only 5 minutes, at least I spend only 5 or 6 minutes, but I can keep on telling them the same things in the next visit. I don't need to tell everything about diabetes on the first visit. Remember this point, it's very important. Just about a word about trans fat. We keep talking about cardiovascular diseases, coronary artery disease. You want to reduce it, you know diabetes is an important risk factor. You are even talking about CVOTs, you are talking about newer drugs like SGLT2, how they work, help us, advantage, all that. But we are forgetting that trans fats, which is a dangerous part of the fat, which causes cardiovascular complications, are banned in all these countries, and India is yet to ban, which has actually reduced the percentage to 3% now, the India, but it's only on the paper. In execution, it doesn't happen. I'll tell you the seriousness of it. All these have got trans fats to a great percent. All of them, if consumed more, have problem. But we have bigger problem. Our bigger problem is trans fat is nothing but it usually happens by hydrogenating the cheapest edible oil that we have, that is the palm oil. So we export a lot of palm oil from Malaysia, most of the countries, because it's come so cheap to us. Government gives palm oil to all the poor people out of them, and the industry converts palm oil into trans fat, and trans fat is used left and right in all the street foods that are available, which are consumed by the poor and lower middle class. Fortunately, we don't use it at homes, and even hotels like this don't use so much. And so it's always there in all the baked items. And remember, fried foods like our choices foods like samosas, puris, even dosas in Bangalore, street dosas, or either they use a lot of trans fat, Srinivas, which is really bad. And we have to do something. All of them have got huge amount of trans fat, and these are eaten left and right by the so-called poor people. All this, even the packaged namkeen has so much of trans fat. We need to ask the government to do something about it. But even if they do, you cannot execute it. Finally, people are going to eat. So finally, just 2 minutes about how much time did I take? About Bansi told me to take only 20 minutes, although it was 30 minutes. Did I cross 20 minutes yet? So this is about type 1 diabetes challenges. We need to be equally grounded when you're talking about type 1 diabetes, because I have been also working in this field for last maybe 25 years. I deal with some of the children, unfortunate children who are poor. Some of the problem that I noticed is most of these poor children consume high carb food because that's what they get. The government gives them free rice, free roti, and they eat all the time, 3 times, in spite of whatever you tell the parents or them, because that's the only thing they have. They coupled with it, sometimes they may eat little protein or a cheap fat like what I mentioned. So I have also seen that most of these poor children who are also underweight require high dose of insulins. So I used to break my head, ask everybody. Finally, there was no solution. It was only that you have to pump them with more insulin, request them to eat less carb. So type 1 diabetes is a huge challenge for all of us. Explaining the implications to an illiterate parent is a problem here. Here, most of the parents are illiterate. Wife and husband work. They have a child and you go on telling them or scare them literally, because you want to scare them actually. Otherwise, they won't take the precautions. But they have their own issues. They go to the government school. Sometimes the afternoon insulin is definitely skipped, especially by the girls. And these kind of, sometimes when you do good job and try to train them, some of these children become well. I have a few of girls who are from lower socioeconomic strata. They have become very confident now. When we organize some program, they even talk. Of course, this was said by the President IDF almost 2 decades back, that no diabetic child should die because of lack of insulin. But certainly children are dying either because of improper use of insulin or improper checking of blood glucose. They don't have a glucometer with them. You're talking about all these. The type 1 diabetes requires everything that is required, but they don't have them. They don't have a glucometer. Even if they have a glucometer, they don't have strips. Do you know that there are so many type 1 diabetic children in this country who don't check the blood glucose even once in a month? It happens, whether you believe it or not. That's why I said we need to be grounded. There are children like this. Unfortunately, one of my own diabetic children who passed away, whatever I told them. This is one question I always want you to address. Who should treat type 1 diabetes in the children? Actually, the priority should be from down. It is a general practitioner, physicians, then pediatrician, of course, then endocrinologists. I don't know whether pediatric endocrinologists, we do have them, how many of them could they treat? Maybe 1% of them. So general practitioner and physician are the most important people, and pediatricians, of course, even to treat type 1 diabetes. We all need to be trained in managing type 1 diabetes, make their life little better, longer, whatever way possible. So this is what I just wanted to be brief and just remind our own responsibilities. I am just amongst you. I want to do the same thing. Whatever I did and whatever I tried to do, whatever RSSDI should do is something that I wanted to share with all of you. I know it's not something that I have told you that you do not know, but I just try to highlight them so that all of us would perhaps take a bigger role in our society, become bigger responsible. And I am telling you one thing, finally I will leave by saying one thing, that when physicians, the doctors do something, the society appreciates, the people appreciate, your image increases, your value in the society increases. Money is always important, but when you do these programs, people appreciate you. People wish you on the road, even in the cities. I have seen this. Village, of course, people still respect doctors. Even in the towns and big cities, people respect a good doctor. If they think, good doctor, whatever they think is good. So we have huge challenges faced, but please consider these points and do whatever you can. And RSDA can play a huge role, Gujarat RSDA, and I'm sure it will do it. So with this hope and I will leave, and thank you so much for giving me this opportunity. Thank you.
Very much for very nice and very important topic or the message that is given to us. Thank you. Give a memento to our speaker. Just in response to what Dr. Vasant Kumar said, we are very happy to announce, sir, on behalf of Gujarat chapter RSSDI, and we will request you to mark the date of 8th January in your calendar also. We are going to have, with the help of district coordinators all across Gujarat, in all 33 districts, at the same time we are going to have a health education program. 33 districts all together would be speaking the same Gujarati presentation of 20 slides only for the public. We'll have enough of announcement for the same. We'll teach all district coordinators what to speak. Exactly the same language would be spoken all across the Gujarat on 8th of January 2023.
Thank you. I will request Dr. Urman Dhruv to felicitate our chairperson, Dr. Jitendra Nagar, with memento. Now we will move on to the next oration, and that is state chairman oration, and I will invite our secretary, Dr. Sandeep Desai, and our advisor, Dr. T.K. Mishwar, to chair this session.
Dr. Urmandru, our state chairman, and we are presenting this on the annual conference of RSSDI Gujarat Chapter Diabetica 2022. Dr. Urmandru is MD Medicine, LLB Fellow Diabetes India, PG Diploma in Hospital Administration, and he is currently the Director at the Department of Internal Medicine and Diabetes at HCG Hospital, Ahmedabad since 2003, and was visiting faculty at AMC Dental College, Ahmedabad. He has received the prestigious Gujarat Ratna Award in 2019. He has been the recipient of late Dr. B.N. Mehta Oration by Ahmedabad Medical Association in 2013-14 and APGA Oration by Association of Physicians of Gujarat in 2017-18. He was also awarded Investigator of the Year 2017 by the Indian Society of Hypertension. He has served Association of Physicians of Ahmedabad as President and is currently the Chair of Gujarat State of RSSDI Chapter. We at Gujarat Chapter of RSSDI recognize his immense contribution and wish him success in his future academic work.
Yes, please, requesting our resident to felicitate our state chapter chairman. So I will request You too, sir, felicitate him.
It's really a great honor.
I would like to tell only one line for Dr. Urmandur. He's a wonderful man. We all know him. But all the time, since last 20 years, I have done multiple meetings and activities in Ahmedabad. And he is always a great support for any scientific meeting. He may not be great organizer, but I can tell you a great executor for a scientific program. I have seen him in our Epicon and RSSDA meeting. I just tell you to everyone, those who are here, he will come sharp at 8 o'clock. Not from the hotel, from his house. He will not take breakfast. He will not take cup of tea. Probably he may take one cup of tea, sir. That is too much. He may take. And he will start program sharp at 9 o'clock. It will continue. He will be there. And he will see that all 4 coordinators who are in other hall also are taking care of the timings perfectly. He will ask all chairperson also that, the program should run at right time. And he will finish right at 6 p.m. as the program that used to be in Epicon. Last we have done 9 to 6. Now we have extended it to 9 to 7. The same way 9 to 6. The RSSDA program. He will finish everything. He will say, Bansi, goodbye. I am going. I will tell, sir, please take a dinner. No, I will not take Bansi. You know that. And he will go there. And that's how behind the curtain, he is always there. And we requested him before 2 years to become the, before 4 years rather, for chair elect for RSSDI, and then agreed. And then for after 2 years of chair elect, he is, since last 2 years, he is chair of RSSDI Gujarat chapter. And he has done tremendous work for Gujarat chapter, which he will be talking in his presidential talk also. Thank you once again, Urban Bhai, for a great support to everyone.
Bansi says good words because he himself is a good person. As I told you, I request all of you to book your date. Every one of you to book your date and send this message all across Gujarat that on 8th of January 2023, the whole Gujarat, the RSSDI district coordinators of the Gujarat, all at a time simultaneously will speak the same language of health education in Gujarat for 40 minutes for all the people of Gujarat. And it is going to be one of its kind of program that we have dreamt of. And hopefully, as long as Bansi is there, we are going to definitely implement it also in one of its best kind. So, please book your dates. And I'll request our national president and vice president also to join us on that day. The day has been decided because that is going to be the time post-election. In December, Gujarat may be having elections, and between the 1st and 14th of January, we call it Kamurta, when there are no marriages, and that's how the date has been selected. We are going to talk about cardiovascular risk assessment in diabetes. Are we doing enough? So, we have few questions. Should all patients with diabetes be considered CHD risk equivalents? जिन पेशेंट को भी हम देखते हैं, this is CHD, diabetes CHD. We have been hearing it for years together. An echocardiogram and exercise test should be performed in all patients of diabetes, especially those older than 50 years. I may be sounding like what Dr. Vasant Kumar just said. Nothing for everyone, something for everyone. So there is no fixed rules that this patient must require echo, this patient must require these things. Everyone is to be treated individually. Coronary CT angiography should be done in all asymptomatic patients with DM. That's the fashion of the day. Are we on the right track? No. So we are going to also see these 3 cases at the end of my talk and we'll solve them. So we all know that USA and even United Kingdom, with the help of better technology, better services, better resources, have been able to push down the cardiovascular mortality and cardiovascular diseases. The trend is going down there, especially also because of the removal of trans fat, as Dr. Vasant Kumar rightly pointed out. But in India and in South Asia, the trend is absolutely in a reverse way. We are facing a tsunami of cardiovascular disease, we all know. And we are not the same people. We are not the US citizens. Our phenotype is different, our genotype is different, and therefore, whatever is applicable to USA may not be applicable to us, and that's what we need to know. We agree that we have got suboptimal care in South Asia, but still with it, we need to identify who are the people at risk of cardiovascular disease as early as possible so that we can use either primary prevention or secondary prevention. So this was a standard statement 15 years back or 10 years back. Diabetes is considered as a CAD equivalent, and this is one slide I have shown multiple occasions, but it is wrong. This was the Finnish study which suggested that diabetes is equivalent to CAD, but it is wrong. The reason is this 2009 Diabetes Care article which suggested that everything is not that bad. 10-year cumulative incidence of CHD, something we must remember. This is very, very important. When you compare a diabetic patient, a patient having diabetes, without history of coronary artery disease, with a non-diabetic person having a history of coronary artery disease, remember the chances of coronary artery disease or myocardial infarction or cardiovascular death is more in non-diabetic. I'll repeat, a patient having diabetes without any history of coronary artery disease with minimum risk factors, but compare him with a patient who is non-diabetic but had a myocardial infarction in the past, the chances of this second fellow dying is more as compared to a diabetes, and therefore diabetes is not a CV risk equivalent. Not one size fits all. Just the presence of diabetes does not mean a myocardial infarction or the death or cardiovascular disease. Age and duration of diabetes both play important role. Why should we bother? Once again, I will bring Dr. Vasant Kumar into the picture. He rightly said that we have been trying to use curative medicine, but it's time for all of us to think about stopping the tap from the above so that we don't have to take out the water from the floor. We follow the guidelines, US guidelines, ADA guidelines, whatnot. Every guideline says use SGLT2 inhibitors first. Is it true? No. No guidelines ask you to use SGLT2 inhibitors first. What do guidelines say? Guidelines say first check whether there is established ASCVD or not. It says check whether there are multiple cardiac risk factors or not. It says check for the renal function, microalbuminuria, urinary albumin creatinine ratio, and then think about the second drug. But we take the shortcut. ADA says metformin followed by SGLT2 inhibitors, metformin followed by semaglutide. Start it. We forget these three caveats, and that's what we need to remember while managing a patient of diabetes in our clinic. We need to stratify the risk, because the risk stratification in a patient having diabetes would lead to primary prevention, would lead to prediction of subclinical CVD, will also lead to prediction of silent ischemia. It would decide the future CV events. It would decide which statin and in which doses. It would decide aspirin is required or not. But the most important thing is, it is going to decide which oral hypoglycemic drug requires to be given. So even before you start the treatment for diabetes, you need to stratify the cardiovascular risk, because the guidelines say that without stratifying the risk of diabetes, cardiovascular disease, you should not add drug number 2. So what is risk? A little bit about risk. As such, the word risk is a very philosophical word. Lots of things have been said about it, but the risk says how to find out unwarranted event, how to find out the cause for that unwarranted event, how to decide the probability of that unwarranted event, the expectation value of that unwarranted event. It is not enough to say that this patient may have MI. We also need to know how severe the MI could be. So probability multiplied by severity, that is MI and death, would decide the expectation value and a decision made in the context of known probabilities. So there are two types of risk. Before I become very theoretical, this is the last slide when I will be theoretical, then we will be shifting to something clinical. So there are two types of risk, absolute risk and the relative risk. What is absolute risk? The risk says the percentage probability of an adverse event within a stipulated time. 6 महीने में चांसेस कितने हैं, 2 साल में कितने हैं, 10 साल में कितने हैं, within a stipulated time. So the absolute risk says the probability of an individual of developing an adverse event over a given period of time, and that is more important than relative risk. The guideline says that you should know what is ESCVD, that is established cardiovascular disease. But most of us do not know what is atherosclerotic CVD. So first of all, we all must know what has been defined as ASCVD, and then we have to find out how to find it out. So these are the 6 different parameters which determine ASCVD in all CVOTs, and most of the time we do not know it. CV risk in diabetes. Coming to now something practical. Cardiovascular risk factors, and then there are cardiovascular risk enhancers. So first of all, let us see what are cardiovascular risk factors, or what we call as traditional risk factors. They are either non-modifiable or modifiable. The non-modifiable factors: age, gender, family history and ethnicity. And modifiable factors: blood pressure, lipids, smoking, calories and diet and exercise. So before deciding any further step, first thing that we need to do is to look for these 8 things. That is age, gender, family history, ethnicity, blood pressure, lipids, smoking, calories and diet and exercise in a patient having diabetes. And then comes the cardiovascular risk enhancer. And I would like to draw your attention to the first statement, which we most of the time ignore, forget, avoid, whatever we want to say. Family history of premature ASCVD with onset less than 55 years of age in a first degree male relative, or less than 65 years of age in a first degree female relative. How many times when a patient of diabetes comes to us have we asked, did your mother or did your father have a stroke, PVD, MI, sudden death before the age of 55 in case of father and before the age of 65 in case of mother? Remember, this is one of the most important risk factor in a patient having diabetes. This determines how much you need to investigate this patient further. So now we realize that assessing CV risk in a diabetic patient, how much important it is. Most important 2 factors: longer the duration of diagnosis and earlier the diagnosis of diabetes, it becomes one of the most important CV risk enhancer. There are novel risk factors and atheromas which we may skip. They are all basically biomarkers. Same way there are genetic evidences also, as we know the history of chromosome 9, but will not go into detail. I think I have confused you enough. So let's become a very simple storyteller. What to do? Are we doing enough? Obviously by this time you know the answer, no. So what to do? How to do cardiovascular assessment in a patient with diabetes? Number 1, assessment through the measurements. Number 2, assessment through the risk calculators, which you may or may not follow. I am not very fond of risk calculators. You can do it with the help of measurements. And then comes assessment of subclinical atherosclerosis, which is very important, And the last thing, assessment of silent ischemia. How can you do assessment through measurements? Simple things. CVD risk factors, which I gave you the list. If you cannot do that, just go for age, previous event, and the 5 risk factors that I enumerated. Assessment through risk calculators, we'll have few slides about it, and we'll like to see which is the best risk calculator for India. And then assessment of subclinical atherosclerosis. If the resources are there, if you can manage, then the coronary artery calcium score would be one of the best helpful thing for cardiovascular assessment. Simple things first. A patient of diabetes comes to us, start with family history of premature atherosclerotic cardiovascular disease, and also look for common comorbidities in the patient. Think about the eating pattern. On day 1 of the consultation with a patient having diabetes, talk about his eating pattern, his behavioral pattern. This is very important. मेरे पास समय नहीं है, time नहीं है, should not be applicable. Also measure his blood pressure diligently. When I say diligently, you should know how to measure blood pressure, and I am really very sorry to tell you, 60% of paramedical staff includes well-trained nurses, and about 30% of medical staff really does not know how to use mercury sphygmomanometer and the digital blood pressure monitoring instruments. And there are lots of ways and means to do it. We are not going into detail. And then the last one, atherosclerotic CVD risk factors, heart failure history, and the 10-year rate. Now I'll tell you a very simple thing. How many times we have asked a diabetic patient that, do you feel any problem in walking? No sir, I am walking regularly. Did you have any changes in your walking pattern or walking distance within last 1 month? And the patient would definitely say, previously I was able to walk 4 kilometers in 1 hour. Now I can walk 3 kilometers in 1 hour, or for the same 4 kilometers, for finishing a circle of a specific garden, I now take 10 minutes more. Remember, this is probably the first sign of diastolic dysfunction in that person. It's a very small thing, does not cost any money, but you can easily determine that the patient is probably developing left ventricular dysfunction. He is a candidate to go for further assessment. So how do we go for assessment? Which patient should undergo? At what age and how? Who should undergo? All patients having diabetes between the age of 20 and 74. After 75, not a single guideline suggests you to assess for cardiovascular assessment once the patient crosses 75, a patient of diabetes. But between the 20 and 74, a patient of diabetes coming to you at 25 years of age, he requires cardiovascular assessment. When I say cardiovascular assessment, it does not mean fancy investigation in the form of 2D echo or coronary calcium score every time. But he requires cardiovascular assessment. As early as possible once the diabetes has been diagnosed, even before you start the treatment for diabetes. How can you do it? First, identify traditional risk factors, lipids, blood pressure, smoking, obesity, after taking family history. Simplest way for cardiovascular assessment. Would not take much. Blood pressure is not going to cost. Lipids are quite cheaper investigation in India. Smoking history, obesity, simple. You have to measure BMI. Calculate the risk and stratify with risk calculators into high, intermediate and low risk. Low risk, intermediate and high risk. What to do? If the patient falls into low risk, no further assessment is required for 4 to 6 years. He can go ahead with lifestyle changes, monitoring as far as cardiovascular assessment is concerned. Now you can go ahead with his management of diabetes. If he falls into intermediate risk group, he should undergo some important investigation like cardiovascular, coronary artery calcium score. But if he falls into high risk, first of all, he requires to control his risk factors very, very optimally. He is a patient of diabetes, falling into high risk. He requires absolute control of his LDL. He requires absolute control of his blood pressure. He requires absolute control of his weight. Just reducing HbA1c would be of futile effort in this case. Writing 5 drugs to reduce HbA1c and forgetting statin and forgetting his blood pressure, forgetting his weight, you are not helping him out. Variable age CVD risk calculators. There are 6 important risk CVD calculators, but which one is important? Look, what do they ask for? The age CVD calculator in your mobile phone, smartphone, all of these risk calculators are there in your smartphone. And what do they ask for? Age, sex, lipids, history of smoking and blood pressure. That's all. None of the calculators ask anything more than this. You can put these figures and you'll get the risk. This is the age CVD, ACA, AHA scores. So let's go. Why every calculator asks for lipids? The reason is lipids are easier to measure. Number 2, among all this population, attributable risk for MI is highest with dyslipidemia. And remember, the treatment for lipids is easier to monitor, safer than your anti-diabetic treatment and cheaper than the anti-diabetic treatment. So that is one reason. There are certain limitations of CVD risk assessment, but let's go to the which risk calculator for India. As you can see here, there are 6 risk calculators which were compared by multiple trials. And as far as the India is concerned, you can see the highest number of patients having high risk were attainable only by the FRS CVD risk calculator, which is there in your mobile. When you look at more than 40% cardiovascular risk, you can see the first column, FRS CVD, 172 patients, which was 15% as compared to the rest of calculators. So, what is the ultimate outcome? The ultimate outcome says that FRS Global CVD Risk Assessment Model could stratify more number of patients at high risk. QRISK, JBS3 and FRS CHD work intermediately, and ACA, AHA, CVD risk calculator is not useful for Indian patients. So which risk calculator to be selected? The best one would be FRS CVD for Indians, the NICE guideline for statins. So you have used risk calculators. Now comes 3 things. Low risk, manage his diabetes. High risk, manage all his risk factors and manage diabetes. But what about intermediate risk group? This is one group where there are problems. How do you get these groups? Simply by putting 5 informations in the risk calculators. So you require certain screening tests for those who are having intermediate risk. What are those tests? 7 tests. Not all are required for everybody. Resting ECG for patients having diabetes if age more than 40, diabetes more than 10 years duration or other risk factors. You should go for his ECG every 2 yearly, not in every visit. Echocardiography only if you feel that his walking test is abnormal. 6-minute walk test is abnormal. That is when echocardiography is suggested in intermediate test group. And exercise test, remember exercise ECG is not much useful in females. There are lots of false positives. So before sending every patient for exercise ECG, give a thought which patient to select. The best investigation, and fortunately for India, the cheap investigation. Why I am saying cheap? Because in US, the same investigation costs $300 to $1,200 at present. But in India, it costs 1,200 to 2,000 rupees. So a patient having intermediate risk factor may undergo coronary calcium scoring, and that would be very useful. It's a non-invasive test. I'm not going into the detail, but what information does it give? The information that it gives is if coronary risk factor, coronary artery calcium score is 0. If it is 0, the chances of that patient developing cardiovascular disease in next 4 years is 0.6%. That is 4 to 6 out of 1000 such patients having coronary artery calcium score 0 would develop a CV disease. You can understand with the help of 2000 rupees test, non-invasive test. You don't require to be fasting, no injectables. Takes about 3 minutes. And there is very minimal exposure. Somebody may say exposure, the exposure is very minimal. Just little bit more than a chest x-ray, but much less than a mammography. I'll finish within 5 minutes. So, if there is a coronary artery calcium score, if it is 0, that patient does not require any cardiovascular assessment in future, and you can safely take that patient off statin if he does not have dyslipidemia. So this is what is the importance of 0. If the score is more than 400, that patient should be subjected to more invasive or more aggressive cardiovascular risk assessment. CIMT and ABI, I am not going into the details. Early intervention plays long-term dividends. Remember, there are now lots of trials which says that statin therapy in young adults is more important than anti-diabetic therapy. If you have not given statin to a patient, you may be in trouble. That patient may be in trouble. And look how significant is the importance of coronary artery calcium score. A patient having coronary artery calcium score 0, but is having uncontrolled diabetes, is still less likely to develop cardiovascular disease as compared to a patient of diabetes or non-diabetic patient who is having uncontrolled hypertension. So 0 is very significant. These are different strategies that compete with absolute risk approach. So once again, are we doing enough? My answer is no. Why we are not doing enough? Look at this, few of the data from our own hospital. 500 referred patients at our hospital, diabetic patients. No CV risk assessment was done before they referred to us in 435 patients. And as I told you, CV risk assessment, by that I do not mean hi-fi investigation. A simple lipid, a simple blood pressure measurement and a simple history. Family history of premature CVD was missed in 27 out of those 500 patients. And it is very important if the patient's family member has, as I told you, has a history of premature CVD. Resting ECG was not available in 150 plus patients, and 24 out of these 150 showed ischemia on resting ECG. We are so much centered on HbA1c. We are so much centered on fasting glucose. We are so much centered on postprandial that the easier things are completely missed. 48 patients were on SGLT2 inhibitors, and unfortunately, all those 48 patients had no established ASCVD and they did not have risk factors. And there is no indication in any guideline of using SGLT2 inhibitors if there is no renal involvement and if there is no established ASCVD without risk factors. Lipids were not done even once in 125 patients. Dr. Bansi just now told you 2 sessions back, that you must write down the baseline lipid whenever you start treating a patient having diabetes. That is what we wanted to tell. Baseline lipid is much more important, even much more important than your baseline HbA1c. Statins were not given to 55% of patients who qualify for the same, and amongst those given, once again what Bansi told you just now, most of them were on R5 and A10. What is R5? Rosuvastatin 5 mg and atorvastatin 10 mg, which practically have no role. So this shows we are really not assessing or not treating cardiovascular disease in a patient having diabetes. So how do we do? Before initiating treatment for diabetes, cardiovascular risk assessment and stratification is highly desirable unless there are compelling indication to start anti-hyperglycemic treatment. A patient coming with 12 HbA1c or patient coming with random sugar more than 300, yes, you require to start anti-diabetic treatment. Otherwise, start metformin and assess his cardiovascular risk and then decide which drug to be used. Beginning with family history of premature CVD to coronary artery calcium score, we are still lagging much behind in pursuing the evidence per CV risk assessment. So, why do we fail? Because we ourselves do not know, we have no motivation, and we do not have time. I will skip these three cases because of lack of time. I want to finish in 1 minute. So, concluding, diabetes is no more a risk equivalent. Nearly 1/3 of patients having diabetes have low risk. So one head does not fit all, and risk stratification is very, very important even before anti-diabetic treatment is started. And this is one group where you should be very cautious. Coronary artery calcium score is the only non-invasive technique that detects early coronary atherosclerosis other than CT angio, effectively redefines the risk and can better discern which patient warrants statin therapy. Although CAD is common, often silent and associated with worse clinical outcomes, every patient does not require to be investigated for the silent ischemia. So, shift from a glucose-centric approach to an aggressive multifactorial strategy to identify and target patient CV risk factors. Screening is a double-edged sword. One should be careful while selecting the patient for screening. Optimize and individualize screening test. Your risk for heart disease is as much as your arteries age. A man is as much old as his arteries are. A man having diabetes is going to die of his arteries, not of his sugar. Thank you very much. Thanks all, and thank you RSSA Gujarat chapter.
For the next most prestigious Dr. O.P. Gupta oration, I will request Dr. Chintan to join me. First, I will invite Dr. Bansi to say a few words about Dr. O.P. Gupta, sir.
But before we invite, we should invite the orator, and it's really a prestigious oration for RSSDI Gujarat chapter. But at the same time, it is also for RSSDI nationally, as Dr. O.P. Gupta was founder president of RSSDI. So I would like to invite, with the permission of chair, our orator, Dr. Sunil Gupta, and then I will talk about Dr. O.P. Gupta. So Dr. O.P. Gupta was a very, very eminent diabetologist, very, very eminent person of RCT Ahmedabad, from Gujarat and from India. In 1972, when RSSDI was formed, he was founder president of RSSDI. He was colleague of Dr. MMS Ahuja. They both have done their MD medicine together, their MRCP together. Dr. MMS Ahuja was at All India Institute of Medical Science at Delhi. Both of them were from Agra. Dr. O.P. Gupta has done his MBBS from Agra, and then he was at Ahmedabad as a professor of medicine at a very young age. After passing his MD, he was here posted as a, at that point of time, honorary professorship was the system, but he was here as a full time, as a assistant professor, then associate professor, and at the age of 28 only, he was professor of medicine. We all know that Professor M. Vishwanathan had started first diabetes clinic in South India, and he is the father of diabetology. But just to inform everyone here that he started in civil hospital before 1972. So before even 50 years, in 1970, a diabetes clinic at BJ Medical College Civil Hospital. A diabetes clinic also was funded by World Health Organization. We have here a research lab which was funded by World Health Organization, and the lab was inside the medical college in BJ Medical College. Dr. O.P. Gupta, not only he started that diabetes clinic, but he had also done one of the earliest epidemiological study, and I am sure we all count his study also in 1971, the rural incidence and urban incidence which he has done from western part of India. At that point of time, it was less than 1% in rural area in an adult, and around 1.2% was an incidence of a diabetes in an adult population in western part of India, which he has done in Gujarat. So before 50 years, you can see that what are the difficulties which he must have faced, because he had gone from one village to other village. It was village and town and district, and then he has taken Rajasthan, Gujarat, Maharashtra, MP, and a western part of India, and that was quoted. One more thing which I remember from Dr. O.P. Gupta, he had attended from first IDF meeting, which was started in 1956. At that time, he was a student, and he attended all the meeting of International Diabetic Federation. Last meeting which he could not do at Abu Dhabi because he was not well and he had a fracture. Otherwise, he was always there in International Diabetic Federation meeting. He was also there till he survived. Only last 3 years he was not in position to come in RSSDI meeting, and he was also the patron of RSSDI. Last year we lost him. Unluckily, before he died, he lost his son also in an accident. Dr. O.P. Gupta was a great teacher, not only a great teacher, a great guru, academician, teaching diabetes. And in our any meeting of Ahmedabad, if any physician meeting, not only he will be there right in the first seat. In all RSSDI meeting, you must have seen him sitting at the first row. And not only after each talk, he will come and he will ask one question also. He will make one comment also. And that type of enthusiasm Dr. O.P. Gupta was having. He was great diabetologist, but at the same time, in his internal medicine, also he was great teacher. With these words, I once again remember Dr. O.P. Gupta fondly. And Dr. Urmanduro, would you like to talk about 1 minute for more for Dr. O.P. Gupta? And then we would like to felicitate our orator, Dr. Sunil Gupta. Yes, sir.
Sorry, Dr. Gupta, we are running late, but just a minute, and not for Dr. O.P. Gupta. For Dr. Bansi. The reason is we had a diamond with us, but we never used to evaluate him or to understand him. Most of the time we say good words about the person after losing him. For last 15 years, Dr. Bansi was always with Dr. O.P. Gupta, and he brought out the best things of Dr. O.P. Gupta in front of whole India, not only against Ahmedabad. Most of us knew Dr. Gupta, but never knew his qualities, his work, his efforts. So I am so happy that somebody, when he was alive, his all efforts were brought to the society, and that's what Dr. Bansi is. Number two, most of the programs attended by Dr. O.P. Gupta, including initial few RSSDI meetings, he never used to get funded by anybody.
I think I will first read citation of Dr. Sunil Gupta for delivering this prestigious Dr. O.P. Gupta oration. Dr. Sunil Gupta is currently National President of Diabetes in Pregnancy Study Group in India and National Treasurer of RSSDI also. He has got 14 national orations, 4 presidential orations, 6 international fellowships and 6 national fellowships to his credit. He is the only diabetologist of the country honored with the Outstanding Young Person of the Award in USA, and he has received many awards, and he is also being listed in Guinness Book of World Records and Limca Book of World Records. He has done a lot of research in the field of diabetes in pregnancy, and I think we wish him success in his research as well as academic work.
Thank you. Sunil, all you.
And slide changer. Slide changer is working.
Dr. Sunil Gupta sir will be sharing his journey of diabetes in pregnancy over last 3 decades.
फिर कॉल की जरूरत नहीं. You don't. Okay. Thank you very much for all good words. Dr. Bansi Bhai, Dr. Pratap, Dr. Vasant Kumar, our national president. Is it working? Yeah, it's working. It's working. It's working. Yeah, good. It's always pleasure to be here in Gujarat, and since almost 2.5 decades or so, Bansi is like my younger brother, and we extend a very warm and a relationship between. The bonding is very, very strong, and possibly because of him, this I have become more close to Gujarat here now, next to Maharashtra. My talk is dedicated to none other than Dr. O.P. Gupta. I still remember that many of the times, usually he used to go with Bansi in last few years. But when Bansi and me used to be most of them together in most national or international meetings, when he used not to be there in the hall, then he used to call me, Sunil, come, and then he used to come with me because he need to have a support of someone. So many of times I have put him to the chair to going to chair the session or something, and sometimes to the car. Wonderful human being, always has supported, and every time used to remember with the first name. That's what I remember, and very fond teacher and good person. Thank you very much. I am honored to speak on his memory today. Thank you everyone, Dr. Urman and Sandeep Desai also. No conflict of interest for this talk. I'll be very brief, and I'll try to be as quick as possible. I'll have some talk, some discussion on introduction, screening, and the journey. I'll talk more on those lines. So this actually started with Professor Sam G.P. Moses, who one fine day I asked him, Sir, I am Dr. Sunil Gupta. I was very young those days, hardly 4 or 5 years of practice in 1990, 95, 96 or so. And that time I asked him, Sir, I wanted to go little beyond this now, diabetology, and he made me introduced to Dr. Professor Sheshaiah. So Professor Sheshaiah, then he said he is doing good work in pregnancy diabetes. So Professor Sheshaiah, I invited him in 1999, so almost 23 years from now, and he came from Chennai. Those days flights were not there too much. There's only one flight of Air India which used to fly in Delhi and Mumbai, no other flights, and he came by train, almost 24 hours journey those days, and then that was 1999. And Dr. Sheshaiah actually introduced me to diabetology, and from those days then, of course, there are many people, Dr. Asgaonkar, and this is 2008, that after 99 we had another meeting of DIPSI. Possibly DIPSI came out for the first time out of Chennai in 2008, that was to Nagpur. And then of course the things then started running well, and then we had Dr. Many other people, Dr. Samar Banerjee, and this is Bansi. This is Bansi in 2008. Okay, so he means Bansi also used to take a lot of interest in pregnancy diabetes those days. So just
and of course Dr. Jitendra Singh that time was joint secretary of DIPSI along with me. The two joint secretaries in DIPSI, and that was he as a speaker, not as a minister. So let us come to the clinical side of it. And hyperglycemic pregnancy, almost we say 16.7%. That means every sixth woman across coming to any ANC clinic is likely to have pregnancy diabetes globally. But unfortunately, when you talk about Southeast Asia, this 2021 data says that almost every fourth woman coming into the ANC clinic in Southeast Asia may be having pregnancy diabetes, and that figure is very, very strong, 25.9, almost 26%. As the age advances, the risk of hyperglycemia in pregnancy, maybe gestational diabetes, and few of the pre-gestational diabetes increases. Now, this is another tsunami of gestational diabetes, that you have newer cases now coming. The age of marriage has gone up, and the age of childbearing is going up, and the age of diabetes is coming down. So now you are getting many young women between 25 and 35 developing diabetes and coming to it pre-gestational diabetes. Most of the clinicians here practicing since 20, 30, 40 years, we know that pre-gestational diabetes used to be very, very rare. Usually type 1 diabetes used to come with pre-gestational diabetes to you, but not type 2. But we are going to face all this, and we have to be actually get trained on these lines. This is a new classification of hyperglycemia in pregnancy, where you have DIP, diabetes in pregnancy, where you have pre-gestational diabetes, pre-existing type 1 or type 2 diabetes becoming pregnant, or few of them clinically coming to you for the first time, but they are though they are diagnosed for the first time hyperglycemia, but actually it is pre-existing diabetes. They are being classified as DIP, because DIP treatment will be starting with insulin and insulin alone, while the gestational diabetes, of course, you have many other choices. So GDM is now different, and DIP is either type 1, type 2 becoming pregnant, or someone clinically diagnosed to have hyperglycemic pregnancy, maybe in the first trimester, high HbA1c, high fasting postprandial, but have never tested blood glucose earlier. They are also DIP. So who should be screened, when should be screened, screening test, because this is oration, so I'll be very quick and more into the work which we have done. So we have now 2014 and 2018 Government of India guidelines, which were proposed by DIPSI, and everyone of us have to follow that. And they said that we should have single step test, 75 gram glucose given to the person, to the women, irrespective of the time of the meal, whether they are fasting or non-fasting. Give it 75 gram glucose, ask the woman to sit in her clinic, take 2-hour test and get the blood glucose done. If it is more than 140, diagnose is with gestational diabetes. This has been proposed by DIPSI and has been accepted by Government of India, again revised in 2018 with the recent guidelines, also says the same thing. And most of the even IDF now in 2021 have come out with DIPSI as an additional diagnostic criteria available globally. So DIPSI has been added by even IDF in their atlas. Now there is one more category between 120 to 140. We say that 2-hour blood glucose should be targeted to be less than 120, but someone diagnosed to have 130. According to definition, 140 plus is GDM, 140 minus non-GDM. But what is about between 120 to 140? And there was a proposal from various organizations. This is a paper from 2015 where diabetes care paper says mild GDM and long-term childbirth health. So what they have started with now thinking on between 120 to 140, not necessarily GDM, might be a case of mild gestational diabetes. They used to call it as isolated abnormality of blood glucose, or maybe they used to call it a GGI, gestational glucose intolerance, various names given to this. And this again says has been associated with neonatal benefit. Some benefit has been shown here. And the paper from Canadian guidelines, this Canadian journal, and they also say are there any benefits of GDM in treating lower levels of hyperglycemia than the standard recommendations? And they also have come out with this study providing insight that these complication rates and the benefit are definitely there even in patients who are mild GDM. So I feel the next step of ours will be working on these lines. But let me share with you, because I don't know why Bansi has selected for me for this oration, but possibly we are working in this field almost since 1995-96 onwards till 2017 we had paper on these lines of mild gestational diabetes, and we are presented across the globe. Maybe it is Sydney or the Paris or IDF Paris or China. Most of the meetings of almost many RSSDIs, we have presented this data, and this is one of the paper which has clearly mentioned here that if we follow the standard criteria of gestational diabetes, almost 50% of these pregnancies which have been compared with the NASH, there's comparison between GDM and IGGT, and they have shown that we would have missed these 50% of the cases, and the fetal loss in the previous pregnancy, which was around 34%, has come down to almost 1.5% by treating these women who had past history of fetal loss and the blood glucose between 120 to 140, and almost 50% of them, they required additional dose of insulin to achieve good glycemic control, because metformin we never used to give earlier, and we have given insulin, though the requirement was on an average less than 10 units in those days in these pregnancies. So this is another way, another important message to you. What are the glycemic targets? Now, St. Vincent Declaration in 1989 says that to try to achieve blood glucose control as that of the non-diabetic women of the same age and same week. We should try to achieve blood glucose control as that of the non-diabetic pregnancy, and this is a CGM study which says fasting should be around 71, 1 hour should be less than 110, 2 hours should be less than 99, and 24 hours should be around 88. That means we still target fasting as 90 and 2 hours as 120. Possibly we still need to be more closer to these figures where mean blood glucose is around 100 and 2 hours is around 110 if you even add standard deviation. But the target at this moment of time, you as a clinician to remember, is try to achieve fasting at less than 90 and 2 hours less than 120. The new metrics, which is CGM metrics, that continuous glucose monitoring, TIR in pre-gestational type 1 diabetes. I repeat, pre-gestational type 1 diabetes time in range should be more than 70% between 63 to 140. Time below range less than 63 should be less than 4%. Time below range less than 54 should be less than 1%, and time above range of more than 140% should be more than 25%. But when we talk about gestational diabetes in this panel on my right, GDM or type 2 pre-gestational, your time in range should be more than 80%. So more than 80% of time, women should be between 63 to 140. That is what will be giving you the best neonatal outcome. Emphasis on home monitoring of blood glucose to be given. How to achieve these targets? Medical nutrition therapy, exercise, oral drugs, insulin. Oral drugs which are supposed to be the best one, which should not ideally cross the placenta, it should not cause neonatal hypoglycemia, it should not cause neonatal hyperinsulinemia, and it should not be teratogenic to the baby. They are the best drug, oral drug can be given. And which are these drugs which have been tried and approved by global authorities? Metformin, glibenclamide and acarbose. So 3 drugs have been approved, but all of them they cross the placenta. Though they have been found to be not having any teratogenic effect as far as most of the studies globally are available. Fortunately or unfortunately, India has approved only metformin for its use in pregnancy and no approval for glibenclamide or acarbose. If you go to US or if you go to South Africa, they use glibenclamide more often than even metformin. What are the guidelines now? Guidelines says that lifestyle modification will possibly address 70 to 80% of the women to achieve 90 and 120. But insulin is the preferred drug of choice. But metformin and glyburide should not be used as a first line agent. Both cross the placenta, and other oral drugs that and the non-insulin injectable glucose lowering therapy lack the long-term safety data. So we don't have long-term safety data available for glibenclamide or acarbose. But metformin we have data up to 9 years of these offspring of diabetic mother. Metformin when used to treat polycystic ovarian disease for inducing ovulation should be discontinued by the end of the first trimester with the class A evidence. Telemedicine should be used. Now what does Government of India guidelines says? metformin or insulin is acceptable medical nutrition acceptable therapy, should be used after medical nutrition therapy failed to achieve your control. Insulin is the first drug of choice. Metformin can be considered after 20 weeks of gestation. So now polycystic ovarian disease, 12 weeks you have to withdraw. 12 to 20 weeks is a gray zone. What to give, what not to give. Especially someone detected to have hyperglycemia in pregnancy in 14 weeks or 16 weeks, whether to give metformin or not. Still guideline says insulin is a drug of choice in this period. After 20 weeks someone developed GDM, metformin can be given if not contraindicated. Very recently, February 2022, metformin has been approved by the European drug authorities to be used in pregnancy from the day 1 of conception till birth. So very clearly mentioned this, that metformin was approved as a first oral anti-diabetic medication to be used from conception to birth, and this has been of course with whatever evidences they had. So European body as the first body in the world which has officially allowed metformin throughout the pregnancy. What about insulin? We had MIDI trial which was done in type 2 diabetes. They have also shown safety data. What about insulin? Around 15 to 20% women need insulin. Rest of them will be managed on diet therapy alone. But there are some absolute indications for insulin. Those who have high HbA1c, have ketonuria, IUGR, some associated renal or hepatic dysfunction, macrosomia, hydramnias, or some steroid therapy. Insulin remains the drug of choice. Metformin in any case of placental insufficiency, preeclampsia, metformin is contraindicated and should not be used. What are the insulins to be used? Regular aspart lispro can be given safely. Detamir long-acting analog can be given safely. Other regular insulin NPH can be given safely. Premixed is can be given safely. About glargine, it was earlier class C drug till 2015. FDA USA has removed that mandate now. Now you don't have ABC classes of drugs in pregnancy. Now they say for glargine, if clinician feels someone type 1 or type 2 already on glargine, by withdrawing glargine, if you feel that it may deteriorate the glycemic control, then you may continue glargine in pregnancy. So it's on clinician's discretion. About then there are newer faster acting aspart which controls postprandial better than this is the ultra fast acting insulin which controls postprandial peak better than the even rapid acting analog and other insulins. Insulin doses. Now this is data from Europe and the South African data also has been put here. During pregnancy, insulin requirement tend to fall during the first trimester and rise during the second and the third trimester. There is weekly increase in the insulin dose requirement from 24 to 30 week. From 31 to 39 weeks, the level of glycemic control usually may remain constant. Injection requirement from around in type 2 diabetes, it is 0.8 unit per kg body weight for non-obese, 0.9 unit per kg body weight in obese, usually between 0.7 to 2 unit per kg body weight. This is data from Europe. Why I am showing you this data? Please remember this figure 0.8 here in type 2 diabetes, around 40 to 90 units. This is data from Western world. Now let us see what our data says. And the insulin requirement, as I told you, in the first few weeks may go down and then it may go up. This is our data which was almost 20 years from now, which was published as a small paper in Delhi in NNDU, and what we have found is those who are IGGT require around 0.1 unit per 0.15 unit per kg body weight at the time of delivery, GDM around 0.4 unit, and pre-gestational diabetes type 2 0.8 unit per kg body weight of pre-pregnancy weight. Now this we did it 20 years back, and then after 15 years or so we have come out with another paper of type 2 diabetes, possibly the only one of its kind in this part of the world, where pre-gestational type 2 diabetes we have shown the insulin requirement, and what we have seen is first trimester was around 0.5 unit, third trimester as the insulin requirement went up, it went up to 0.8 unit per kg body weight, which matches with the Western population which was published by some other authors. So this again is a thing that we should need to remember, that it goes little up, almost 1.5 time requirement will go up till delivery of the pre-gestational pre-pregnancy body weight. Now meal insulin requirement was maximum at the pre-dinner time versus the pre-breakfast time, which again gives another information to all of us that somehow our population in central India have post-breakfast hyperglycemia is less versus post-dinner hyperglycemia. And being Kavita as our dietitian there, we had thorough dietary recall there with the team of dietitian, and we found the supper calorie was highest, the dinner calorie was highest versus breakfast and lunch. So our population doesn't take as high lunch as Vijay Viswanathan's population or Tamil Nadu population have, because they have post breakfast highest versus the dinner, and their breakfast is like dosa and idli and all, which possibly this part of the country is not doing it. And that is another message to that means that it has to be individualized, not necessarily that it will follow each and every woman, but we have to be careful that you should be monitoring post breakfast, post lunch as well as post dinner, and see to it that your dinner dose is also appropriate to achieve your post dinner blood glucose to be less than 120. There is another data from 900 GDM pregnancies, and which has again shown breakfast, lunch, dinner. If you see the dinner size is almost every time is highest the dose requirement. So insulin requirement, the final message for those who are gestational glucose intolerance or GGI, you should try to keep it between around 1.1 unit at the time of diagnosis per kg body weight, which may go up to at the time of delivery go up to 1.15, 0.25 in GDM, 0.4 it goes up, and gestational diabetes, pre-gestational type 2, 0.5 to 0.8. So this is another message as a clinician to all of us. Then we have come out with one of the data in insulin in paper coming from US in diabetes care. A twin pregnancy type 1 are requiring double the dose at the time of pregnancy versus the singleton pregnancy. So I discussed with few of the some good academician. See, have you observed this? I said I have not observed this, that twin pregnancy are requiring double the dose of singleton pregnancy of the same age. And then we have tried to evaluate our own data. We have evaluated the twin pregnancy of two centers, Pune center with Dr. Sanjay Gupta and Nagpur center, around 44 pregnancies or so, and we have come out with the conclusion that GDM women with twin or singleton gestation differed insignificantly in their treatment strategies and insulin doses. Insulin requirement need not be proportional to the number of fetuses. So there is a very strong message to you in Indian circumstances. So insulin dose should be individualized on the basis of home monitoring of blood glucose. Few of the patients may require insulin pump. Unfortunately, insulin pump is very costly, and every patient may not be may not afford for it. So we do take insulin pump on hire, maybe for 3 months, 4 months, 6 months. GDM women will require for hardly 3 to 4 months. If it is pre-gestation, maybe for the whole pregnancy. And then we can go back, or some of them they may get converted, they may purchase it, but we can use this, and we have used it in few of the women. We used to call them as pump babies rather than so this is one patient who's type 1 diabetes, brittle diabetes, having proteinuria, some moderate NPDR, though it was not PDR, and she was on 1, 2, 3, 4, 5, 6 or 7 pricks of insulin per day. And this minor adjustment of blood glucose was going haywires, and she was put on insulin pump, and she delivered a baby at around 31 weeks because of the hypertension, 1.75 underweight baby, but now the baby is all fine, mother is also fine. Now it's almost 6-7 years now. There's another patient, type 2 diabetes, required around 85 units of insulin with again 5 pricks or 6 pricks per day. Again was shifted to insulin. Type 2 patient, 8.5 HbA1c at the time of this, but she was put on pump, and she required almost 134 units of insulin per day along with metformin, and she delivered normal baby. Now insulin is off, she's just on metformin, again almost 7-8 years from now. Intrapartum management, we should try to achieve blood glucose between 70 to 120. Any high blood glucose during intrapartum phase may precipitate neonatal hypoglycemia at the time of birth, so we should be cautious. What about breastfeeding? Insulin is the drug of choice in lactation. Longer duration of breastfeeding will be higher is the chances that mother will not develop diabetes soon, and as well as the baby will have less chances to develop metabolic syndrome in future. So breastfeeding should be encouraged by everyone. 15% of GDM women will remain glucose intolerant after delivery. 85% will become normal. 30 to 70% of the GDM are likely to become GDM again in the subsequent pregnancies, and 10 to 15% in next 5 years are going to develop type 2 diabetes. This is one of the focused group where we should be planning primary prevention strategies. I strongly appeal to RSSDI also here from this platform, because there is RSSDI banner, that we should be focusing this particular group, selecting them and trying to target them for primary prevention. And then we have got this paper which was again those women who had past history of GDM, and we found almost 51%. Very recently we again have presented, have sent one paper for publication, and that paper again has shown almost 50% of the women who come to us as type 2 diabetes, maybe they had GDM 10 years back, 5 years back, we have got their retrospective data collected, and we found 51% of them, they developed it within 1 year, which is not mentioned in international literature. So within 1 year they developed type 2 diabetes, and rest of the 50% after 1 year. So we have a classification. We have found that some of the risk factors which were, I'm sorry for the poor, you can't visualize it well, but then those who have developed weight gain, those who have required insulin, those fasting blood glucose at the time of diagnosis of GDM was higher, they were more prone to have type 2 diabetes early versus, so early development of type 2 diabetes versus late development of type 2 diabetes amongst those women who have come to us with past history of GDM. Lactation, all drugs will probably be excreted in the breast milk. Insulin remains the drug of choice. Avoid the combination therapy, and this happens very common, that clinician doesn't realize patient comes to in PNC phase and you switch over to glimepiride metformin combination blindly. We should not do that. There is no safety data available for glimepiride in lactation, and we should avoid it. Insulin remains a drug of choice. Those who don't want to go for insulin, take it in writing, and then you can give metformin, and glipizide may be better choice. If the glycemic control can be maximized to the extent that fetus no longer recognizes that the mother has diabetes, then the treatment of mother during pregnancy may become the first step towards prevention of diabetes in these offspring of diabetic mother. So this is primordial prevention. We talk about primary prevention, we should be talking now on primordial prevention, trying to target the intrauterine environment to achieve better generations and disease-free generations in future. And that is why we have 10th of March as National JDM Awareness Day, which is a birthday of Professor Shaya, and like you have 14 November as a World Diabetes Day, you have, and India is the only country in the world which has come out with National GDM Day. There is no country in the world they have taken over this as DIPSI president this year. In last 3-4 months, we have done a lot of public awareness activity which Dr. Vasant Kumar was talking about, and Bansi also favors this. So this is called as Diabetes Prega Talk. And let me also accept and endorse one important fact here. I got conceptualized this particular theme by none other than Dr. Bansi, who started Diabetes Bites so Bansi, you may not be aware, but a lot of people take up good things from you, and we try doing it. So this was again public awareness program. We started every weekly program on Wednesday from 6 to 7, and we started in different, this was the first time in the country that we did, national body did program in national languages, regional languages, and from their own faculty, regional faculties. So this was in Punjabi, the first one, and then we had in Bengali, then we had in Gujarati, where Bansiba is also senior and Rutul is senior. And we involve a gynecologist, a physician and a nutritionist and one moderator. Then we had in Tamil we had 2 such programs. Then we had in Telugu, and then we had Hindi, Marathi, Shashank Joshi and all. Then we had in Assami. We also had in Kannada. Then we had in Telugu, Malayalam, from where Jyoti Dev was the faculty. And then we had even in Sindhi. So we had 22 languages in the Indian Constitution. We had in 21 program. In Bihari we had Awadhi. We had in English. Then we also in Konkani language from Goa, Kashmiri and Dogri for Kashmiri people, and last was Marwadi language from Rajasthan. And we are the first phase of this cycle of 20 such programs is already over, and maybe after our Hello Diabetes Academia, which is planned on 24th, 25th, 26th of June, so very next week, we'll be again starting the second cycle of this Prega Talk for public awareness program. We have done every 20 CMEs for different states for in last 4 months just to empower OBGYs of societies for screening programs for by involving or by educating empowering them with the knowledge so that they can adopt Government of India guidelines, and every woman should be tested for the gestational diabetes. We also have got collaboration done with CEPHOG, which is a South Asian Federation of Obstetric and Gynec, and we had Sri Lanka, Nepal, Bangladesh, Pakistan, Myanmar, and Colombia. So we have 5-6 such places where such countries were involved, and we have tried to implement DIPSI guidelines for them. So GTM is a window of opportunity. All of us have to join hands together to try to focus on this particular aspect, which is less focused, and maybe sometimes because of the busy schedule, or maybe the OBGY, the patient is going to OBGY, doesn't come to you too often. But even the postnatal follow-up is another challenge which we need to follow. This is a new slogan by DIPSI, "Ek जांच से बचे दो जान." So we have to save the mother as well as the child from developing diabetes. Before I conclude, wishing you with love and regards a corona-free year. We never celebrate any birthday by cutting the cake or any anniversary in last 30 years. We try cutting the fruit for celebrating any occasion. I appeal all of you to stop cutting the cake, and hydrogenated fat was spoken by our president. Sir, this is the concept we are running for almost 25 years, and we expect every one of you to please follow this. Thank you very much for your patience listening. Thank you.
Sir, really mammoth work done by you, and the very nice and lucid presentation has encouraged us all. Thank you very much. And we are lucky to have a person like you, doctors like you in our country, so that our females and ladies and whole society is benefited by your work, and we are also learning a lot from you. Thank you, sir.
Thank you.
My one question is this a lot of bodies are talking about metformin, and you showed the current European acceptance also. However, yet when it comes to lactation, we are still talking about insulin. So given a situation where you manage to use metformin for a patient with GDM, maybe not from conception to birth, but at least the early post 20 weeks, if such a patient, if it persists, are we still going to tell them insulin when we never use insulin in pregnancy?
Insulin is a drug of choice. Insulin is a drug of choice for pregnancy as well as during lactation. There is always a second drug of choice. So if you choose going for metformin, I don't mind continuing metformin, because metformin is also appreciably being excreted in the breast milk. That's a problem. And if something goes wrong in future, we should not be in trouble, and that is why we should be also legally protected while using metformin in the first trimester, while using not using insulin. So write down that patient doesn't want to go insulin. See, it's not the question of love with metformin. It's the question of giving best safety. There are always best things available. Insulin is best. There is always second best available. If you don't want to give, you can write down. Patient doesn't want to take insulin in lactation period. They want to continue on metformin, will continue. And many of women are being directly put on metformin. But I'll give an example. Metformin is a good thing. I appreciate the question. One lady came to Maika, was in Nagpur, and she was from Chhattisgarh, possibly Raipur or Bilaspur somewhere, and she went back after delivery. And the enthusiastic physician, without asking that she is lactating woman, she has put on glimepiride plus metformin combination. She came back for a review after 1 month or 2 months or two, and she said, my baby sometimes becomes very sluggish, sometimes become very active, sometimes it cries too much. And I said, have you got your baby here? She said, yes. Her blood sugar of baby was 28 in my clinic. And said, what are you taking? I wrote you insulin at the time of discharge. She said, when there, my old physician was there. He shifted me to glimepiride metformin combination. So such thing will happen. And if this baby had something gone wrong, it was a difficult thing. That is why insulin should be written as a first drug of choice. And of course, we can have always, metformin may not have all hypoglycemia, but if you give, better.
If you not use insulin in pregnancy, it's very difficult to tell post delivery that we didn't use it in pregnancy.
Use metformin, write down na. Even in pregnancy, write down. Insulin is suggested. Patient don't want to take insulin. Metformin give.
But
Till government of India comes out. Even if you see the drug insert of metformin, glycomet, it mentions the pregnancy. It is contraindicated.
Just want to add one point.
Sir.
One is if it's a GDM baby, GDM mother, most of them don't require anything. Even if they are insulin, it can be stopped. No consequences. If it's a pregnancy diabetes anyway, it will be insulin.
Type 2, so the same German or European association which is approved will not
hoga.
comment on lactation for quite some time. So it remains a gray zone.
Yeah, it's a gray zone. I fully agree. It's a gray zone.
Otherwise, we have our light and sound show.
Thank you. So nice of you. Thank you. Thank you very much. Thank you.
Government of Gujarat, this Kevadia colony, this Ekta.
एक आमचा असा फोटो काढून घे कविता मॅडम.
I think before we finish,
ऐसे रखे सिर हाथ रखे.
please give memento.
Yes, yes.
Yes.
Thank you.
Thank you.
Thank you. Now moment to आगे दिए साहब.
ये यहाँ रखे जाने और पैकेट में लेके जाने. आ जाओ आ जाओ.
So we need 5 minutes more. Those who are national faculty, they may go in their room to get fresh up. And those who are RSJ Gujarat chapter member, we would like to have